is 4.5 hours. Why time is brain? Because as stroke strikes, every second about 32,000 neurons are lost. Every minute 1.9 million neurons are lost, and per hour 120 million neurons are lost. Per stroke they say about 1.2 billion neurons are lost. However, in a stroke, not as the stroke begins, everything is lost. There are three zones. As we could see, in a blue there's a ischemic area, in a green there's a penumbra, there's a oligemic area and normal area. It means that as the stroke progresses, as the time lapses, basically the area of damage increases. So our aim in the stroke is to early intervene so that we can minimize the area of damage and prevent the further catastrophe. The earlier you treat, greater is the benefit. Number needed to treat: whenever a patient within first 90 minutes, NNT is 4 to 5. However, as the time lapses between 90 minutes to 3 hours, NNT is 9, and number needed to treat is 14 when we thrombolize the patient between 3 to 4.5 hours. Stroke management: how does a patient move? Whenever a patient comes in the casualty, it is to be assessed by stroke physician, look for the vital sign, take a short medical history, and to assess the neurological assessment by NIHS scale. Emergency nurse has to monitor the vitals, O2 saturation, temperature, and immediately blood samples has to be drawn for routine tests like CBC, glucose, PT-INR. 2 IV access has to be done. Immediately the patient has to be informed to the radiology department and to get an immediate CT or MRI. Once the diagnosis of stroke, the infarct is confirmed, patient has to be shifted for thrombolysis. Diagnosis is mainly clinical based, and imaging help us to guide the management. Stroke severity is assessed by two ways: clinically on the basis of NIHS scale. I am very sure in Holy Spirit we are quite well acquainted with NIHS scale. It basically helps to directly quantify the extent of neurological damage and help us to differentiate the patient who can benefit from thrombolysis or mechanical intervention. The idea is lesser the NIHS score, more is the benefit. It is also an objective measure to assess the patient's clinical status and those patients to identify who are at a risk of ICH. Stroke severity is assessed radiologically by aspect score. It is a 10-point score in which it is a CT based, where 2 levels are taken of the CT, one at a ganglionic and supraganglionic level. 0 score indicates there is a diffuse ischemic damage, and score of 10 indicates it's a normal scan. So lesser the score, bad is the prognosis; higher the score, good is the prognosis. So IV thrombolysis, what are the inclusion criteria? In India, two medicines are recommended: alteplase and tenteplase. It has to be done within the first 4.5 hours of the onset of stroke. Diagnosis of stroke has to be clinically measurable, and age should be more than 18 years of age. However, before inclusion, we have to rule out all of the exclusion criteria like high BP more than 185 systolic and diastolic more than 110, hypoglycemia less than 50, arterial puncture need not to be done in less than 7 days, active internal bleeding, acute bleeding diathesis, use of heparin within 48 hours, or patients whose INR is more than 1.7. Use of DOACs, any history of trauma or stroke in the past 3 months, history of ICH in the past, rule out SH, neoplasms, any history of surgery, recent surgery, or the patients who has more than 1/3 area of infarct. These are the two agents which are recommended. Alteplase, the dosage is 0.9 mg per kg. It is given as a double bolus. In this, 10% we give as a IV fast over 10 seconds, and rest 90% is given over next 1 hour. Tenteplase has been recently approved for the thrombolysis. The dose of tenteplase is 0.25 mg per kg. It is given as a single bolus over 10 seconds. Maximum dose for alteplase is 90 mg and maximum dose for tenteplase is 20 mg. However, whenever you thrombolize, there are certain prognostication factors. Like positive predictors include when a patient has a stroke which is less in severity, younger age, few ischemic changes on CT, patient having a normal glucose, and the shorter door to needle time. The negative factors include the advanced age, the patient who have a cognitive impairment or cortical involvement, having a increased plasma glucose, higher DTN door to needle time, or those who have a higher severity of stroke, or if the patient does not show any improvement after 24 hours. Whenever thrombolysis has been initiated, the patient has to be monitored either in ICU or stroke unit. If a patient develops during the thrombolysis any headache, hypertension, nausea or vomiting, we have to immediately discontinue the infusion and shift the patient for CT scan. BP assessment has to be done every 15 minutes for the first 2 hours, then every 30 minutes for the next 6 hours, every hourly until 24 hours after the treatment. However, if a BP is more than systolic BP more than 180 or diastolic less than more than 105, antihypertensive medications has to be initiated to get the BP below this level and then initiate a thrombolysis. Delay nasogastric tubing, indwelling catheters or intraarterial punctures, and we have to obtain a repeat CT at 24 hours before starting any antiplatelet or anticoagulants. However, This 4.5 hours is not a very fixed window period because the newer trials has came like a wake-up trial which has offered a longer window period for opportunity in a stroke. This is mainly idea is to improve the hyperacute stroke management. Either this can be done by thrombolysis or a direct mechanical clot removal which can be done by thrombectomy. In thrombolysis, now the wake-up trial which has shown that whenever we have a patient in whose the time of the onset is not known, or when the patient wakes up with a stroke, we are not very sure about the time of onset. And this ideally we have a MRI-based criteria where we go for a MRI limited sequencing where we can do a diffusion weighted images and a flare sequencing. If there is a flare diffusion mismatch, meaning the lesion is seen in the diffusion but not in the flare, it suggests there is a hyperacute stroke, we can still proceed with the thrombolysis. Other method is by thrombectomy. So what is thrombectomy? It is a minimally invasive procedure in which mechanically the clot is removed, especially from the large vessels. Large vessel meaning one which starts from the common carotid till the M1 segment of the middle cerebral artery. It involves there's a navigation of the catheters through a large blood vessels either through radial artery or through femoral artery, and pull back the stent retriever and or aspirate the catheter to dislodge and remove the clot. What are the indications for the thrombectomy? So based on the time onset, thrombectomy is of proven value for patients who have less than 6 hours of duration. It can be performed even between 16 to 24 hours. It has found to be safe and efficacious. However, its efficacy more than 24 hours has not been established, and patient can be carefully selected by using either CT perfusion or MR diffusion weighted or perfusion weighted images. Imaging criteria for the patients who are less than 6 hours presentation, it includes aspect score between 6 to 10, MRI diffusion aspect between 5 to 10, the patients on CT angio showing moderate to good collaterals, and those who have a small core infarct volume between 50 to 70 ml, or those a marked penumbra to core mismatch on the perfusion imaging. For the patients who are presenting between 6 to 24 hours, the imaging criteria include CT perfusion or MR perfusion core less than 21 ml in age more than 80, NHS more than 10 with a core volume of less than 31 ml and age less than 80, NHS more than 20 with core of less than 51 and age less than 80, and CT perfusion core less than 70 ml with a penumbra core more than 1.8 ml. It is said that a large vessel occlusion, especially in a patients in a ICA, though it's an intra or extracranial segment, occlusions can get benefited. Also, it will be beneficial in the patients who have occlusion in M1 and M2 segment. However, efficacy in a patients those who are distal M2 or AC occlusion, the efficacy is not clear. However, thrombectomy associated risk of vessel perforation and vasospasm has been quite noted. Other medications apart from the thrombolytic, what we commonly use is antiplatelets. Most commonly used is aspirin and clopidogrel. Aspirin usually will load either with 300 milligram followed by maintenance dose between 75 to 150. It is used in both TI as well as in stroke. Clopidogrel is 300 mg stat we have to give followed by 75 mg once a dose we have to give. Heparin in the form of either conventional heparin or unfractionated heparin depending upon the situation. Most commonly indicated in the patients who have LV clot or those who have CVST. Unfractionated heparin we give either 6 hourly IV or low molecular weight heparin 0.6 ml twice daily depending upon the renal dose adjustment. DOACs or the warfarin or acetone also can be used. DOACs we prefer use in patients who have non-valvular AF, and conventional we use like warfarin or acetone we use patients who have valvular non-valvular AF. The idea is to maintain the target INR between 2 to 3 in a patients who receive warfarin or acetone. Management of complications I am taking into this acute management because stroke, as we see, the complication rate is very high. So important complication I'd like to address pressure source or the bed source because most of the patients are bed bound. So bed source has to be taken care of by frequent mobilization of the patient, maintain the adequate nutritional status. There is no role of prophylactic seizure medications. We have commonly seen lever has been initiated in many patients who have acute arterial stroke. It is not recommended unless and until patient have a clinical demonstrated seizure. Agitation can be there, especially in the patients who are dominant lobe stroke. In that cases, either sedation or some antipsychotic medications can be initiated. The patients are having a dysphagia of feeding has to be taken care of. We have to ensure patient takes adequate oral feeds. If there is no demonstrable proper feeding, then either a nasogastric tube or a PEG tube has to be inserted. Aspiration is one of the most common complications, so this can be taken care unless until, or don't start oral feed unless until we are sure that a patient's dysphagia is not there. However, if there is a dysphagia, again nasogastric tube or enteral tube has to be placed. There is no role of prophylactic antibiotics to prevent aspiration pneumonia. And second is DVT, because the immobilization risk of DVT is very high. So in this cases, anticoagulation, low dose anticoagulation like Clexane 0.4 can be given without any increased risk of ICH. Fall being the other complication, and this can happen at any stage of the stroke, maybe it in acute, hyperacute or in the chronic stages. So necessary care has to be taken about the patient's cognition, avoid the drugs which can lead to the postural hypertension or falls or which can lead to sensory impairment. Exercise, calcium supplements and biphosphonates will improve the bone strength and decrease the fracture rates in stroke patients. What does the stroke unit consist of? It consists of an emergency physician, stroke nurse, neurologist, neuroradiologist, neurosurgeons, stroke unit care directors. All staff members should undergo regular training and get regularly updated at least once a year. So to summarize, treatment is time dependent. As we say, time is brain. Passage of time following an acute ischemic stroke is associated with deleterious outcomes in terms of brain damage. Restoration of the blood flow to the occluded blood vessel can be achieved either by thrombolysis or mechanical thrombectomy. Two agents have been approved only in India are alteplase and tenteplase. Post-thrombolysis care and monitoring for the complications is crucial. Thrombectomy is a minimally invasive procedure that uses mechanical tools to mechanically remove the clot from large vessels, and teamwork is of utmost importance. To sum up, every stroke receiving hospital has its own unique set of blocks, which even the thrombolytics cannot lies. However, to overcome this are imperative to achieve the status of stroke ready hospital. And I'm very sure, as you all are aware, we have started with the code white since last couple of years, all thanks to our administration that for their entire support, our team management, including the ICU, our casualty team. I'm very sure all our residents know how to thrombolize the patient. So the door to needle time has been quite shortened in our time, and the shortest time we have achieved is 18 minutes in a hospital. Thank you.
Excellent presentation.
Yes.
You have covered practically every point.
Thank you, sir.
If you have any questions, that means you have not listened to him properly. But still ask if you have any questions.
Yeah. Hello.
Yes, ma'am.
Now, if such patient comes to OT
Yes, ma'am.
for thrombectomy, should we take down the BPs to the normotensive level?
Yes, ma'am. We have to maintain the BP.
No, because the blood supply of the ischemic area is depending on collaterals also.
Yes,
no?
ma'am.
So,
ma'am, what the idea is that we have to avoid a higher BP more than 185. It's for the thrombectomy also. It should not be below 140 because the penumbra, as it is pressure dependent, because causing the very low BP or inducing hypotension can also lead to the damage. Especially the penumbra area can be it is salvageable if your BP is maintained between the normotensive level.
yeah. Another thing, fever is detrimental. So, is it really that hypothermia is induced or no?
Ma'am, hypothermia we never induce in acute stroke patient unless until a patient is having a brain damage or a brain death, then we have to conserve.
Any role of mannitol or craniotomy? in
Yes.
stroke
So, ma'am,
patients?
whenever a stroke progresses, when a patient we see there's a drop in a GCS score, or whenever neuroimaging shows the patient is having a mass effect or a midline shift, then usually mannitol we don't give prophylactically unless until there is a big stroke or when the cerebral edema is setting in. And despite of the cerebral edema setting in, patient is developing a midline shift, then in that case craniotomy we have to proceed for, ma'am. Craniotomy, to tell, it is just a life-saving procedure. It has got no outcome with the recovery of the weakness of the patient. Recovery will totally depend how the circulation is established following the thrombotic therapies.
Thank you.
Dr. Wag, can you take the patient for a re-thrombectomy? Like recently we had a patient was taken for thrombectomy, patient recovered
Yes, sir.
and she worsened again next day.
Yes.
We thought it could be edema or some hemorrhage,
Right.
and we realized there's a re-thrombus,
Yes.
thrombus occurred again in the same artery.
Hmm.
We went ahead with conservative management, but is there any role of re-thrombectomy in such patients?
So whenever we take a patient, because most of the time we have seen because of the cost constraints, the decision is quite delayed. So ideally whenever a patient comes to us, we usually see there's a flare and a diffusion mismatch. We thrombolize the patient, even if patient for thrombectomy. So but if the flare is showing as the same level of lesion to, I'm coming to that.
Yeah.
If the flare and the diffusion is showing the same lesion, that means the patient will not benefit from thrombectomy, sir. Even if you establish a circulation, the damage has already been happened, sir. So in that case, re-thrombectomy I will not recommend. Better go for a conservative management.
So re-thrombectomy practically is not really an option.
So because the time has already lapsed and the brain tissue has been already been damaged. So because if it is there, it must be definitely 24 hours later. So re-thrombectomy after 21st I will not recommend.
Thank you.
Your recent slide showed that there is about 50% patient will develop dysphagia.
Yes.
How long will you wait for dysphagia to recover before considering patient for either PEG tube placement or for a Riles tube feeding or anything?
So if a patient having a demonstrable dysphagia, Riles tube, so I'll definitely place. For going for a PEG tube, at least minimum 3 months should we wait at least for the recovery, provided patient is taking a proper care for the speech therapy also, swallowing assessment. And I'd like to have a baseline fees for functional endoscopy assessment, look for the stage of deglutition and what care can be taken so as to impair the nutritional status of the patient. If the nutritional status is getting compromised even after 3 months, I'll definitely recommend for the PEG after 3 months.
Okay. Any time frame, say like for we as a gastroenterologist would wait for any patient about 1 month before considering PEG.
Right.
As a neurological stroke, any specific guidelines? Okay, now there is no possibility of recovery and yes, he will need a long-term feeding.
Yes, sir. So that's what, sir. Because since if the stroke is quite big, still we hold on a thing because the speech therapy has shown a demonstrable effect. The swallowing therapy has shown a demonstrable beneficiary in the patient's improvement of the swallowing. So 3 months I'll definitely wait before proceeding for a PEG tube insertion. Yes, ma'am.
I would want to know how often is imaging required to be repeated in a patient? Does the GCS determine how often you repeat the imaging, number one?
Yes.
And in patients who have a hemorrhagic stroke, is there any method? You spoke about thrombectomy, which is for an ischemic stroke.
Yes.
But for a hemorrhagic stroke, what is the methodology? Is there an embolectomy that is described for? Because sometimes when you see a patient bleed out, they start with a GCS, which is good, and in front of your eyes, you see them deteriorating, and it seems like then they're too far gone for even neurosurgery. So is there any minimally invasive process that can help a patient with a hemorrhagic stroke?
Yes. Ma'am, the imaging totally depends upon the patient clinical status. If you have a lacunous stroke or a small stroke, there is no need of repeating imaging unless a patient shows any new neurological symptoms or any deterioration in the GCS. If a patient is having a deterioration in GCS, immediately go for a scan. Or if a patient is having a big stroke, we either wait for 24 hours or clinical deterioration, whichever comes first, depending, we repeat the scan. Coming to the bleed part, if the bleed is quite in the core of the brain, like example in the internal capsule, it is quite difficult to navigate. So in that case, surgeons usually conserve. But if a clot is peripherally placed, definitely surgical evacuation of the clot can be done, depending upon the patient's general condition is deteriorating. Or placement of a EVD, extraventricular drain. If the patient's, it is causing a hydrocephalus is setting in, then that case go for a EVD insertion. Neuroimaging, we totally decide like if there's a deterioration is being seen, so whatever comes first, as I told, GCS drop or a new symptoms are happening or 24 hours, whichever is first, we go for a repeat scan. If at least 2 scans are showing there is no further deterioration, then usually we don't repeat the scan again and again, ma'am.
I have a futuristic question.
Yes, sir.
We spoke about doing a thrombolysis and a rethrombolysis.
Yes.
Is there any chance if you think that the vessel is damaged, putting a stent to prevent a rethrombosis?
Sir, especially considering for thrombectomy in acute stage, especially in MC and all, we don't go for the stent immediately because the as the clot is retrieved, the vessels are quite fragile. So chances of perforation are high, as we told. So trials are still undergoing regarding the placement of stent during. Only whenever stenosis is there, especially in MCA, then we go for a stenting. Right now, if there only is a clot, so just retrieve the clot.
Thank you.
Yes.
Thank you, Dr. Satish Wagh.
Thank you.
Excellent presentation.
I would request Dr. Russell Pinto, sir, to give a token of gratitude to Dr. Satish Wagh.
Welcome to today's session on diagnosis and treatment of acute limb ischemia. ALI is a medical emergency characterized by the sudden loss of blood flow in a limb, often resulting from embolism, thrombosis, or trauma. Early recognition and prompt intervention are crucial in preventing irreversible damage and potential limb loss. In this session, we will explore the clinical science, diagnostic approaches, and latest strategies for managing this critical condition, including medical, endovascular, and surgical treatment options. Understanding these key concepts will enhance our ability to manage ALI effectively and improve patient outcomes. I request Dr. Anirudh Boyan, the birthday boy, to go ahead.
Fantastic introduction for the topic, sir. So today we'll be discussing about acute limb ischemia. Normally what presents to us is, I think the screen is visible, is the foot and the hand in such a state. When you get this sort of presentation, it's quite late in nature. And most of the times the last doctor who is consulted before an amputation is mostly us. And this is when the game is all lost. So what do you normally do? You see a limb, you see it is devascularized, there is no blood supply going down. You try to remove the clot, and once you remove the clot, everything is gone, and the limb can be salvaged. It is very important to know the difference between an old clot and a new clot. An old clot is basically a plaque. It is the fat, it is the calcium which is remaining in the blood vessel. Whereas on the other hand, a new clot is all the new muck which is formed because of any flow disturbance in the body. So it is very important to differentiate. When a patient comes to you, you should ask for a history. You should understand whether the symptoms have come in today or it has been there for years prior to the problem. And the most important problem in India is delay, delay, and delay. A patient has a pain in the leg, a patient does not come to you first. He will try all the alternative medicine methods, put balm, put oil, and then once that does not happen, then he comes and then he realizes there's a big clot in the leg. Now the thing is, why is it an emergency? It is very important to note, people talk about cardiac events, people talk about strokes, but people think that, okay, limb gaya to gaya. We can always amputate it. But most of the times when the patient comes to you, this limb can cause a reperfusion injury. And that reperfusion injury can cause the myoglobinuria, can cause a DIC, can cause multi-organ failure, and unfortunately death of the patient. So what we need to know is muscle death can start within 3 hours and may be irreversible by 6 hours. As muscle death occurs, the risk of reperfusion injury goes up, because when you reperfuse the dead muscle, that is when all the lactates, all the nascent oxygen goes into circulation, and that may kill the patient. And in cases of irreversible ischemia, never revascularize, always ampute, because when you revascularize a dead limb, you're causing all the toxins to go into circulation and ultimately kill the patient. So what is important is you should know at what stage the patient is presenting. If the patient has no movement, no sensation, no signal, both arterial, venous, and it is a cold limb, please do a fasciotomy, look at the muscle contraction, and only then plan for revascularization. But it is always better to ampute these patients rather than trying to save the leg. It is always important that life is over limb of the patient. And if the patient has a viable limb, yes, good signals, try to save the patient. If it is marginally threatened, where there is little or no blood supply, you can always anticoagulate. And immediately threatened, please wheel in the patient to the OR and try to remove the clot as fast as possible. As I have told you, a reperfusion injury is primarily because of the toxins in the leg, and that can be because of oxidative stress, any inflammatory response, endothelial dysfunction, any necrosis, apoptosis, and cell death. Now, the clinical implications are that there might be a lot of local wound damage all the way to a multi-organ dysfunction. And the prevention of such is by antioxidants, surgical techniques. There are many emerging techniques of ischemic preconditioning in which smokers tend to actually do better in an acute limb because they're already collateralized. So even if one vessel goes down, that patient is not dependent on that single vessel. So whenever we do a surgery for an acute limb, we always do a fasciotomy. And a fasciotomy is just to make sure that we give some breathing space to the muscle. And the clinical dilemma normally in such cases is to know why and how the patient has had an acute limb. So it could be an embolus, it could be an in situ thrombosis. There can be multiple sites of ischemia which can play a role. And it is very important to know whether it embolized, because then you need to treat the source of the problem. And when it thrombosis, that is, if there is a problem, there is an acute event in the background of a chronic event, and that is when you need to know what to treat and how to treat. Now, what will you do with an ALI patient? Even in the middle of the night, please get help. And that is with terms of calling the specialist. Please start with heparin. Heparin is a friend, it is not a foe. It can be reversed very easily, but only when there is a bleeding tendency for the patient, don't start. Keep checking for movement, keep checking for sensation, and fast track the OT and prepare the patient for metabolic acidosis. it's a very good habit to check for the pulses. Check all the pulses, including the carotid, radial, lower limb, tibial, dorsalis pedis, etc. And it is not wrong to, if the patient has a wound, please wear gloves, sterilize the hand, and then check for the pulses. The problem is that when there's a wound in the leg, a diabetic foot, we tend to stay away from the patient and we don't check the pulses ourselves. However, a proper evaluation would be screening with a Doppler. There could also be CT scans which can be done initially if there is extensive thrombosis. MR is not usually recommended in an acute setting, and DSA would be operator dependent. As one can see over here, this is how we do a thrombectomy. This is the femoral artery. We go in, we try to remove the clot, and you can see all the clot coming out like jelly. It's like currant jelly, and it comes out, and that actually restores blood flow. You can see a flash of blood once a clot is completely removed. On the right hand side, you can see all the laminated clots. This is a subacute clot, and it basically laminates, it fixes into the vessel, and these clots may be difficult to remove because the moment they embolize into a smaller vessel, that can create a lot of problems. So in this patient, if you see, there is a blockage here which looks like probably an angioplastiable or a stentable lesion. But then you ask for the history. The patient says, oh, I've got this for only 3 months now. And before that, I was walking, talking, and doing everything. The other leg pulses are absolutely fine. And that is when you plan not to angioplasty, open up, remove this laminated thrombus, and get good flow going into the vessel. So post-operatively, the scenario may be very interesting. You might get a lot of clots out, and the patient might be very happy after the clots are removed. But always, always understand that the more minimal you are in whatever you are doing, the better is the quality of the vessel. That means, as Madam had said, or I think Dr. Manish had said, rethrombectomy. Now, rethrombectomy normally damages the vessel as much as, meaning there's a lot of intimal damage. So when you go in first, that is your best option to get the clot out. The second time or the third time may be rethrombotic in nature, the surgery being the cause of the problem. These are newer devices which are now available, like Rotarex. There is an atherectomy system as well. That is more for the chronic clots when there's an acute and chronic presentation. And as you can see here, it's very easy. A block which was there gets opened up. We go into the vessel. That device is actually over there. We have kept for a demo for anyone to actually go and see. And that is how we get the perfusion going. This is one of the cases where there was a left forefoot gangrene since 2 weeks, first dusky, then demarcated. This is Dr. Prashant Parikh sir's patient. And there was an attempted angioplasty done of the left lower limb, which was abandoned due to the thrombus going down. So when we did an angio, we found that everything till the knee was okay. And it is below the knee which had actually gotten affected. If you can see here, just above the ankle, the anterior tibial artery is the only dominant vessel. And that is completely gone. And there's no flow which is there in the anterior tibial artery or the foot. And if you see the picture of the foot, you understand what it has actually caused. So in this patient, we do a thrombolysis with a thrombosuction. This is endovascularly, where we go in with a wire and we try to core out as much as possible and suck out as much as possible. And after which, we get a good final outcome where we get a completely restored pedal arch. And that actually at least saves the patient from an amputation where the dry gangrene will actually sort of demarcate and fall off. And the patient does not require any treatment thereafter. This patient had a DPA palpable on discharge, and the patient has been on follow-up. The other thing I wanted to tell is do not stent inside a thrombus. So many a times we get a lot of patients stented, and the thrombus basically just cheesecakes inside the stent and completely blocks it off. So it is very important to know what is acute, what is chronic, and what is subacute to actually plan the treatment for such patients. Another note about the cervical rib, where it's an accessory rib which is there for upper limb ischemias. They normally present like a Raynaud's with disky discoloration. This is one of the patients which actually had dilated subclavian artery just at the level of the cervical rib. And this is where we went in, slightly gore for a few people, but this is how, this is the supraclavicular nerves. This is the lateral border of the sternocleidomastoid. There's supraclavicular rather. We retract them laterally, and the brachial plexus is here. And once we retract them, you find there's an artery over here, which is a subclavian artery. and there is a cervical rib just below that, and that is compressing between the clavicle and the cervical rib, compressing the subclavian artery. And that is how we remove the cervical rib in such cases and completely treat the patient from the problem. So I would like to end by saying not all feet are created equal, and every patient requires a catered treatment and diagnosis. Thank you, everyone. Any questions?
What is your emoji about? I can't understand the emoji below Holy Spirit Hospital.
That's a smiley, sir.
Oh God, you're an old man.
Did you have another image of that lady who had that right gangrene? You said, you got the circulation posterior, the anterior tibial artery, Is there a photograph of her limb post-procedure? Because
no, it will remain the same, madam. Whatever is gangrenous and gone.
But
now,
you don't have to amputate that?
No, the patient is on follow-up. It's
will
a dry
follow
gangrene, the patient is on follow-up. Dry gangrene does not need to be amputated unless there is infection which is set in.
Hi, Aniruddha, fantastic presentation. Just a clarity on a few things. What you mentioned was an acute, a subacute, and a chronic thrombus. Now, in intervention, whenever you are intervening, are there any specific approaches to a chronic thrombus? Like, do you anticoagulate them so that you achieve, do they soften subsequently for you to intervene later? And the second question is that the first part of your talk, you said that it has to be a close liaison between the surgeon and the vascular surgeon in attempting an ischemic limb. Wouldn't it be right or good to discuss it amongst each other and plan or formulate a line of management? Will that help in saving limbs?
Sir, SOPs are very important. Ideally, as how Dr. Satish Wagh had said, there is a code white. Similarly, for any acute organ ischemia or acute organ injury, it is always better to discuss, try to get a consensus growing, and that actually helps. A phone call, rather the discussion is just a phone call away, and that will actually help in the patient overall outcome. Regarding your first question regarding the chronic issues, that comes under a category of CLI or critical limb ischemia. And critical limb ischemia should always be intervened if there's a wound or there's rest pain. Now, critical limb ischemia, the advantage is there are collaterals already. Because the chronic state, there is reperfusion, the patient has gone over it, and there are a lot of collaterals which are there. So that helps the patient. So the patient will not land up with an acute limb. But if, for example, those collaterals go down, that is when it's very difficult to manage such patients.
The idea would be to amputate.
How do you deal with patients who have some sort of renal insufficiency, who have this? What dye you use? Do you prefer CO2 angiography?
Sir, the advantage is in an acute limb scenario, we have to go in fast, quickly. Now, we can use Visipac, which is a non-iodinated contrast media, and we can also use carbon dioxide as a dye. And that will help in visualizing the vessels quite clearly. The problem with CO2 is that we cannot visualize the below-knee architecture well. And for such patients, we initially do an MRI time of flight, which is a MRI per se. And looking at that MRI, we go ahead and plan, whether it's open or endo. That gives a very clear idea about the anatomy of the leg.
Anirudh, just one. Yeah, Anirudh. Yeah. Just one out of way question. आजकल सोशल मीडिया पे 10 लाख का पेनुम्ब्रा कैथेटर बहुत आ रहा है जरा. Just can you let me know?
So penumbra lightning, it is called. It's an AI based catheter. It goes into the clot, and wherever there's a clot it sucks. Wherever there's no clot it does not suck. Technology is growing, cost of technology is more. I think initial acceptance jo hai, the initial phases, everything is costly. As time progresses it will become cheaper.
Yeah. What worries you more, a thrombosed vessel or a ruptured vessel?
Thrombosed.
Thrombosed vessel.
Rupture you can always manage if everything is set up well. Thrombosed vessel, you don't know whether it will open, it will remain open, and then post-op care is also important thereafter.
one question. ALI is very painful, no? So you give any analgesic?
Madam, we start with prostaglandin, which actually opens the collateral vessels. We also give heparin. And in terms of analgesic, over-the-counter fentanyl, meaning rather IV fentanyl, we give any painkillers which are available. That actually helps. The ICU guys actually manage that well.
Yeah.
Thank you very much. Thank you.
Thank you, chairpersons. We move on to the next session. Just a moment, sir. I think we move on to the next session. The chairpersons of the next session, Dr. Akshay Shah, Dr. Vernon Sequeira, and Dr. Sandeep Shah, sir. Kindly take the stage.
We move on to our next session, and I would like to call upon Dr. Nadeem Motlekar, who is going to speak on thrombosis in critically ill ICU patients. I don't think so Dr. Nadeem needs any introduction.
Okay.
And his talk will also give his introduction very well.
वो इधर लाओ ना. One slide is missing here. यहाँ पर है. इसको डिलीट कर उसके बाद. हाँ, इसमें. Sorry for the little delay. One of the slides which I want to showcase is not showing up that well. I'm just trying it so that I can get it. To start, I guess it's an opportunity, a great opportunity. I would like to thank Holy Spirit Hospital, Sister Lissy, Sister Felsi, Dr. Susan, Dr. Anuja, she's not here, and of course Dr. Anirudh for inviting me to talk on thrombosis in critically ill. I have always understood any topic from a base level and then try to build up, because I feel understanding as to what is happening might help us intervene at the right time. So thrombosis in the critically ill, we are actually, now these is what we normally encounter. An intensivist in the intensive care will always encounter certain syndromes. Now, it is the domain of a lot many, and I guess we have excellent speakers, and the topics are well designed to talk on that subject. Subsequently, over the next part of the day, the cardiac thrombotic syndromes, Dr. Amit will be able to take it better. But the non-cardiac thrombotic syndromes is what I would be more interested in. And of that, sepsis and trauma is an area which I'll try to focus on more. And I'm sure the others would speak on their concerned topics from the cancer point of view, and the stroke has already been dealt with. A deep venous thrombosis, heparin-induced thrombocytopenias, which we normally encounter while we are treating patients in the intensive care unit, acute pulmonary embolism, sepsis, trauma, TTP, HUS, thrombotic DICs, and stroke and central nervous system venous thrombosis. Now, I've kept my presentation more diagrammatic. Diagrammatic is primarily so that we understand as to what happens and how a thrombus is initiated. We normally try to mug up in our first and second MBBS and write a very beautiful answer, subsequently just coming to know or understand that in the final phase, how important it is to understand the entire coagulation pathway. I guess all of us are aware of this classical coagulation pathway. Now, blood stays, as to how a thrombus is formed, is that it stays with fluidity. And one of the most important things in fluidity is the vascular endothelium. Now, anything that causes a disruption of this vascular endothelium incites a coagulation cascade, and subsequently to the formation of a thrombus which comes. Out here, what I've shown is a common pathway, all right? And in the common pathway, the primary event, I'll not elaborate, I'll just highlight the salient features, is that it is initiated either through the intrinsic pathway by the activation of factor 12, by the generation of a high molecular weight kininogen and kallikrein, or through activation of intrinsic pathway by tissue factor. Now, this is important because that is the first step where a clot is formed. And since the paradigm is shifting, earlier days, the thought processes were different, ischemias, hyperperfusions. Of course, they have a role to play, but with the COVID pandemic, which we faced, inflammation or the role of cytokines have come into a lot of play. Now, what I mean by that is that there is a crosstalk between the intrinsic and the alternative pathway. And that is how incites the formation of a thrombus or a clot. Now, has it come on to the next one? How do I get that? Yeah. Okay, so this is basically a crosstalk, a modified clotting cascade indicating crosstalk between the intrinsic and the extrinsic pathway by the action of factor 7. Now, factor 7 is a tissue factor which leads to the disruption. So the tissue factor comes into play when the endothelium is exposed to anything, be it sepsis, be it trauma, be it TTP or anything, or even from the gynecological emergencies, certain things or certain trigger has to activate this. And that is what activates these system or the coagulation system. How do I? I'm not as good as Anirudh to keep on changing. I don't know how to change the slides. Yeah, that's how it is. Now, this is how what I've shown in diagram. This is the endothelium, all right, the vessel injury ultimately leading to hemostasis. Now, hemostasis is not just formation of a clot, it's also fibrinolysis. Otherwise, if that process is not stopped, it will keep on generating more and more and more of thrombus. Now, the ultimate thing in a clot formation is the formation of a thrombus where fibrinogen is converted to fibrin by the action of thrombin. So this thrombin plays a very important role in fibrinolysis also. It activates what is called as an activated protein C, and if you go, I guess few of them may have used it in the recent past. When sepsis guidelines came, Zygris was one of the molecules which was used in sepsis.
the activated protein C, because what they found was that it's the microcirculation which plays a very important part in organ dysfunction. So the paradigm shift has come to microcirculation, not macrocirculation. And that is the site, and it's a very huge area. A huge area, so much so that it can cause multi-organ failure. Now, the role of platelets plays a very important role out here, where primary hemostasis is at the site of vascular injury. Now, the platelets are initially activated and express specific adhesion molecules. Once the platelet is activated, it goes and binds to a von Willebrand factor, all right, and then it leads to activation of a series of steps, ultimately leading to the formation of a clot. And never to forget, the final is that the thrombus, which is formed, can't be allowed to propagate. So then the process of fibrinolysis in a normal thing takes place, where the thrombin and the thrombomodulin complex leads to the activation of an activated protein C. So what this activated protein C does, it causes fibrinolysis to maintain again the fluidity. So any disruption in our understanding of this physiological parameter would help us. No. It could be any diseases. Could it be sepsis? It could be trauma. It could be acute coronary syndrome. It could be deep vein thrombosis. It could be pulmonary embolism. It could be HIT. The activation has to take place, otherwise it will not clot, or it will not form, or it will not lyse. Again, out here, what I've tried to show, it's more of a diagrammatic presentation, where I've tried to show how the thrombin and the thrombomodulin complex, with the help of the endothelial cells, causes a release of tissue plasminogen activator and urothelial plasminogen activator. That leads to the formation of plasminogen, plasmin, and this is where your D-dimers and FDPs go up high. Just an important point out here is that the difference between an FDP and a D-dimer is that nowadays the reliance is more on D-dimers. There is a lot of overlap between DICs, trauma-induced coagulopathy, sepsis-induced coagulopathy. The distinction is becoming more and more broader. They have their self-presentation, and it's a little different in the initial aspects, that it is not entirely DIC, it might manifest as DIC. So when you say D-dimer, it is basically after the amount of plasmin, which is, or the fibrin, which is formed by the action of thrombin on the fibrinogen, and not an FDP. FDP can be formed in non-DIC related issues as well. How to interpret the data. So the D-dimers play an important role in the management. And subsequently, as we talk, the D-dimers has a role in anticoagulation as well. So if you follow, probably we'll be able to understand it better. This is important, which I was trying to highlight, that trauma-induced coagulopathy and sepsis-induced coagulopathy are two distinct entities. They are not a part of DIC initially when they are incited. They are a little different. Now, to start with trauma, a traumatic patient, the commonest thing a patient is in a state of shock is hemorrhage. And after resuscitation, it leads to, initially it leads to, the phenotypes are two. Initially, you will have a hypercoagulable state where there is a form, because it has to have an effect to stop the bleed. So the body initiates a mechanism where a bleed has to be stopped. But subsequently, when in failure to do so, it can lead to a hypercoagulable state. So in trauma, prophylaxis or prevention of deep venous thrombosis plays a very important role. Similarly, in sepsis-induced coagulopathy, earlier days they come in a state of shock, but what have they found is that in all the organs, there is a hyperdynamic circulation. What I mean by that is that in the renal system, people talk about hypoperfusion. But what studies have said, there is an increased renal blood flow. Still the creatinine goes up high. So it's the role of cytokines that causes or initiates the clotting or thrombus formation. Basically PAMs and DAMs, damage associated molecular proteins or pathogen associated molecular proteins and their activation. And it can happen in trauma. The difference between trauma and sepsis is that trauma can have an inciting of a thrombus within an hour. Whereas in sepsis patient, what we see in the intensive care unit is that initially they come, the counts are high, the platelets are normal, subsequently day 2, day 3, the platelets start going up, down, and then, of course, the sepsis-induced coagulopathy comes into play. The picture will be very similar to a DIC, but no, DIC has 3 different phenotypes. I'm sure the hematologist, Dr. Shilpa or something, will be able to give us a better insight of it, is that one DIC is where you have all the parameters and they bleed. One DIC can be prothrombotic, especially metastatic carcinomas. They are prothrombotic. They are not, they have a picture like a DIC, but instead of giving them blood products, we give them heparin, and it does wonders. And the third phenotype is that they have VA and they don't bleed at all. So there are 3 different phenotypes of DIC per se. And this is what I want to show, is that we went through a pandemic, and probably COVID taught us a lot many, where the virus basically damaged the endothelium, which I was talking about, and subsequently leading to multiple thromboinflammation and causing thrombus in multi-organs, where we never had guidelines as to how to treat them, but then people subsequently understanding, and the guidelines went up to 3 months to 6 months. I guess cardiologists give it up to 6 months of anticoagulation. The mechanism of trauma-induced coagulopathy, it's basically what I said was hypoperfusion, tissue injury, endothelial activation, immune system activation, and subsequently thrombin, there is a decrease in thrombin formation, fibrinogen, platelet dysfunction, and one of the phenotypes is clot formation, which is the initial aspect of trauma. Again, this is what I've just said. Yeah. So basically, a severe injury can provide a myriad of trauma-induced TIC phenotypes that generally begins with uncontrolled bleeding and progresses to thrombotic complications. This is what I wanted to emphasize, is that everything what you see in the intensive care is not DIC. What I'm trying to say, in a certain subset of people. In this subset of people, probably instead of giving FFPs or fibrinogen or platelets, all right, if we understand the mechanism, I guess probably we'll be able to understand it and intervene appropriately. So there are 3 phenotypes: the thrombotic phenotypes, the mixed phenotypes, and the bleeding phenotypes. Now, what Dr. Anirudh said is that a good clinical examination is mandatory. Clinical examination is bound to stay. For us in the intensive care, it is basically the interpretation of data. Your data analysis has to be good. And what is important in thrombosis, in the intensive care and its management, is the role of TEG. I guess over a period of time, we were introduced to TEG when we were working in a cardiac institute where cabbages required a lot of transfusion. So how do you judge how much to give, how less to give, and what to give? Now, the role of TEG is study-wise proven that it is beneficial in 3 conditions without any doubt. One is in trauma, and there is an upcoming role in sepsis. Because any blood or blood products you give, kindly understand it is a double-edged knife. The Abbreviations of TRALI, TACO is a reality. If you over-transfuse, you may encounter and create a problem for yourself. So understanding as to what products to give, how much to give, probably may have or give us an idea. So that is why I have included TEG. The newer one is ROTEM, rotational thromboelastography. And of course, in thrombus, the PT, the PTT can be normal. So it may not give you any idea whether it's a mesenteric ischemia or is it a limb ischemia. Your APTT or prothrombin time may not be normal. I mean, may be normal. And it may not give you anything. So what is important out here is that endogenous thrombin potential, indirect markers of thrombin generation, basically the prothrombin fragment F1, F2, certain labs do that. Antithrombin, thrombin-antithrombin complexes, markers of fibrinolysis activation and inhibition, the plasma, antiplasma complexes, and the PA activity can be known through specialized laboratories and may help us guide treatment. I wanted to introduce this slide, or probably expose you all to the concept of understanding TEG. Now, plasma, what prothrombin time and APTT, what you do is basically a plasma-derived investigation. Here, it's a whole blood. And what the TEG does, it tries to read right from the inciting of the injury to what has caused it. So if you take 36 ml of blood, and if you put it in the TEG machine, and it spins between 40 to 45 degrees at every 5 seconds, all right, and it is suspended by a pin, and the wire has got a torsion. So with that spin, it creates a graph. And depending upon that graph, you can come to know as to what is the coagulation defect. Out here, this is a normal graph, and it has a tail, which is called as the R time. It has got an angle, all right, oh sorry, it's got it, as it goes down, this is the K time. So everything has its importance. So basically the R time is normally 5 to 10 minutes. It's called as the reaction time. It's the time for the formation of the initial clot. Naya wala fibrin aane tak. So the tail tells you that, and the length of this tail may give you a clue. So the patient's problem is basically coagulation factors, and you may infuse FFPs. Maybe the platelets are not really required here. Subsequently, the K time, it's 1 to 3 minutes, and it is the kinetic time. That is the time until clot reaches a fixed strength. So it takes some time for a clot to reach a fixed strength. And the problem is fibrinogen. So if it is low, that means you need to replenish fibrinogen, that is basically cryoprecipitate. Subsequently, the angle out here, the angle which it makes out here, is the alpha angle. The speed of fibrin accumulation, again the problem is fibrin, you can give cryoprecipitate, and platelets, one of the guidelines say 1:1:1. When to introduce cryos, textbooks say that after 4 units of transfusion you can introduce cryo. Otherwise the transfusion protocols in a massive transfusion protocol is 1:1:1. That means blood, platelets, FFPs. And the maximum amplitude, that is the height with which that wire generates, also gives you. So the problem is the platelets. So this height will go up and down depending upon your platelets. Here, of course, you need to give platelets or desmopressin. And of course, the lysis time at 30 minutes. The percentage of amplitude reduction, which is approximately 0 to 3 minutes, 3%, percentage of amplitude reduction 30 minutes after maximum amplitude, that means excessive fibrinolysis. Here, you need to give tissue. Aminocaproic acid, or what we call as, in the crash trial, what we give is 1 gram, I'm not able to recollect that, tranexamic acid, right? And this is how the graph looks. Okay, various shapes and sizes. Okay, this is normal, all right. The tail has become big. Okay, there is an increase R and K time, decrease alpha time out here. Of course, it becomes longer to thrombocytopenia, platelet blockers. Okay, decrease maximum amplitude. And this is where fibrinolysis, that means where there is excessive of fibrinolysis taking place. This graph you can treat in CCUs after you thrombolize a patient as well. Hypercoagulable state, the entire amplitude increases, okay? The tail shortens, the K time shortens, and the alpha angle increases. Early DIC, hypercoagulable, secondary fibrinolysis, and of course, in late DIC, which is in hypercoagulable, this also increases, and so this becomes shortened. What we do in the intensive care is prevention, more so prevention, and of course inviting our specialist friends to help us out, is that we take two scores, well validated, basically the revised Geneva score and the Wells score. Wells score is given in a lot of textbooks. The maximum the score, the chances of you having or you being at risk of thrombus formation in the form of deep vein or anywhere else is high. These are the variables which they take into consideration, basically previous DVT, platelet counts. This is not valid in gynecological patients. So when this was devised, the score was devised, you can't use the same patients or same criteria to assess that this patient is at risk of a DVT in gynecological, though pregnancy itself is a hypercoagulable state. These are the common regimes which is important. Now, dosage is important. Ramesh sir is there, I don't know. Okay. Heparin, conventional, when you give a prophylactic dose, if it's not given in an appropriate dose, probably it may not help. How will it help? All right. So the dosages where unfractionated heparin is given at any level of creatinine clearance, the dose is 5,000 subcut BID or TID. The fear should not be there, especially when you're giving, because two people who may benefit, who may not benefit or have a negative outcome are patients with stroke. The incidence of a PE is 58% if they are not anticoagulated. That's very large. Similarly, patients with sepsis and trauma, and the duration of treatment also differs. The duration is not well defined in studies, but certain places, the duration, especially metastatic carcinomas, it is for 28 days and not 5 to 7 days. Similarly, using enoxaparin, in polytrauma, the dose becomes 60 milligrams per day or 0.3 subcut BID. Otherwise, universally, it is 40 milligrams OD. Anyone who's on the higher side, about 100 kilograms, like myself, could be around 0.6. All right, and of course, the other things which you can use is dalteparin, fondaparinux. And what caught my interest, especially in orthopedic patients and all that, is that if there is a high risk of bleeding, so there has been a paper where people have used aspirin, 81 milligrams. Earlier we used to criticize as intensivists, aspirin acting on venous system, but there was a beautiful paper which came and which said that in major orthopedic surgeries where you were not able to use for some reasons warfarin or any other drug, you could use aspirin to prevent a DVT. Dabigatran, apixaban, intermittent pneumatic compressions with or without pharmacological prophylaxis. Now the key points out here, early TIC is a distinct entity from DIC, share common features. Early TIC typically manifests as the inability to achieve hemostasis. It is important for us to know, and is driven by a combination of inadequate thrombin generation, fibrinogen depletion, and platelet dysfunction. DIC is a result of inflammation-provoked hypercoagulability, resulting in increased tissue factor expression and widespread clot formation. Fibrinolysis shutdown can occur in both trauma-induced and DIC, inhibiting the physiological process of clot degradation. And let me tell you, viscoelastic hemostatic assays, that is the TEG and the ROTAM, have got an improved mortality benefit, 15.8% mortality benefit. So if I give tranexamic acid in a trauma patient, as per the CRASH 2 trial, you have a mortality benefit of 0.5%. And if I resuscitate this patient of trauma by plasma therapy, before the patient arrives to the ICU, the mortality benefit is 9.8, mortality benefit, not anything else. But if I use this system of viscoelastic hemostatic assay, studies are innumerable. And they have a mortality benefit of 15.8% when used appropriately. SIC is a new terminology based on platelet counts, INR, organ dysfunction, and may progress to DIC. Thank you.
Any questions?
No, sir. This machine is commonly used in, what I got exposed was in Kikabai, where Dr. Bhave used to use it a lot with cabbage patients when they had a lot of bleeding. And that gave us a fair insight of what products to give.
So if you have this machine here, the mortality benefits are
Yeah,
15.
that's what the study says, 15.8%. That's a large benefit, sir. The only three modalities, since we're catering to trauma, which has shown benefit, is the role of viscoelastic assay.
Sir, I think
15.8%.
it will also benefit
that's a huge
patients
benefit, yeah.
who are actually bleeding in the OT, and patient is likely in DIC. You send a TEG, you see a TEG graph, you know that the patient is in DIC for sure.
So a lot of benefits of
Lots
this.
of benefits. And this technology is almost more than 20, 25 years old. It's not a new technology.
Anyone else?
Dr. Nadeem? Yeah, behind you.
Ah, yes.
Can you guide when will you prefer using warfarin over NOAC?
So the guidelines from the cardiac perspective in valvular heart, there are new studies which are coming up, the role of apixaban, they are using it as a prophylactic agent, NOACs. Otherwise, warfarin is the drug which is to be used. Probably over a future year, probably when people are becoming more bold and they take chance with these valvular heart disease patients, I think ultimately it will be NOACs. The advantages of NOACs are primarily that you don't need any monitoring. And it's difficult to actually have a target INR with warfarin. और अपने यहाँ पे इंडिया में these are basically acting on vitamin K dependent factors. People are, majority of them are vegetarians. So in the diet, if you have a large K content, okay, rich in A, so probably the desired dose might not be A. And it's very, with warfarin, you need to keep on monitoring the PT and the INR. Whereas in NOACs, you don't have to do. Even if they get deranged, you don't need to monitor, because the site, there are different NOACs which act at different sites, something direct thrombin inhibitors, anti-10A inhibitors. So they act at different levels of the coagulation pathway. So I guess the future is going to be NOACs only.
Any more questions?
So, no, sir, I'm not asking. I'll just address that little query. So there are three major things where we can use warfarin is preferred over NOACs. One is antiphospholipid antibody syndrome. There is clear cut. I'll be presenting that in my talk. Second one is mechanical prosthetic valves and places where there is increased risk of GI bleed. So these are the three. There are certain more indications where warfarin is preferred on NOACs, but these are the three major indications, sir.
Any other questions? Students?
Thank you, Dr. Nadeem, for enlightening presentation.
I would request Dr. Vernon Sequeira, sir, to give a token of appreciation to Dr. Nadeem. Behind you.
So our next speaker would be Dr. Sandeep Dawala.
he'll be taking a lecture on perils of mesenteric vessel thrombosis.
I will be speaking on intestinal ischemia. After Dr. Nadim's exhaustive theoretical talk, I will be more practical oriented. So, as I start, ischemia always will give you a fear wherever it is. Whether it is more so when you are worried about when it is cardiac, because if untreated it can go to death or mortality. Also in patients with CNS where you have stroke, if untreated, patient will have again death or it may be a permanent disability. But in GI tract, if there is ischemia and if it goes unnoticed initially and untreated, then it has also a very high mortality. In acute setting, up to 70% of the patients will die due to ultimately due to intestinal infarct, bowel gangrene, sepsis and death. So, how do you classify intestinal ischemia? It is either arterial ischemia or it could be venous, it could be focal segmental. Again, the mode of presentation, either it is acute or chronic. Arterial ischemia can be again divided into two. This is more of, I will be speaking more of later into the acute type. Arterial ischemia, we have SMAE, that is superior mesenteric artery embolism. That is the most common form of arterial ischemia acute. Then we come to mesenteric artery thrombosis. And there is some element that is we commonly see in ICU settings, that is non-obstructive mesenteric ischemia. Focal segmental ischemia, only a part of small bowel is involved where there is ischemic focus. And although colonic ischemia, it is the most common form of ischemia, not, previous slide please. If you see among all these, colonic ischemia is the most common form, not in acute. Venous ischemia, it is either superior mesenteric venous thrombosis, usually acute, or chronic thrombosis of the mesenteric venous system. Usually that is the presentation when you have portal vein thrombosis. Patients usually will not have acute presentation, usually they will have presentation of more of like GI bleed. Now, next slide please. Now, before we go into the clinical orientation, I will just give you a brief update on the blood supply of the intestines. It is basically from the abdominal aorta, three main vessels. It is celiac artery, superior mesenteric artery, celiac artery, superior mesenteric artery, and the inferior mesenteric artery. Celiac artery primarily supplies the stomach and the proximal duodenum. SMA takes over the majority of the small intestine, and the IMA and the right side of the colon, and the IMA is predominantly the left side of the colon and the rectum. Similarly, the venous side, everything is into the inferior mesenteric vein, superior mesenteric vein, ultimately going into the portal vein, the liver, and then finally into the via the hepatic veins into the inferior vena cava. So, if you see the arterial and the venous, it is very complex. It has a great collateralization. In the arterial side, we have lot of collaterals which is coming from the SMA, from the celiac. As you see in the diagram marked, the left side of the colon doesn't receive much blood supply. That is the watershed area from where that is the commonest site of the colonic ischemia. Similarly, the rectosigmoid area is also the commonest site. Now, what is the applied anatomy for this blood supply? So colon, as I mentioned, it's an exhaustive blood supply, lot of blood supply with good collateralization except in the large intestine. Now intestinal injury will depend on how fast the obstruction or how fast the ischemia has happened. What is the cause of the obstruction? It is embolic or it is thrombotic. How fast are we able to salvage the intestine? That is how fast the treatment has been given. And once the obstruction is relieved, how much fast is the reperfusion happened? Now, what is the intestinal injury? They say in small intestine, although you are able to salvage the intestine in time, but even after you have removed the cause of ischemia, the vasospasm in the small intestine of the smaller vessels keep on continuing, which leads to more intestinal injury, and that is the reason for the high mortality in these patients. Although gut can tolerate, as per the last line, the gut can tolerate ischemia for up to 12 hours, and even if, and also up to the, that is mean arterial pressure, unless it goes below 50, we are able to tolerate. Now, majority of risk factors. What are the risk factors for this intestinal ischemia? The most common is, as we start, is the cardiac disease, that is ischemic heart disease, valvular heart disease, infective endocarditis. All these will can cause ischemia because of the embolic event. Then aortic surgeries or instrumentations or handling of the aorta during the surgeries will again lead to thrombus formation, embolic. Atherosclerosis of the aorta or of the abdominal aorta, which can be seen majority of times in the elderly age. If we see and the patient is presenting with abdominal pain and there is exhaustive atherosclerosis of the aorta, colonic ischemia should be suspected as a cause of abdominal pain. Variety of drugs which we see can be given, that is vasoactive drugs, nasal decongestants, alosetron, diuretics, OC pills, all these can cause ischemia. Hypercoagulable states, that is protein C deficiency, protein S, which Dr. Silpa will be speaking in. So that is also a predisposing factor for intestinal ischemia. Then infection, inflammation anywhere in the gut is a predisposing factor, mostly because it causes venous thrombosis. Hypovolemia due to any reason will cause what is called as non-obstructive mesenteric ischemia. Now segmental bowel ischemia, that is what the surgeons usually see from the local causes, that is due cause of obstructed hernias, then volvulus, intussusception, then something called as SMA syndrome, and MALS, that is then vasculitis due to any reason. Even liver cirrhosis is a predisposing factor for basically mesenteric venous thrombosis, that is portal vein thrombosis, and retroperitoneal fibrosis due to malignancies or due to any other reasons. So these are all the risk factors which will cause intestinal ischemia. Now, how do you see these patients? What do they clinically present? As in any other acute abdominal case, usually you will have a lot of abdominal pain. Patients may have vomiting, distension of the abdomen, usually may have ileus-like, or it could be GI bleed. Now, one thing to remember here is when you see the patient, if there is a lot of pain and clinically if you see the signs are less, that is the time when you suspect that there is intestinal ischemia. On examination, these patients will definitely be looking sick looking. If you have, they usually will have tachycardia unless they are on cardiac beta blocker drugs or anything. Hypotension, earlier stage they may be normotensive, but ultimately they will be hypotensive. Maybe having fever because that is a sign that the patients will be going into sepsis. On localized examination, they may have general or localized abdominal tenderness. If guarding rigidity is present, then usually there is peritonitis due to intestinal ischemia. Systemic system, you can see cardiovascular system, they may have murmurs, leg edema, deep vein thrombosis signs can also be seen on the examination. Now, how do you approach? Any intestinal injury is as such an emergency. So, commonest investigations which will tell us is first is CBC, which will show leukocytosis. Low hemoglobin sometimes may suggest that there is associated bleed. One more point over here is in CBC usually have this RDW value. Now RDW value is found in some studies that it is high in patients with ischemia. CRP will be elevated. Amylase elevated, but not the type as what we see in pancreatitis, although the nature of the pain also is different as compared to pancreatitis, but usually we send in acute abdomen, usually we will be sending amylase, so it will be elevated. High D dimer, high lactate levels, and ABG almost showing acidosis. So, as in any acute abdomen, usually what we do is the surgeon or myself or will ask for an X-ray abdomen. Is it very sensitive in patients with ischemia? No, it is not very sensitive, but it gives us a lot of ideas. Now, very low sensitivity, 30%, but typical findings what we may be seeing is either a segment or a bowel loop may be dilated, ileus-like picture. Sometimes we may see intestinal thickening. Of course, air under diaphragm will always tell us that this is peritonitis, and other things what we can see is nematosis intestinalis, which is the, if you see that, it is almost confirmed that it is intestinal infarct. I will be sharing some pictures. Now, here on the left you can see the bowel loops are dilated simultaneously. There is thickening of the small bowel loops. When you see these patients, usually you will not see any colonic air. Usually acute intestinal injury of the intestine, mostly the small bowel loops are dilated and the colon is compressed. The picture on the right, if you see, it is air under diaphragm, it is almost certain an emergency that says that it is peritonitis. Now, this is what I was talking about, nematosis intestinalis. If you see the air on the dilated loop of the bowel, which is there, and the arrow showing it, this is almost confirmed that that is intestinal infarct. It is more easily picked up on a CT scan where you can see air on the individual bowel loops. Now, once you are through with X-ray, normally we can usually we say in acute abdomen we can do ultrasound, but when you have suspected intestinal ischemia, the role of ultrasound becomes very less. Why so? Because the patient is under severe pain, and here ultrasound where Doppler is more sensitive rather than only ultrasound. It will just show dilated bowel loops and you may actually not see the blood flow in the vessels properly. So the imaging of choice here becomes either CT or MR. Again, CT is always preferred over MR because it is less time consuming and the sensitivity specificity is very high, almost 90 to 95%. So what are the, usually we do CT scan with arteriogram. If there is associated history of venous thrombosis or DVT, then you may ask for a venous phase also, so that we come to know about the venous status of the patients also. Now, how does it help? It will tell us the arterial thrombosis, the venous thrombosis, the extent of thrombosis, the distal flow, the collateralization. It will also tell us about the status of the intestines, whether they are dilated, there is intestinal nematosis intestinalis. Of course, then is there any perforation? So everywhere CT takes over. MR, that's why is not preferred, although the sensitivity as per the literature, even MRI is equally good as compared to the CT. So these are a few pictures. The left is the normal CT angiogram of the GI tract. On the right, as you have seen, we have marked that is an aorta, and in between you are seeing that there is no flow, which shows that SMA is completely occluded. That is, this is the transverse section again showing that the SMA is blocked. Few other pictures from the venous side. You can see there is portal vein thrombosis. Usually portal vein thrombosis presenting as an emergency, usually these patients will have either cirrhosis or malignancy or something of that sort. Acute portal vein thrombosis, if you see in a young patient, usually there will be hypercoagulable states or something. The same thing, SMV thrombosis with intestinal edema can be seen on the right side. So as I said, MR abdomen with MR angiography similar to CT but not preferred in acute setting. Again, it is time consuming, it takes a longer time to diagnose. So how do we approach these patients? Once you know that these patients have intestinal ischemia, from my point of view, first thing what I will see is clinically examine him and see is there any signs of peritonitis as on CT. If there is, then direct reference to the surgeon, although the surgical team be other, but nowadays even if you have peritonitis, the treatment of choice first becomes angiography, digital subtraction angiography, because that will delineate what is the cause of the thrombus, and again the outcome of the surgery is also much better if you do a pre-operative DSA and then the patient proceeds for surgery. So if peritonitis is present, exploratory apnotomy is considered. If no peritonitis and there is abnormal CT angiography, you proceed to DSA. Even if you are planning to surgery, DSA should be done because of its high diagnostic as well as therapeutic value. So as in any other emergency, the initial airway breathing circulation is maintained. Patient is put on IV fluids. Usually we keep them nil orally. Nasogastric decompression. Antibiotics will be started. And then, as Dr. Nadeem said, that role of anticoagulation, either you give heparin or you can give low molecular weight heparin. In acute, the doses are slightly different. Heparin is usually 5,000. Usually you don't proceed beyond 5,000 units. Stat dose, and then it is titrated according to the PTT value. Then here comes the role of vasodilators. Vasodilators are usually, when you do a DSA, usually as Dr. Anirudh will be discussing, when you do DSA, usually we give vasodilators to enhance the blood flow. Two types of vasodilators are preferred. It's either papaverine or it is a prostaglandin inhibitor, that is alprostadol. In case patient needs vasopressors because of ongoing hypertension, the drugs which are preferred are either it is dopamine, dobutamine, milrinone. We usually don't prefer noradrenaline because it will cause more vasospasm. Now, as we said, the most important management over here is the role of DSA, because that is the way it will tell us if there is arterial block, it is venous block, or it is only NOMI. Once you do DSA, we are very clear on that. Suppose there is an arterial block and there is an embolus, then you can straight away remove the embolus and you can put intra-arterial vasodilators. You achieve a good collateral circulation, patient gets treated. If patient has associated peritonitis or there is bowel gangrene, simultaneously the patient will be taken up for the surgery. Similarly, if it is mesenteric artery thrombosis, thrombectomy can be done, or you can do angioplasty of the affected vessel, or thrombolytic agents, urokinase, plasminogen, tissue plasminogen activators can be given intra-arterially so that you are able to open the vessels. Non-obstructive mesenteric ischemia, usually these patients we may or we may not subject them to DSA, because majority of times CT itself will tell us, and clinically these patients are sick. Although when you do DSA and if you can give vasodilators, it improves the circulation and you can salvage the bowel. On the venous side, you can also remove the thrombus if it is acute and then followed by anticoagulation. Now, as I said earlier, it helps in bowel preservation and sometimes may also avoid surgery unless there is peritonitis. These are the few cases which we did. The first case is showing that the SMA was completely blocked and angiography, that is DSA, was done, and subsequently the clots were removed and there was complete blood flow which was restored to the intestine and also in the arcades. The second case also similar, clot lysis was done, aspiration of the clots was done, and the complete restore of the blood supply was achieved. So this is just a flow chart. How do you manage these patients? Any patients with acute intestinal injury, the first step is to correct hypovolemia. decompress the patient by putting an RT, keep them nil by mouth, restore blood you can start IV fluids, you do an immediate CT scan, you confirm what it is, either it is an arterial block, venous block, whether patient has peritonitis, no peritonitis. Then according to the DSA, we can take it forward from there. If the patient has peritonitis, patient of course goes for exploratory laparotomy. The affected bowel is removed. Usually we may not close the bowel. Dr. Vernon will be telling us after that. Usually we can do a second look surgery. Usually immediately we may not close if there are signs of ischemia, and also if majority of the times once you do DSA and you have restored the blood supply, you can salvage the intestine which is not affected. So summary in brief, intestinal ischemia is always a clinical diagnosis. You should suspect that any patients with acute abdomen not having much more signs clinically, always suspect intestinal ischemia. Once you have suspected it, do the appropriate investigation. CT is the modality of investigation which will tell us the diagnosis. DSA plays a crucial role in diagnosis, not only in the diagnosis and also in the treatment. Early surgery for peritonitis and remove gangrenous bowel. Role of relook second surgery maybe after 24 to 48 hours. And once the surgery is done effectively, usually lastly the medical management comes of the short bowel syndrome. Thank you.
Any questions?
Yes, sir.
Just mention briefly what is the role of a small bowel transplant in case there is an extensive gangrene of the small bowel because of mesenteric artery?
Yeah, so there is a role, definite role. Usually in patients, if you see the causes of short bowel syndrome, the first and the most important cause is the ischemia, followed by Crohn's disease, which is extensive. Now usually these, once you have removed 3 or 4 feet of your small intestines, they are usually malnourished, depleted. That is where the role of intestinal transplant comes. Now it is not done in many of the centers in India. Only few centers in India does. In Bombay, I guess there is only one center.
Global does it.
Global does.
We have him on our team here, sir, as well.
So
but the only thing is, may I interrupt you? The only thing about the intestinal transplant, sir, is that you cannot do it immediately in the immediate phase.
Yeah,
you have to wait. You get a little bit of short bowel syndrome, whether you are putting an ileostomy and you're bringing exteriorizing it, or like he said, or whether you're anastomosing it, sir. But you get out of the acute phase, you diagnose the patient, stabilize the patient, and you put them on the list. Once you put them on the list, our Dr. Aditya Nanavati is also on that panel, sir. He does this transplant. It's done at Global. The approximate cost is about 25 lakh rupees, sir, as of today. And it's not very uncommon to get bowels because nobody is donating too many bowels nowadays. It just gets wasted. And also, it's now available in Bombay, so that's a very important thing, sir. But I have to say one thing, sir. I remember that one case of yours as well many years ago. We had a short bowel syndrome with a patient. After Anirudh was joined, our salvage rates have increased a lot, sir. Because like Dr. Davawala said, it's the DSA and the medical intervention which is much more important than the surgical aspect. We are just salvage surgeons now, sir. And when it comes to a intestinal transplant, sorry.
It's the same thing what he said. Normally when depends upon how much of the length of small bowel has been resected, and then we come to a state where it is called a short bowel syndrome, and a short bowel syndrome where patient's nutritional things are not, then he has lot of diarrheas, and then obviously if the medical management fails, you go for a small bowel transplant. Not an easy fact coming up now, but most important is short bowel syndrome, whether he is able to manage his nutrition part or no.
Yes, ma'am.
We saw a lot of salvage which our staff member also who had a severe mesenteric artery thrombosis and he did so well. Unfortunately, this was a young woman, just 40, and I think she came to you all
So that's what I told. As you see the pathophysiology, even if you are able to restore the ischemia part, even within appropriate time of 12 hours, in small intestine, the vasospasm of the arteries or the veins persist. Even though you have removed the embolus or you have removed the thrombus, the intestinal injury continues. Once the intestinal injury continues, it will cause infarct. And there is the time when these patients get prone to more and more infections. There will be bacterial translocations, although they will be on multiple antibiotics. But usually that's why the mortality rate is so high, for 50 to 60% mortality in acute setting.
Yeah, I would agree with that. And Dr. Susan, what you said, the first person was absolute. It wasn't a salvage. That guy's life is totally saved, and it is thanks to the. Sorry, I mean, I know it's your this, but it's thanks to the intervention which was given by the vascular surgeon. And about the second case, I'm not too sure about the Riles tube, ma'am, because I don't have the details of that case. But it could be contributory. Yes.
I would request Sandeep Shah sir to felicitate Dr. Sandeep Dawawala.
Sandeep to Sandeep, heart to heart.
There is a Thrombo trivia quiz next, so please be here around. Thank you very much, respected chairpersons.
I thought we had to wish you today.
Thank you. So, going over to the Thrombo Trivia Challenge. I think people are interested. The prize is a smartwatch. So, anyone who knows the right answer, first raise your hands and answer, please, to me. Let me start with the first question. Which anticoagulant was used as a rat poison before being used in oral anticoagulation? Anyone? Raise your hand, please. Yes, madam. Thank you. Right answer, madam. I would request Dr. Vijay Dalal, sir, to kindly congratulations, Dr. Sujamurthy, madam. So we break for tea now. 10 minutes, and we come back again for the second session. There will be more prizes for the audience in the middle. We'll keep that a secret when we'll be doing that. So we go on to the next session. I would request Dr. Prashant Parekh, Dr. Ashish Sharma, and Dr. Deepak Bharati to come on the stage as chairpersons. Yes, you can speak.
Hello. Am I audible?
Yes.
Okay. Fine. So next topic is management of DVT by Dr. Anirudh Bhuyan. So we'll be speaking on that. Then we have a lot of many thrombosis lectures on thrombosis, but we'll start with this DVT now.
Thank you. So nice to see you all in the second session of the CME. I'll be speaking to you about deep venous thrombosis. Let me start with the case presentation. Now this is a 28-year-old male who presented with bilateral lower limb swelling and pains in 7 days, with an increase of pains in 6 hours duration. And clinical examination showed a swollen leg, which was left more than the right, but the lower limb signals were quite good. Now this patient had a previous history of a catheter-directed thrombolysis done for the left leg earlier. And there was a filter placed and there was suction done, and this filter was removed after 2 months. The patient was not compliant on stockings, and the arterial Doppler, on the other hand, was completely normal. The venous Doppler showed an iliofemorodistal DVT, and the D dimer was markedly elevated. When we did the factor V Leiden, it was positive, but the protein S, on the other hand, was low. The patient was kept on antiplatelets, but patchy intake history was noted. A CT venogram showed an thrombosed infrarenal IVC with bilateral lower limb veins, which was acute on chronic in presentation. Now, I think most of you all get such a patient, you will first anticoagulate. But because the clot was from the IVC all the way down, we had to do an angio. We had to do a veno. So we entered from the left popliteal vein, actually in this case both. And once we went up, the guide wire basically was not going up. When we have a loop, the loop cuts through like cheese and butter through the clot and goes up. But it was not going up, meaning that there was a bit of chronic component which was present in this clot. The other side also was the same problem. The wire was looping, but it was not going up. However, we have catheters which are angled, through which we can try to go through the clot and through the thrombus, even through the chronic thrombus, and negotiate all the way up to the IVC. Once that was done, we did a pre-lysis IVC angio, which showed good amount of flow in the IVC. The thrombolysis was initiated with actylase, and this was done on both the sides, as you can see here. The entire IVC, which is laced with clots, is given actylase, and you can see the contrast of the actylase on both sides. And thrombolysis was initiated on both the sides. Then we go to day 2, which is aspiration and venoplasty of the clots. The angio showed an acute and chronic presentation, especially in the femoral artery, going into the IVC. The IVC had a tight occlusion. The left iliac veins which were there had a clot, and that clot was not allowing the blood to go up. So what we did, even on the right side when we did an angio, you find that there is a clot which is there here that is not allowing the flow to go or move up. We do something called as a thrombus aspiration. This is a catheter which is angled. We suck out the clots going all the way from top to bottom. And even then, there are a little bit of residual thrombi which are present in the vein. For these, we again aspirate, and the checked venogram gives very good and strong results. A right side angio also showed good results, but the main problem was there in the IVC. And the IVC, we normally keep it for last, because if we do the top first, there's a very high chance the clot can actually fly up into the lung and cause a pulmonary embolism. And in that, we did an IVC suction, as you can see in the image. And still there was a residual IVC stenosis, probably because of the barbs of the filter, which was there in the IVC. We did a balloon angioplasty for the same, and the IVC was completely opened up. The popliteal vein access was taken for the final angiogram, and that actually showed good outcomes. Now, DVT per se is a multifactorial management. You have a physician who has the patient, who manages the anticoagulation. You have us from the vascular side of things, where we remove the clot and we give a good outcome to the patient. And you should know what is a DVT and what is not a DVT. This is not a DVT. A swollen leg is not a DVT. Please investigate other problems for the same. On the other hand, this is also not a DVT. This is a venolymphatic malformation, which we treat and the patient becomes all right. So it's very important to note what is acute and what is subacute, as I told in my arterial lecture as well. In a subacute DVT or a chronic DVT, you do not tend to lyse. Lysis will only be in the 14-day duration, and that is recommended because then the clots basically don't come out. It is very important to know what a venous clot is, and when you remove these clots, the entire clot burden and the entire vein becomes free of clots, and the flow actually starts well. It's very important to know that we need to prevent these problems before they actually occur. So always mobilize the patient. When a patient is there in the hospital, in the ICU, please follow a proper physiotherapy of at least moving the joint. Tell the patient if you can't move the joint, at least move the foot. Even moving the foot causes a passive movement, and that emulates walking. And elastic bandages, yes, you have to use them for patients who are on long-term, who are highly morbid and who are on long-term bed rest. You have to give a class 1 stockings to them. Or even if you have the facility, you can use a DVT pump, which prevents any problems. I will not be boring you on anticoagulation because there is quite a few speakers have spoken about it already. But I would like to tell you that heparin is one of the mainstay of treating a DVT in a hospital setup. Because what heparin does is, it primarily acts on factor 2 and factor 10, and that helps in, and it is reversible. So you start heparin, you can always stop it, 90 minutes, the half-life is gone, and you can take the patient for surgery in the next 6 hours. So using heparin is very important because you need to know that when you're giving heparin, you have to maintain something called as an APTT. And that APTT should be between 45 and 60. That is 1.5 to 2 times of the normal range, where 30 is normally considered to be standard. Always to note is heparin-induced thrombocytopenia, where a patient, you start heparin and the platelets fall. That is where direct thrombin inhibitors are useful, like dabigatran, argatroban, bivalirudin. LMWH, on the other hand, has better bioavailability. You can give a LMWH and be rest assured for 12 hours that the LMWH is in the system. And it does not require any laboratory monitoring like heparin does. And it has been used safely in a lot of patients till date. Prophylaxis is very important. You have something called as pharmacomechanical prophylaxis, where mechanical is more of a compression, pharmacological is with LMWH or heparin. And as I said earlier, APDT is considered to be the most sensitive test for heparin activity. Warfarin, on the other hand, as we had the trivia challenge, is derived from a rodenticide. And warfarin inhibits quite a lot of factors, but mainly you need to know that it inhibits protein C, protein S, factor 5 and factor 8, because of which initially if you start warfarin, you have to overlap. And if you don't, then you are in a prothrombotic state in the first 48 to 72 hours. And I would also like to mention about DOACs because they are quite commonly used nowadays. There are multiple DOACs available like dabigatran, apixaban, edoxaban, which is not in India and rivaroxaban. And it's important to know its reversal because you know that dabigatran has adarucizumab, whereas andexanet alpha, which is there for factor 10 antagonists, are not available in India. So the other option is a prothrombin complex concentrate. We should give it primarily for DVT patients who have good renal function, good hepatic function, but the patient does not maintain a good INR because they may be poorly adherent. They might have renal dysfunction. So then you do not give any NOACs. So basically I'll come to the main topic of mine. How do I treat the DVT? This DVT should not be treated, should not be operated If, for example, the patient has an uncorrectable anatomy, that means you have multiple collateral channels, the main channel is also blocked, you don't need to treat it, because then what happens is the collaterals are taking the flow and you don't need to correct the main channel which is blocked. If the patient has an ineffective calf pump or a frozen ankle, the patient will tend to get a clot again. So that is when you don't treat it. And if the patient has a permanent muscular deficit where he may or may not walk, then medical management is much better than surgical treatment. In terms of surgery, the age-old method was to do a thrombectomy. So basically, because of the valves, the clot is not removed from down, the clot is removed from top. And you milk the entire clot from the calf all the way till the groin, and the clot is removed from the femoral vein and not the distal part. In an artery, on the other hand, the clot is removed from down, the lowest part of the clot, not the highest part of the clot. There are other methods which are available. This is a Inari flow retriever where it's a stent which is put in the artery, and that stent retrieves the clot. So they are called stent retrievers. It could also be bypassed in cases where the uncorrectable anatomy is quite bad and you require to bypass that blocked vessel. Next to note is an IVC filter. The filters are now pretty well commonly used, but it should not be used for all cases. It's very simple to put it. You can put from the jugular root or the femoral root, and as you keep on deploying, it's a sheathed device which you just pull out the sheath and the filter just opens up like that. But the problem with the filter is retrieval. Many of the patients don't retrieve their filters, and when the retrieval does not happen, the filter clots, and the filter itself is the cause of the DVT. And even when you try to open up the filters which are blocked and try to get a flow going through it, it is quite difficult, and the results are normally not very encouraging. So as you can see here, the entire diameter of the vein is about 18 to 20 millimeters, but the filter, the zone which you have opened, is hardly about 6 millimeter. So that won't last long in such patients. The other problem of a filter is incorrect deployment. So you technically have filters which are jutting out of the IVC, probably poking the aorta, and that is when you need to cut the IVC and remove the filter off. So how do you retrieve the filter? The main thing is filter should be retrieved within 14 days to 3 months of putting the filter. We take a gooseneck snare, we just go on the hook, we pull it, and we pull the filter out into the sheath. So this is how we lasso it like a cowboy, literally. And many a times it gives us, it is not very simple, because sometimes the angle of the filter may be tilted or incorporated in the vessel wall. And that is where sometimes we need to use bronchoscopy forceps to crush the platinum tipped wire which is on the side. This is what it looks when a filter comes out. You can see the tips having a lot of vein wall, and many a times the vein ruptures. So you should always be prepared for putting a covered stent once you put a filter. So the indications of a filter is very clear. When you can't anticoagulate, when you have a complication of anticoagulation, and you have an inability to achieve therapeutic anticoagulation, only then you put a filter. You do not put a filter in every DVT patient. Okay, even if the DVT is there in the common iliac vein, the external iliac vein, common femoral vein, the patient does not require a filter. The location and the anatomy of putting a filter for DVT is a floating thrombus in the IVC, or if the patient has got a pulmonary embolism, even with the anticoagulation, you put in a filter with an inability to anticoagulate. The contraindications are a blocked vein, chronically occluded vena cava, multiple vena caval abnormalities, and inability to access the vena cava. So all anatomical problems, you do not put a filter in. What do you do for chronic blocks? Basically, patients who are having a completely blocked vein. You do something called as a Palmer-Dale procedure, which is a veno-venous bypass, in which you take the GSV from one side, you put it across the pubic area, and put it on the vein on the other side. So what happens is the vein supplies into the shunt, goes through the pelvic area, and then goes up. So this was one of the patients we did in the hospital. And the good thing is that this is, I think the audio is not coming, but the flow is quite good in the vein. So the clinical learning data is that normally Palmer-Dale or any vein or any graft, there is a good patency rate. The problem with stents are that we should not stent in the problem. We should stent from normal to normal. And that is where the stent patency actually works well. So if, for example, the patient has a bad inflow, that is, the femoral vein is blocked, the popliteal vein is blocked, and there is complete blockage of the iliac vein. And now if you go and put a stent in the iliac vein, because there is no inflow, there will be no outflow into the vein, and the stent will get occluded. So the basic principle is we stent from normal to normal. And if we do a good procedure, the iliac vein stent patency is as high as 66% even in 3 years' time. This just a slide for Dr. Prajay as well. We do a lot of pulmonary embolisms where we do lysis, and it gives beautiful results when you do a pulmonary lysis. So I would like to end my talk by saying not all limbs are created equally, and not all DVTs happen equally. So we have to know that every DVT is different, every limb is different, and every way the patient responds is different. Many a times we had patients who, we did a lysis, the patient developed an anaphylactic reaction. One patient we did a lysis, the patient developed a bleeding. The patient can have a stroke as well because of the lysis. So you have to cater your treatment of DVT based on the patient parameters. Thank you all. Let's continue saving our vessels.
Dr. Anirudh, what is the cost of this IVC filter in our hospital?
50,000, 50 plus GST, 60.
60. And there is a total procedure cost?
No, that is the cost of the filter itself.
Okay.
The procedure cost in a general ward comes to around 75 to 80,000.
Okay. And suppose what if the indication is that the patient cannot be anticoagulated and you have to be persistent, how do we do it? You have to remove the IVC filter in 3 months.
Yes.
So what do we do after that?
What happens is if you can't anticoagulate, then the IVC filter remains in for life.
For life?
For life.
Okay.
And if there is, the indications are very clear.
Okay.
So if you can't anticoagulate, you have to continue the IVC filter for life. But the IVC filter becomes the part of your body, of your vein, after 3 months. So normally retrievals are not attempted after 1 year.
Okay. Okay. Thank you.
Infrarenal. Yes, sir.
What is the scope of having a biodegradable filter?
There is a lot of scope. So even the stents are coming nowadays, but nobody has yet manufactured it.
Why don't you do something?
No, the problem is that whenever there is a filter, there is a lot of additions which happen in the vein. So even if it is biodegradable, unless the flow is good, the filter is an obstruction device. It's not a stent. A stent is a scaffold around the vessel. The filter is bang in the middle. So even if it degrades, it's just going to embolize on top. Yeah. So I think, thank you.
Yeah, thank you very much. Yeah, next, hello. Next is Dr. Shilpa Gupta. She is covering optimizing anticoagulation and diagnostic. Dr. Shilpa, madam.
अश्विन अश्विन उधर से खोलना, उधर से अगर खुलता है तो। Shilpa madam. It is shared as Google slide below. PPT है क्या? Go to the next topic. Go to the next topic. I think we have time for one more thrombo trivia question till the things get sorted out. Yeah, so anyone can raise their hand and answer. What is the antidote for a DOAC such as dabigatran? Yeah, perfect, correct. Dalal sir, can you? Dr. Sheldon, who is awarded the thrombo trivia. We'll play the last round just after the lunch. It's available. It's available free of cost by Pfizer. They have stopped giving it now after the generic dabigatrans are now available. No, not very frequently. Yeah, FFPs work.
Are the slides seen?
Yeah. So what we will play here, we will play.
Okay. Good morning, everyone. Thank you, Dr. Anirudh. Thank you, Holy Spirit Hospital, for arranging this beautiful session. So in the next 15 minutes or so, I would, the topic that has been assigned to me is to talk about how to investigate cases of thrombosis, how to do a thrombophilia workup, and which oral anticoagulations can be prescribed to these patients. So, what exactly is thrombophilia? So, thrombophilia is a general term. It is used to describe any hereditary or any acquired conditions which predispose to clot. So, this is a tabular form, hereditary versus
It's a PDF.
It's not synced. This is not synced. This is not moving. So I'll have to tell you to move to the next slide. So I'm on this slide. Okay. Okay, so right now I am on slide number. I can't see. Slide 5. Can you put? Yeah. So, sorry for this technical glitch. So we can see thrombophilia can be divided into two categories: hereditary thrombophilic disorders and acquired thrombophilic disorders. So hereditary includes these gamut of disorders which are factor V laden, prothrombin gene variant, protein CS deficiency, antithrombin 3 deficiency. Acquired can be antiphospholipid syndrome, PNH, myeloproliferative neoplasm, JAK2 mutations in absence of a myeloproliferative phenotype, and pregnancy. Pregnancy itself is considered as a
दूसरा HDMI देना होगा HDMI छोटा वाला HDMI
एक सेकंड मुझे देंगे I'll sort it out
पकड़ के छोड़ रहा है यहाँ से
एक
ये निकाला था आपने किसी ने निकाला था तभी तभी तो दिक्कत
नहीं चल रहा था ना लूज हुआ था इसको निकाल के लगाया था उन्होंने
We are having an Apple versus Windows problem, so we are just settling that off.
ये छोटा हो जाएगा
हाँ चलेगा हम छोटा
चलो
If you could restart again, madam, the entire.
I'll start from beginning. Okay. So what is thrombophilia? It is a general term which is used to describe hereditary or acquired conditions which cause increased predisposition to clotting. So there can be hereditary or acquired causes. We saw hereditary causes could be any of these: factor V, prothrombin, protein CS deficiency, antithrombin 3 deficiency, antiphospholipid antibody syndrome, PNH, myeloproliferative neoplasms with JAK2 mutations without without having an MPN-like presentation, or pregnancy, which is a hypercoagulable state due to physiological changes in the coagulation and fibrinolytic system, which will be covered in detail by Susan ma'am. So most of my slides I have derived through these guidelines. The British Society of Hematology guidelines. It was published in 2022 in BJH. So I'll first focus on the hereditary causes of thrombophilia. So basically anticoagulant deficiency, most commonly protein CS, and antithrombin 3 deficiency are established as the increased risks of venous thromboembolism. The degree of this deficiency is variable, and in general the thrombosis risk rises. Thrombosis risk rises as soon as the levels of protein C or S or antithrombin 3 fall from below the normal range. To basically find out which particular genotype is causing the antithrombin 3 or these three deficiency of the natural anticoagulants, it's not always necessary unless it influences the change of our management. So always, this is a very particularly important statement. The testing for the deficiency of these physiological anticoagulants should be performed only after 3 months of anticoagulation for acute thrombosis. Why? So because this is the way we collect it, I'll just come to this slide again. But yeah, so why do we perform these tests later on? Because there are other causes of reduction of all the 3 natural anticoagulants. Basically, if the patient is on vitamin K antagonists, if they have any of these basically if they have any of these, patient has come in sepsis, DIC, or has had recent thrombosis. Ani, I understood. So what can I do? I don't know. I have not done why all these technical glitches are happening. So recent thrombosis, sepsis, OC pills if the patient has taken. So basically when patient is presenting with an acute episode of thrombosis, these levels are bound to come low. They have been used up naturally in the physiological processes of anticoagulation. So they will come low, and it may give us a false negative assessment that this may be the reason why the patient has clotted. So we should not ideally do these particular levels during the acute episode of DVT or PTE, or for that matter any unusual site thrombosis also. So we'll go to the previous one, the slide prior to that. The previous slide, not next, the previous one, prior to the, yeah. So protein CS activity should be collected by collecting in a citrate sample. The plasma is frozen in alicot, stored at -80 degrees Celsius. It has to be frozen within 4 hours of collection. The patient should discontinue warfarin for at least 2 weeks before withdrawing the sample. So again, this is a practical point. When we want to actually test the patients for any hereditary thrombophilic disorder pertaining to protein C S antigen, we should ask the patients to stop warfarin for at least 2 weeks. So even when the patient comes on OPD basis, we do not first thing evaluate them immediately in the acute setting. Secondly, we evaluate them after they have completed the course of anticoagulation, and that too stopping the anticoagulation for at least 2 weeks, especially if the patient has been on warfarin. So yeah. Yeah, now the third, the procoagulant other factors which are factor V, these are the genetic disorders, factor V laden and prothrombin gene mutations. There are certain other genetic variants like MTHFR gene mutations, SERPINE, and factor 13 related mutations. But what is important to know here is that they should not be included in the thrombophilia panels at present. This is as per the recommendation by the British Society of Hematology, because they do not let's try to understand the logic here. So patient who comes to us, many a times, if we have we decide on the basis of provoked versus unprovoked DVT. If the patient has an unprovoked DVT, the guidelines as per ASH or British Society of Hematology are that we need to continue for a long duration of anticoagulation. So as it is, if we test these particular genetic mutations, are they going to change my management? Am I going to give this patient a longer anticoagulation, or the treatment, the anticoagulation duration is going to remain the same? So there are, I will be coming to that, there are certain indications where we need to do these genetic mutations, but they are not recommended as of now to predict the first episode of venous thrombosis, or they are not included in the thrombophilia panels also as of now. So there are certain procoagulants, like the procoagulants which we saw in the intrinsic and the extrinsic pathway. So there are studies to suggest that increase in these levels may increase the risk of thrombosis. But when correction for age, sex and other factors were done, it was found that only factor 8 remains more than 95th centile. It has a significant 16 times impact on the increase is having an impact on the clotting of in the thrombophilia workup. So as it is, we do not check for these particular factors, to excess of which may or may not cause thrombophilia risk. Now, the commercially available thrombophilia profile to us includes all these things. So this is the maxi profile which we have. Like usually we send these practical, I'll just say to the, we usually outsource these from our institute. So most of the labs, they offer protein CS activity and thrombin 3 activity, lupus anticoagulant, homocysteine, ACLA, APLA, and activated protein C resistance. So all these factors are there, out of which if we do a mini profile, which may not be the ideal scenario to send. Basically we have two profiles. I'll just talk practical aspect here. There are two profiles, mini profile and maxi profile. So many times we get a call which profile to send from the lab. So mini profile has only protein CS activity, homocysteine level, they have antithrombin 3, it has a ACL, anti-cardiolipin antibodies. It does not have the rest. So when we are testing for only these particular subsets, we are not doing a complete profile. We are not coming to know the reasons why we are doing the thrombophilia workup is first thing to find out whether the patient has an underlying antiphospholipid antibody syndrome. Alone anticardiolipin antibody may not be a complete judge for the patient having it. Lupus anticoagulant and presence of antiphospholipid antibody, all three if comes positive forms a entity called as triple positive APLA, which is again a very distinct entity and has a distinct management. So recommendation goes to perform full thrombophilia workup rather than going for a mini profile, which may not give you a adequate measurement. If you have done for a follow-up, maybe you can ask for a mini profile, which is almost half the cost. So now let's talk about the acquired genetic traits, PNH and myeloproliferative neoplasm. PNH, it is an acquired clonal stem cell disorder affecting the PIGA gene mutation, in which there is absence of CD55, CD59 on the cell surface. So absence of CD59 leads to complement activation, and it results into the classical features of intravascular hemolysis and thrombosis. Now this clone, the amount of this clone, the percentage which is there, if this clone, but absent clone, which is, if it is the percentage is more than 50%, then the 10-year, the cumulative 10-year incidence is 34.5. If it is less than 50%, it falls to as low as 5.3%. So we get a lot of patients who are in between this range, who present with PNH. When it progresses, it presents like a hypoplastic anemia. So we get a lot of patients between the range of 1 to 10%. They do not carry the risk of thrombosis. Only when the patients have a percentage of this particular clone more than 50% will they have a risk of thrombosis. Myeloproliferative neoplasm, it is a gamut of 3 diseases, polycythemia vera, essential thrombocythemia, and primary myelofibrosis. It may or may not be associated with JAK2 mutation. There are four common mutations: JAK2 mutation, which is on exon 14, JAK2 mutation on exon 12, and CALR mutation and MPL mutation. So now the aspect about this particular JAK2 mutation, when there are thrombosis of unusual sites. What are unusual sites and what are usual sites? Usual sites are DVT, PTE. These are considered as usual sites. Unusual sites are CVST, cortical sinus thrombosis, or splanchnic vein thrombosis. If patient presents with unusual site thrombosis, even with a normal CBC, we should consider doing a JAK2, especially in a younger patient. So these are these are the studies in the next slide. Yeah. So about 3 to 6% of these patients had JAK2 mutated with a normal full blood count. So this is quite a significant number. There are studies of as big as 152 patients, which shows, I mean, we should not obviously miss these patients. So because they have a tendency to progress into myelofibrosis or acute leukemia at a later date. So what are the recommendations now? We suggest that a PNH patient with thrombosis at unusual sites and abnormal hematological parameters should undergo testing for PNH. MPN panel should be done for patients with thrombosis at unusual sites, even with a full blood count, with or without a full blood count abnormality. What are the acquired non-genetic traits? The main disease which is there in acquired non-genetic cause of thrombophilia is antiphospholipid antibody syndrome. It is dependent on at least one feature of one clinical feature, thrombosis or pregnancy morbidity, and at least one of the laboratory features amongst the ones which we listed earlier should be present. If of three, a positive lupus anticoagulant is quite strongly associated with recurrent thrombosis. But individuals who are positive for all three are called as triple positives, and they have the highest risk of thrombosis. So I think I just touched upon this provoked and unprovoked DVT. So unprovoked DVT, there is in the patients with thrombotic antiphospholipid, uncertainties remains as to the recurrence risk. So initially, if there is initial unprovoked compared to provoked, if we have a provocative factor like a surgery, then these patients, as compared to the provoked, the unprovoked will have a greater risk of recurrence, because it is quite logical that if you remove the provocative factor, the chances that the patient may not clot is less. I mean, patient may clot is less. What is catastrophic APLA, which is potential, but it is a rare disorder. It is characterized by sudden extensive microvascular thrombosis leading to multi-organ dysfunction, more commonly seen with triple positive APS. So what are the recommendations? Recommendations follow that antiphospholipid antibody screening should be done following unprovoked venous thromboembolism, because this may alter the management and including the choice of antithrombotic therapy, which we'll be seeing later. Screening of antiphospholipid antibody is suggested in the venous thromboembolism patients provoked by minor risk factor, again as it may alter the management of antithrombotic therapy. Patients with acute multiple thrombotic events and evidence of organ failure should be tested for antiphospholipid antibody. And as it is an acquired thrombophilia, screening for an antibody, screening the family members for these antiphospholipid antibodies is not recommended. So what are the general guidelines? We'll just sum it up. So in situations where the clinical utility of this testing is not clear, testing is clearly not mandatory. How do you define clinical utility? It is the ability of the test to improve the clinical outcome. So whether this will change in future, when do you test for thrombophilia, whether when you are expecting the recurrence risk is high, or it may affect the family member, decisions with regards to the family members. So that is when we test for thrombophilia. Next. So there are conflicting data whether we should test for factor V Leiden or prothrombin variants. So it was seen that for when we adjust for the age, sex and periods of anticoagulation, the 3-year follow-up, neither the factor V Leiden nor the prothrombin mutation was associated with the recurrent thromboembolism as compared to the controls. A next one. A meta-analysis of the antithrombin 3 deficiency patients also found that there was an increase 2 to 4-fold increase in absolute annual risk with the long-term anticoagulant therapy. Overall, the recurrence risk is determined by the clinical situation, that is whether the clotting episode was a provoked versus unprovoked, or other risk factors such as BMI and age, rather than the inherited thrombophilia panel. So when do you test the first degree relatives? When the patient is known to have a hereditary thrombophilic tendency, you test this first degree relatives if they have a high penetrant deficiencies in a woman of childbearing age. Because yes, this is something which will alter the management and will help us decide about the prophylactic anticoagulation during pregnancy. Previous one only, please. Oh, I think you should pay attention. Yeah, I was not done with that slide, and you just changed it on your own. Please go back 2 slides up. Yeah. So the influence of family history on thrombosis, thrombophilia testing, and risk of thrombosis is related to estrogen progesterone content of therapies should be discussed with all women to determine whether they will clearly alter their therapy choices and should be documented clearly. Now, testing for heritable thrombophilia traits after a venous thrombotic event is not recommended as a routine guide to management. We do not offer routine thrombophilia testing to first degree relatives, and selected testings for the patients with protein C and S thrombin deficiency, where this may influence the management and life choices depending upon the personal circumstances. You're changing my slides here, or you're changing the slides there? मैंने कुछ भी नहीं किया इसमें. Yeah, that's what I don't understand, because I've not moved any slides even on this laptop. Okay, so now, okay. This next slide this is actually coming in a PDF, right? Yeah, so again. So this slide was actually presented in the morning by Dr. Nadeem, which showed the different ways of action of oral anticoagulants. There are various categories of oral anticoagulants that we have. I didn't change, नहीं, मैंने कुछ भी नहीं किया है. मैं तो वही करने का कोशिश कर रही हूँ, पर वो अपने आप चेंज हो रहा है.
अभी मैंने नहीं किया मैम, तो आप भी ऐसे करो.
It breaks our chain of thought, sorry. It does. So, vitamin K antagonists, it acts on the extrinsic pathway, 2, 7, 9, 10 factors, and also on the natural anticoagulants that we discussed, protein C and S. So, amongst the PG students, can somebody tell me what is the significance of this? Can I ask a question, Dr. Anirudh? So, factor 2, 7, 9, 10, and what is the significance of it acting even on anticoagulant proteins? Warfarin, when it acts on anticoagulant proteins, what is, I mean, why, can anybody, I mean, just take the mic. Only the PG students, not the consultants. Why? Yeah. Yes, so what do you do for that? I mean, how do you prevent that? Bridging therapy, yeah. So very nice. So this is what it is important. So in many cases of unprovoked, even when you, I mean, we discussed this in the previous one, that in in acute thrombotic settings, we cannot test. We cannot test for protein CS and it may come low. So in all the cases, it is always better to bridge. So as a default setting, we should be not be directly starting the vitamin K antagonists for this particular reason, because they decrease even the protein natural anticoagulants. So the other set of anticoagulants are the factor 10A inhibitors and direct thrombin inhibitors, which is dabigatran, and factor 10A are the other like rivaroxaban, apixaban and edoxaban. This was actually a chart. This has come in a PDF format, but I wanted to show this chart behind this. Maybe I'll share the PPT later on. This is depicting the various pharmacological, pharmacokinetic and differences between the vitamin K antagonists and the NOACs. So what the crux of this is that it has the half-life of warfarin is way high as compared to the other NOACs, which have half-life of not more than 8 to 10 hours. And interactions are many in warfarin as compared to other NOACs, which have lesser interactions. So, so anticoagulation therapy should be based upon the risks, benefits and pharmacological characteristics, and in-depth knowledge is needed of the pharmacological properties before actually prescribing. So why these NOACs have become important and why they are becoming popular is because they have more efficacy, they have consistent dosing, they have they do not require any monitoring like the PT-INR monitoring in warfarin, they have fewer drug interactions and lower risk of adverse side effects. So what are the FDA approved indications of DOACs? These are stroke prevention in non-valvular AF, prevention of thromboembolism after total knee replacement or a total hip replacement, treatment of DVT and PTE, prevention of recurrent DVT and PTE, treatment of heparin-induced thrombocytopenia. We have seen in the previous sessions how this is useful. Also, there are some off-label indications like cancer-associated thrombosis, especially the role of apixaban is coming up very much in this particular indication. Prevention of thromboembolism in hospitalized acute medically ill patients and in PCI after NWAVE. When do we use warfarin? So warfarin, these are few indications where warfarin holds a fort as compared to DOACs. APLA syndrome, severe renal impairment, severe hepatic impairment, mitral stenosis, prosthetic valve, high body weight, changes in gastrointestinal anatomy causing high increased risk of GI bleed, pulmonary arterial hypertension, or in left ventricular thrombosis. So these are few of the studies which have clearly established the role of warfarin as compared to the DOACs. So particularly in triple positive APLA. I will just go fast through this, and it was clearly seen that even after a follow-up, these patients, this trial was stopped early because of the extreme side effects related to, there were multiple thromboembolic events. They were significantly more frequent in the patients who had continued DOACs. So this is a clear indication where we should be using warfarin. So other things that in addition to patient hydroxychloroquine was suggested to be an important role in reducing the APL titers in these patients. Why is this happening? Because still we don't have clear answers to that. It may be due to poor adherence, insufficient drug concentration, or a different mechanism of action with respect to warfarin. Now, in mechanical valves also, this was a realigned study which showed that patients should avoid DOACs. The same thing, again, this was a significant finding that in a PROACT study, it was found that there was the combination of a standard dose warfarin along with a low dose of aspirin is associated with a better bleed to clot risk. I mean, the amount of the INRs was safely maintained, and the risk of bleeding was pretty low in these patients. So combining warfarin and low dose aspirin is the to-go thing in aortic wall replacement. Again, there is for patients who are at high risk of GI bleeding, warfarin is preferred over any of the NOACs. So
Ma'am, can you sum
take-home
up?
messages.
We are running late. Little.
Yes, sir. So these are this is last slide, which is the clinical utility of the test should be ascertained before ordering investigations, and testing for APLA is recommended. It can change the choice of anticoagulation, and it should be the therapy selection should be guided by risks, benefits, and pharmacological characteristics of each agent for each patient. So thank you, everyone. I'll leave you all with this message.
Thank you, Dr. Shilpa, for the wonderful lecture. Can we take the questions later because we are running short of time?
Dr. Shilpa, madam, a token of gratitude from Dr. Ashish Sharma. Thank you, chairpersons. Sir.
Okay, thank you.
So we move on with the next session. I would request the following chairpersons to come. Yeah. Dr. Kevin Quadras, I think, is not available. Dr. Shampa, madam, Dr. Shampa Brahmachari, and Dr. Manish Arya. So this will be the last session before lunch. We'll be taking the ACS and the pulmonary embolism post-lunch.
Hi. So we changed the gear a bit. So this is one area. Sorry. So Dr. Susan will be talking about thrombosis in pregnancy. And this is one section of patient where most of the physicians are a bit scared. I must confess that. So madam will be talking about thrombosis in pregnancy. Susan, madam.
Everyone's got to be asleep now. Or 2.5. Oh God, this looks like a very interesting and a very intelligent audience. Another quick question. What should be the preferred heparin if you have a case of a pulmonary embolism? Would you want to use unfractionated heparin, or would you want to use your low molecular weight heparin? Show of hands for the first one. Okay. This is the case which is very interesting. She was a young girl who was 24, first pregnancy, traveling down to Mumbai for her delivery, and she had a flight from London to Bombay. Her BMI was normal, her BMI was 24. And when she arrived in Bombay, she noticed that she had a swelling, a painful swelling of the left leg. The swelling and the pain didn't get relieved with a little rest and analgesics, so she showed up at the hospital. And over here, given the fact that she had a unilateral swelling of the leg, it made us suspicious that she had a deep vein thrombosis. We did a color Doppler and it proved that she had a thrombosis of the femoral vein. She was then sent across to our colleagues in the surgical department and vascular surgery, who immediately helped her, and the medical department put her on low molecular weight heparin. She was also fitted with an IVC filter. She was taken consent for the radiation exposure given the fact that she was pregnant, but she was in her second trimester of pregnancy, and she was diagnosed to have a protein S deficiency. She took the low molecular weight heparin throughout her pregnancy. The swelling and the pain of her leg subsided and she was a lot better. Given the fact that she was on anticoagulants, we decided to do an induced labor which could give us time to stop the anticoagulation and then deliver her. Once her Bishop's score was favorable, we induced her labor. She went through a very uneventful labor and delivery, had an episiotomy. She had no bleeding from the uterus, which was expected given the fact that usually we don't have bleeding from the uterus when you have a problem with the coagulation or a person on anticoagulants. But even her episiotomy gave us no trouble. She was discharged very soon after, and she was put again on low molecular weight heparin for the next 6 weeks. As Dr. Anirudh had described earlier, the putting in of the filter looks an easy job, the removal is more challenging, and so also in this patient, it was challenging to remove the IVC filter. Given the fact that the woman was pregnant, it upped her chances of having a thrombosis, because Mother Nature has made it such that every pregnant woman near term has about 600 ml of blood flowing through that uterus. To stop life-threatening hemorrhage, both the uterine vasculature and your own coagulation system has to be revved up to stop bleeding. And the Furkow's triangle tells us that pregnancy is a hypercoagulable state. There's venous stasis, there's vascular damage, so it ups any pregnant woman's chance of having a coagulation. Most people think of pregnancy in the late second trimester and third trimester. But any woman, as early as a missed period, ups her chances of having a coagulation disorder, given the fact that the coagulation profile changes early in the pregnancy. That's one thing to be remembered. And if you have a couple of things in your history, such as a past history of a VTE, a family member who has had VTE, you're over age 30, which is very commonplace these days, your BMI is over 30, which is again very commonplace these days, immobility for some reason, a cesarean delivery, air travel like this patient, and a presence of a acquired or inherited thrombophilia ups your chances several fold of having a VTE. Now, what about a VTE? You can have a painful limb, you can have swelling, but 13% of women who will have a VTE or pulmonary embolism will die of it. And a child in utero whose mother has a pulmonary embolism will also not survive. So that's the importance of preventing coagulation problems during pregnancy. Now, if you get through with it, but you still have had a deep vein thrombosis, you may have the sequelae of it, of a thrombotic limb, such as constant pain, leg ulceration, swelling, which may last many years to come after that. Now, people who are put on anticoagulants, usually any of those low molecular weight heparins and heparin doesn't cross the placenta. But if a mother has a bleeding episode and has hypoxia, the child can suffer damage. A mother who's been on warfarin for some reason in the first trimester, that child has a 30% chance of having teratogenicity, such as stippling of the long bones, nasal hypoplasia, as well as phocomelia. Now, this has been shown time and again from morning. However, I have to say this, that when I take a round, sometimes I'm rounding in the critical care, this is such a yin and yang of the coagulation cascade. I had seen a young man, and he had a known von Willebrand's disease. He had a trivial fall and developed a subdural hematoma and required factor VIII urgently to save his life. And then the next cabin, there was another man with a thrombophilia, and he had thrombosis, he had a stroke, as well as he had a DVT and required surgery for his problems. So this is the yin and yang, and it's so important to keep this coagulation cascade in mind when one's treating a thrombotic phenomenon. Now, what happens about a thrombotic event in a leg? 90% of it in the left leg. Clinical features are very important. The Homan sign, which is the dorsiflexion of the leg, of the foot, which causes pain below the knee, is the sign that you elicit to develop, to clinically diagnose deep vein thrombosis of the leg. And Moses' sign, where there's pressure given in the calf muscle, is another clinical sign. You confirm your diagnosis usually by a color Doppler examination. It's important to repeat the color Doppler examination if there's a strong, it's a negative test, but there continues to be a strong clinical suspicion. You repeat the test 3 days later or 7 days later. Dr. Shampa will agree with me. These are the signs that you see sometimes on the color Doppler. You will see the thrombus. You will see no flow. You will see a dilated vein sometimes. And sometimes there's a combination of all these which will make you confirm your diagnosis on the color Doppler. Now, this is what we talked about, the mother having a thrombotic event. But today, as gynecologists, we know that recurrent pregnancy losses are so often caused by thrombosis that happens in utero. And if a woman has a repeated pregnancy loss, especially somewhere between the 7th week and the 14th week of pregnancy, she's pregnant, she's continuing the pregnancy well, you see the heartbeat, and somewhere around 7, 8, 9 weeks of pregnancy, you have a disappearance of heartbeat, and that happens once, twice, 3 times, you can almost be sure that she has an APLA syndrome. Any woman who has an unexplained fetal growth restriction, you know she has no hypertension, you've done tests to see that she has no malnutrition, you're doing all the other tests to find out what could be possibly the cause, it's quite likely her mother has a hypercoagulable state. Early onset gestational hypertension, like I had a patient a week ago, where she was doing well right up to about 29 weeks, then she suddenly developed very high blood pressure. Going back to her family history, her mother had a stroke in her 50s. And she developed hypertension, which was 170, 120. We had to terminate the pregnancy quickly, basically to save the life of the mother. Also, unexplained intrauterine fetal deaths have to be investigated for the mother having a coagulopathy. The laboratory investigations we usually ask in these women are these following investigations, which have been told to you all before. And we usually do a mini thrombophilia screening for protein S, protein C, the antithrombin levels, the factor V laden mutation, and the homocysteine levels. The treatments of thrombophilia are low molecular weight heparins. Often aspirin is given, but aspirin has nothing to really to do to prevent the coagulation cascade. But in the longest clinical trials, the WASP trial, it was found that those women who were given low-dose aspirin, they had a better fetoplacental circulation because the remolding of the spiral arterioles as well as the thrombotic events that happened at the level of the spiral arterioles were prevented by giving low-dose aspirin early in the pregnancy and continued most often till about the 8th month of pregnancy. Unfractionated heparin is very rarely given unless the thrombotic event is very close to the delivery date. And warfarin can be prescribed in the 2nd trimester of pregnancy. In the large study done by Nobel et al. In 2005, it was proven that those women who were given both low-dose aspirin as well as low molecular weight heparin had pregnancy outcomes and beneficial effects during their pregnancy, less complications, and live birth rates almost to the tune of 76.5%. Now, I remember this patient who had a cesarean section for non-progressive labor. She was a nurse from a hospital in Mumbai itself. And on the 3rd day, she complained of a very, very severe headache. And we thought the usual. She had a post-spinal headache. We gave her fluids. We gave her analgesics. We told her to lie down without a pillow. It didn't get better, so we called the anesthetist in. Sphenosplanetline block was given. And a little while later, when we realized that her headache was a little more severe than what clinically was expected, we did a CT scan which showed a superior sagittal vein thrombosis. And she had to be put on low molecular weight heparin for the next 6 weeks after that. She did subside. And quite often when you have a headache, you know, you have to rule out other causes which happen in young mothers, such as sleep deprivation, sinusitis, migraine headaches, and of course our common post-spinal headaches. Now, this is our dreaded complication during pregnancy and after, the pulmonary embolism, which can cause symptoms such as dyspnea, which gradually increases. You can get pleuritic pains, which appear like an infection, but keeps on increasing. The clinical needle of suspicion has to be high to diagnose these patients early and put them on the appropriate treatment. You have submassive pulmonary embolisms, which present as dyspnea. The arterial blood gases show that they have, a hypoxic, they have raised the JVP, and there's right ventricular strain patterns. And of course, the unfortunate women who have these massive PE, it's like you just complain of breathlessness and you drop dead almost. So those are the frightening cases that you sometimes have to deal with during coagulation problems. Confirmation is usually done by a CT scan, and the other ECGs and all will give you the strain patterns that you have. In case of a massive PE, it has to be multidisciplinary with unfractionated heparins given. Thrombolytic drugs are common given for this very serious medical emergencies. And quite often, a thoracotomy with surgical embolectomy has to be done as a life-saving measure for these patients. Now, having said what can happen during a hypercoagulation state during pregnancy, what can be done to prevent? One is to always recognize that pregnancy is a high-risk state. Do not hesitate to give prophylaxis to those women who are high risk. Early mobilization, whenever patients have surgery, or some people who are put into bed rest for preterm labor, they should be taught exercises which keep the limb movements even when they are taking bed rest. And they require to take this prophylaxis not only antenatally, but for at least 6 weeks in the postpartum period. These are the different methods available for the thrombolysis. One is unfractionated heparin, low molecular weight, warfarin. You have your thrombolytic agents for acute medical emergencies. And of course, preventive measures such as DVT stockings during surgery or bed rest, and sequential compression devices should be used whenever necessary. These are the list of tests that you should do prior to coagulation, but it's said that a thrombophilia screening is not recommended. Now, the differences between unfractionated heparin and low molecular weight heparin is basically the molecular weight. Even if you're vegetarian and you require anticoagulation, you're going to be non-vegetarian because it's made from the lung of cows and sheep, or it's made from the gut of pigs. So you're vegetarian, but you have to save your life, you better take your heparin the way it is. Both of them, fortunately, do not cross the placenta. They act slightly differently. One acts at the level of the antithrombin 3 and factor and inhibition of thrombin, and factor 10A to an extent, while the low molecular weight heparin is mostly at the inhibition of factor 10A. Low molecular weight heparin has the advantage of longer half-life and bioavailability. The other advantages are you can self-give the injection at home, it's subcutaneous. Regular labs are not required for its continuity of treatment. It's convenience, once or twice a day dosing. You don't really have dose escalations except when you've started taking it early in pregnancy, given the fact that the body mass index as well as your blood volume changes in pregnancy. Escalation of dose may be required after the 20th week. Those who are at the extremes of weights, less than 50 kgs, greater than 90 kgs, might require to do a factor 10 levels, and levels over 1 should tell you that you should de-escalate or reduce the dose of the low molecular weight heparin you're using. And a routine platelets is not really recommended for LMWH. Now, 2 days ago when I was in my OPD, a young woman came in. She was a second gravida with her mother. The history was she was on low molecular weight heparin and she wanted to terminate the pregnancy because of the fact that she was diagnosed with a DVT in her femoral vein. And her history was she had a sonography done, she had asymptomatic, she was 6 weeks, and on ultrasound she had a small blood clot which is asymptomatic in the uterus. The doctor gave her progesterone and the doctor gave her tranexamic acid in a big dose. The next day she had severe lower abdominal pain and pain radiating down the leg. It seemed like a sciatica, but when the color Doppler was done, she had a deep vein thrombosis and she was immediately treated correctly with low molecular weight heparin. She was better, the pain had reduced. But her mother was affronted with the fact that she thought it was an iatrogenic complication, number one. And she was alarmed at the fact that she had to take it through the pregnancy and it was entailing a cost to it. So I explained to her that she did require anticoagulation, but in the second trimester, she could choose to go on to warfarin, which would be much less expensive than the low molecular weight heparin, and she should consider carrying on the pregnancy, because this was probably an iatrogenic complication that she did have. I did explain to you all earlier about the teratogenic effects of warfarin, so it is never to be used in the first trimester. And the bleeding risks are significant when the INR crosses 4.5. The advantage is affordability. Second trimester is a good time to give it. It's an oral medication. And it can be also used after the first week postpartum for a duration of 6 weeks or 6 months, wherever it's required. Now, when you're using anticoagulations during pregnancy and delivery, there are certain guidelines. It's better to use unfractionated when you have a person requiring heparin very close to her delivery, because you can change the doses very quickly. LMH should always be stopped when a person comes in labor. She will probably take a couple of hours, but you should stop it immediately. Whenever it's a planned cesarean section or you're planning to induce labor, please stop the LMWH 24 hours before. Regional anesthesia should not be given for at least 24 hours after stopping the last dose of therapeutic LMWH, while if it's prophylactic, you probably can use it 12 hours later. Do not give your LMWH for at least 4 hours post-operative procedure, and if you're pulling out the epidural, please wait for at least 12 hours before you pull out the epidural catheter when you've given a person low molecular weight heparin. When you're a surgeon, please remember meticulous hemostasis. Please put in drains whenever necessary, and interrupted skin sutures to allow for a hematoma to drain should there be a hematoma. The side effects of heparin are thrombocytopenia, and it's definitely more common with unfractionated than with LMWH. It's rare in pregnancy, but it usually will start 5 days after the onset of therapy, and it might be worthwhile to do some blood counts now and then to check that a person is not going into thrombocytopenia. Anyone who's been on LMWH for more than 3 months, please recommend to them to have a bone densitometry done after the pregnancy and delivery, so that they know that they need to take supplements if they've been on heparin for long. Now, it's important to stratify the risks. Some people will be low risk, some people will be intermediate, and some will be high risk. It's because you basically give treatment based on those recommendations. Low risk patients usually will have a family history, no personal history, a mutation which is heterozygous for factor V as well as protein S, while intermediate risks are heterozygous for C, they have a homozygous for factor V, or they have an antithrombin 3 deficiency. While high-risk patients are already proven to have a VTE, and they're already on anticoagulation, and they have type 1 antithrombin deficiencies. The recommendations for low risks are only postpartum for a few days, maybe a week or 10 days. Intermediate will be for about 6 weeks postpartum, but not really recommended antepartum. And those with high risk will require not just prophylactic doses, but therapeutic doses of LMWH or unfractionated for the duration of pregnancy and for the duration of 6 to 6 months postpartum. Warfarin can be used for after 1 week postpartum. The amounts in the breastfeeding are negligible, and they can be used even during breastfeeding. These are the new developments which I think my esteemed medical counterparts have already spoken about, but people who have thrombocytopenia can use an alternative to the heparin, fondaparoxine. Again, the question, I think all of them answered correctly, was what do you think should be the INR? Is it 1.5, 3.5 or 2.5? Show of hands quickly, please, to see that you're still awake. Okay, I think that the audience is there on that one. And do we use unfractionated, or do we use LMWH when it's a PE? Unfractionated. Okay, we are all in agreement with that. And I thank you for your patient listening. And I think we also take a take-home message from here, in that anyone who has an IUGR baby, a baby who's an IUFD, intrauterine fetal death, these people are a prothrombotic state, which they don't end being a patient only during their pregnancy and delivery, but they have to be counseled about their future lifestyle, about being aware of, prevention of DVT in case they go through surgery, air travel, and several factors in their life will up their chances of a thrombotic event. Thank you, everyone, for your patient listening.
Thank you, Dr. Susan. We now invite Dr. Suja Murthy. Oh, sorry, any questions for anybody, because we are running a little late.
But that is more like Dr. Dalal asked a question about amniotic fluid embolism. That's another catastrophic event that usually happens during labor when there's strong uterine contractions and the amniotic fluid gets embolized to the lungs. It's like an anaphylactoid reaction, where there's a complete collapse within seconds or minutes of the woman experiencing it. There's dyspnea, there's frothing, the ABGs show that there's severe acidosis. There's also a cyanosis, peripheral cyanosis, hypotension, almost no pulse recordable. And one treats the patient as, you know, a crashed patient. CPR gets initiated, you start the ventilation, and you also believe that it's an anaphylactic reaction where in minutes the baby has to be delivered, because if you want to give efficient CPR, you need to deliver the baby within minutes of the event happening. And then probably with PEEP and with high pulmonary pressures, you can salvage some of these patients where treatment is given really as an urgent basis of, and you require, you know, a tertiary care center where, you know, you call for a crash intubation and you take the patient, and sometimes it's acceptable even to do a cesarean section in the ER or in the labor room for conditions like this.
Madam, you said second trimester onward you can use warfarin in pregnancy.
Yes.
Is absolutely safe or it's just a choice?
No, it is safe.
Absolutely
It is safe. It is safe in a second trimester of pregnancy, but you have to stop it because the long half-life, so before delivery you have to stop it well in advance. Those people who have mechanical valves, and when there's a cost constraint, but the cost constraint makes it such where some people choose to use warfarin during the second trimester of pregnancy.
We have Dr. Suja Murthy, a senior consultant in pediatrics, talking about something very scary, that's thrombosis in neonates. At least us radiologists were very scared when we asked for color Dopplers in ICU.
Thank you, ma'am. Thank you. Thank you, Dr. Anirudh, also, for this opportunity. Good afternoon, everyone. I'll just take a short session. I know everybody is hungry. So we'll talk about thrombosis in newborns mainly, and children also. So what is the developmental hemostasis? Why is it different from adults? So there are major differences in neonatal and older children and adult hemostatic system. Basically, the platelet function is supposed to be reduced in platelet aggregation studies and functional analyzer, though the number is the same as older children. So bleeding time in neonates is generally shorter than adults and older children. Also, circulation levels of various coagulation proteins are different. Factor 8 and von Willebrand is normal or elevated, and the vitamin K dependent factors, that is 2, 9, 10 are less. Now, natural inhibitors of coagulation, that is your antithrombin, protein C, protein S, they are also lower. So though the hemostatic system is balanced, because some of them are in excess and some of them are lower, it is more precarious. Thus, neonates are at increased risk of bleeding as well as thrombosis. So we need to deal with both. Also, there is relative plasminogen deficiency in neonates and increased risk of thrombosis. Now, what is the physiology of thrombosis? Like Dr. Susan ma'am said, there's Virchow's triad, in which you have hypercoagulability, disturbances in blood flow, and endothelial damage or disruption. Now, different speakers have spoken about all of them. So in newborns especially, we have hypercoagulability when they are physiologically deficient initially itself. Then you have disturbances in blood flow caused by various diseases like sepsis, shock, congenital heart disease, polycythemia, in IDM mothers, etc. And endothelial damage. Most common cause of endothelial damage is vascular catheterization, which predisposes them to thromboembolism. Hence, neonates have the highest risk, that is almost 13 to 65% of thrombosis in all pediatric age group. So among the pediatric age group, neonates are the most predisposed. Next come adolescents, which we treat same as adults. Now, there was a study which was done in 1995 which showed that 2.4% of 100 NICU babies developed TE events. And what are the risk factors? They can be either congenital or acquired. In the congenital, you have all the deficiencies which Dr. Shilpa has spoken, of which factor V Leiden is the most common. You have protein C, protein S deficiency, antithrombin deficiency, hyperhomocystinemia, lipoprotein A deficiency. You have anatomic defects like thoracic outlet obstruction, which is also known as Paget-Schroeder syndrome, in which the IVC may be obstructed, the iliac vein compression, which is known as May-Thurner syndrome, and absence of an IVC, which can predispose to TE events. The acquired, you have intravascular catheters, which I again lay emphasis on, which is one of the most common predisposing factors. Congenital heart diseases, infection, immobilization, especially in newborns who have dislocation of hips, who put on casts and immobilize, so then they are more prone to get embolic events. Artificial heart valves in older children, dehydration, which is very common, any surgical event, trauma, malignancy, and all the maternal conditions, especially APLA syndrome, may transmit antibodies to the newborns also, and they may have a transient thrombophilic phase. Now, for us, signs and symptoms are very important because we rely more on them than other diagnostic tests. So how would the clinical presentation be? It would be related to decreased venous drainage. So there would be swelling and pain. SVC syndrome, where you have swelling of the head and neck with headache and discomfort. Ascites and organelli, when there is an abdominal thromboembolism. CVT, that is cerebral venous, like Susan ma'am said, raised ICT, bulging fontanelle, irritability, seizures, focal deficit. So any newborn in the NICU who is admitted for other illness and who develops all these symptoms, you have to think of a cerebral venous thrombosis. Pulmonary embolism, unusual distress, tachypnea, hypoxemia. Thrombocytopenia may be a manifestation of thrombosis unique to newborns. So we have to remember that the platelet count may be low because of use up in the embolic event. What is the diagnosis? What is the aim? The aim is twofold, that is identification of the location and the extent of the thrombus, and identifying the risk factors and etiology. Now, gold standard for exam purpose is venography, which is not done. Doppler ultrasonography is preferred. Now, identification of specific risk factors and etiology is important for management of the baby and anticoagulant use. Also explains unusual signs in the baby like thrombocytopenia and cardiac dysfunction. So we know that the patient has a CHD or any other illness. Now, identify acquired risk factors first, that is catheters, dehydration, sepsis, then go on to thinking of genetic factors. Genetic risk factors cannot be modified, and whether or not tests should be done is controversial. Like Dr. Shilpa said, ideally the first 3 months of any event, tests are not done. Same thing for newborns. So it is, our focus is not on identifying deficiencies or genetic factors or what mutations they have, but our focus should be to treat and salvage the baby first and then go on to identify any risk factors. They may help in deciding treatment approach later. So like if there's a hyperhomocystinemia, the correction may lead to improved metabolism and shorter length of anticoagulant. Like Dr. Shilpa said, generally prophylaxis is given for in newborns especially, it's given for 3 to 6 months, depending on if it's a provoked or an unprovoked thromboembolic event. So that will help. This your identification of genetic factors will help in how much duration you need to give, but it is not an immediate emergency. On the other hand, neonate with purpura fulminans, that's a entity where the newborn comes with disseminated purpura. They may have severe protein C deficiency, though that's a clinical sign, and you may do that only that test to confirm if it's so. So you need to consider the pros and cons before ordering thrombophilia tests, and the diagnosis mainly has to be on signs and symptoms. Now, genetics, like I said, factor V latent mutation is the most common. Now, we never had so many genetic mutation tests and all till recently. In India, even now, due to financial constraints and availability, it is still less. So these are all European data which is there. Prothrombin G20210 mutation is the next. Protein C deficiency is common. Protein S deficiency is also common over there. And newborns are naturally deficient and only have 25% of adult value in the first few days of life. Also, when we order tests, we have to remember that most of them are not based on newborn data. So most of the tests have the values have adult criteria, adult values, and we have to actually tell them that it's a small baby, or they have to randomize the trial and they have to say. So the number of trials and the number of values are also very less. What is the treatment of venous thrombosis? Two principles. One is to prevent embolism, and one is the treatment of the thrombus. What is post-thrombotic syndrome? The incidence is 10 to 60% of children with DVT. In this, venous insufficiency secondary to valvular damage. So there is a valve damage and venous insufficiency leading to less drainage and swelling of the area. Anticoagulant therapy is used unless there is a contraindication like brain hemorrhage or there is a surgery, then it should be started immediately. Everybody's been talking about it. Unfractionated heparin is the drug of choice. It is quicker. That's why we prefer using it, but a shorter half-life. Loading dose in newborns is 75 to 100 units per kg over 10 minutes, followed by 28 units per kg per hour. So all our medicines are calculated based on the weight of the newborn. Low molecular weight heparin, enoxaparin can be used. It has to be given subcutaneous. It has a longer onset and a longer half-life. Reviparin, we don't use it, but there are studies which have done. And we have to monitor these medicines by APTT and anti-10A levels for the low molecular weight heparin. Warfarin, we don't use it in newborns because it's difficult to administer. The therapy is 3 to 6 months, like I said, for unprovoked and provoked. So if it's a provoked, it's 3 months. Provoked means there is a cause or there is a catheterization or some reason. So that is 3 months is enough. Once the provoking part is done, you can stop. 6 months is for the unprovoked. So you don't know the exact cause. You need to continue. Surgery, thrombolysis not recommended in newborns. We don't have such specializations also, and especially in preterms, because preterms are the ones who are more predisposed to getting thromboembolic events. They are the ones who are mostly in the NICU and having all the complications. Also because of the risk of ICH. In rare cases like the SVC syndrome, it may be considered, or pulmonary embolism. Replacement therapy for deficiencies like protein C, protein S, can be protein C concentrate not available, FFP or plasma, depending on what the deficiency is. This was venous embolism. We come to arterial thrombosis. So arterial thrombosis is very uncommon, almost always associated with arterial catheterization or damage during venous catheterization. So it's always mostly iatrogenic. Commonly in aorta, femoral artery, umbilical artery or renal artery. Patients at high risk are congenital heart disease and preterms because they already have risk factors. So that's why they are more prone to risk to getting this. Symptoms are of decreased perfusion, first loss of pulse followed by color change and necrosis. So that's why somebody mentioned that all the pulses, I think Anirudh mentioned, feel all the pulses. So first loss would be loss of pulse, followed by color change, followed by necrosis. By the time you come to that, there would already be a thrombus. Aortic thrombosis may be incidental on finding differential blood pressure. That's the importance of taking blood pressure in the upper limb and lower limb. Renal artery thrombus presents with hypertension. Diagnosis and treatment is Doppler sonography, echo, CT, MRI. There is no need of thrombophilia evaluation, like I already said. Arterial thrombosis most commonly iatrogenic or catheterization, so there's no point in doing thrombophilic evaluation. First and foremost important aspect is to remove the arterial catheter. Next is to determine the extent of the damage. Mild block, only removal may be sufficient, and if there's a severe obstruction, it may require therapy. Now, TPA, that is tissue plasminogen activator, may be used for this. The dose, alteplase, that is, the dose is 0.1 to 0.5 milligram per kg per hour. It's a fibrinolytic agent, acts by catalyzing the conversion of endogenous plasminogen to plasmin, and low dose heparin may be given along with that. Urokinase is also used in neonates in dose of 4,400 units per kg per hour. Now, in this you have to monitor the fibrinogen levels. Local thrombolysis, that is with TPA, improves the efficacy of therapy. So, local thrombolysis by putting a catheter only in that area and using TPA is also done. We're done with newborn. Now, thrombosis in children is almost like adults. I'll just insist on some points. So, advances in treatment and supportive care of critically ill children, coupled with increased awareness of genetic risk factors, have increased the diagnosis of TE events in children. So, overall incidence in general population is 0.07. But in hospitalized children, it is 60 per 10,000 admissions. So again, it is because of other factors which causes thromboembolic events. Infants less than 1 year account for majority of the cases, followed by adolescents. And presence of central venous catheter was associated with 90% TE in newborn and 60% of childhood TE. So that is the emphasis on appropriate catheterization and appropriate use of IV lines. Oral anticoagulants, warfarin may be used in older children. It, like Madam has said, it interferes with vitamin K metabolism and decreases some of the factors. That's how its action is. Direct oral anticoagulants are no trials in children. TPA we've already seen, and thromboprophylaxis of low molecular weight heparin may be given in immobilized patients, like post-op patients, same like in adults, we can be used. Antiplatelet therapy, aspirin, Madam said it acts on the small vessels. This another action is antiplatelet, so it decreases the platelet aggregation. That also prevents platelet thromboxane 80 production. What is the role of prevention, which can play a big role in newborn and children? In relation to arterial and venous catheterization, there are some guidelines which have been put based on catheter placement, use of heparin, and duration of catheter. So based on this umbilical venous, we have certain criteria. I will not go into the details, but there is certain positionings of the catheter. So the umbilical catheter should be at the tip. The tip should be between T8 and T9. Once the catheter is placed, an X-ray is done to confirm the presence. And a peripheral inserted central venous catheter just proximal to the junction of SVC and right atrium. Umbilical arterial catheter at the tip at the highest placement, that is T6, T10. Use of unfractionated heparin in infusion. So we use what is known as Hipaloc. I didn't hear the mention in adults, but I guess they must be using it. But we use it in arterial catheters. Dose of 1 unit, in 1 unit we add 1 ml, and the solution is run at 0.5 ml per hour continuously till the line is in situ to prevent any thromboembolic events. And the duration of catheter, how long can we place these catheters? Both UVCs and UACs to be removed after 10 days. Beyond 10 days, you cannot keep any catheter. Peripherally placed central venous catheters can be used for several weeks. This is what the indications and guidelines are, and the references. Thank you so much.
We're going to rush through. Thank you so much, Suja.
Thank you, ma'am.
And I call upon Dr. Prachi.
Just, Madam, one token of appreciation for Dr. Suja Murthy. Dr. Shampa. We don't have any tokens. It's coming behind you.
Dr. Susan? No, I got mine in the morning. I have a full garden at home otherwise. These are fun.
Dr. Prachita is coming from my department, the Department of Radiology, to run through radiology and thrombosis.
Hello everyone. I'll be quickly running through different case scenarios in radiology, helping us to understand how radiology helps and makes changes in the management of the patient. We'll be this full screen.
रीड नहीं हो रहा है.
This will be one of the last talks before lunch. So,
It's a very big topic, though I'll start, and there is some delay, but I like to introduce, in radiology, we can use multiple modalities to assess thrombosis in different parts. The modalities commonly used are ultrasound, CT, and MRI. Contrast is required for CT scan. Both the other modalities are without contrast most of the times. The first line of investigations usually in the peripheral, we can start with the presentation. So I have picked up certain cases to make us run through the diagnostic role of imaging in thrombosis. No, it's not. Yeah, so here's my first case, 69-year female with right lower limb swelling since 5 to 6 days, presented in ER. A right lower limb color Doppler was, venous color Doppler was asked for. We could see a acute thrombus in the SFV, which was extending into the iliac veins as well as IVC. The intrahepatic IVC was showing, pointer isn't working. Yeah, so the intrahepatic IVC was patent, but there was a thrombus in the IVC. The infrarenal IVC, the iliac vein, as well as the SFV and entire right lower limb venous system. In view of raised D-dimer, a pulmonary angio was performed, which revealed a thrombus in the right pulmonary artery, and a simultaneous CT venogram was performed, confirming the findings on ultrasound. So commonly we see the combination of findings, but the patient was only presenting with right lower limb swelling. Similar case, we had another young fellow, 23-year male, complaining of history of dyspnea and exertion with raised D-dimer, CT pulmonary angiography, again showing, the slides aren't moving here. Yeah. No, you're going ahead. We need to go ahead. I'm on slide number 6. Yes. So we could see a partially occluding thrombus in the left lower lobar pulmonary artery. The chest radiograph did not show any markable findings here. In view of pulmonary thromboembolism, further workup with bilateral lower limb venous color Doppler was performed, which again revealed thrombosis in the entire left lower limb. The right lower limb was unremarkable. So the two case scenarios had similar findings involving pulmonary embolism as well as DVT, but the presentations were different. So entire workup for such patients is required when you see any of the findings. We move to our next case. He is a 55-year-old male complaining of dyspnea with exertion and palpitation. He was a known case of rheumatic heart disease with mitral stenosis and MVR. He had acute presentation of swelling in the right hand, chest and face as SVC syndrome. Dr. Amit would be very well recollecting the case. So patient came to us for a right upper limb vascular evaluation. We could see a thrombus distending the IJV. This is a longitudinal section and a transverse section. We can see the difference in the caliber of the carotid artery and the vein. Apart from that, we could see certain lymph nodes also. This is the subclavian vein along the subclavian artery showing complete thrombosis. In such scenarios, we are interested to know what is the cause for such thrombosis. Usually there is a central obstruction. So a further investigation of was performed. This is a large lymph node in the axilla, and an infiltrating soft tissue was also seen in the chest wall. Further, yeah. So a CT venogram along with a CT chest with contrast was performed. A large infiltrating soft tissue mass was seen in the anterior chest wall along both sides of the sternum. Significant osteolysis in the sternum was seen. The mass was extending into the mediastinum with severe compression of the superior vena cava. So this was a SVC syndrome. We could also see here we could also see the lymph nodes. There were few chest wall collaterals. Yeah. So the next slide, please. Here we can see the extrinsic compression of the superior vena cava in the cranial end very well here, and no flow in the right subclavian artery as well as the IJV. So in such clinical scenarios where ultrasound gives us a brief idea about the positive finding of thrombosis, further evaluation of the central venous system as well as the adenopathy and chest wall was required, and the CT guided us well with the disease process, understanding that it was a large infiltrating chest mass extending into the mediastinum and causing central venous obstruction. CT guided biopsy confirmed that the presence of a large B-cell lymphoma in this case. Next case, 47-year male complaining of left upper limb pain, numbness along the medial aspect of forearm. He had a past history of pulmonary thromboembolism and was irregular on antiplatelet agents. CT aortogram was asked along with right upper limb angiography. So here when we know what exactly we are looking for, so we can accordingly plan the scan, because usually the scans for aortogram are done with the hands up. We do not cover the hand in the FOV. But here we knew that the patient is having an absent pulse and some symptoms in the arm, so we could cover because we knew about the clinical scenario. So beautifully we can see that, so the aortogram shows a small thrombus at the origin of the left subclavian. The upper limb angiogram shows absent flow after the origin of the ulnar artery. The radial artery shows a good flow. A delayed phase revealed a very patchy flow in the rest of the ulnar artery, which is probably through the patent palmar arch. This is a VR representation of the same angiogram. Here we cannot really appreciate the small filling defect what we are appreciating on the MIP images here, but the absence or the no flow in the ulnar artery is better appreciated here. So CT do play a vital role in knowing the extent of the disease and planning of the future treatment. Next case, 65-year female CKD was on regular dialysis through a right upper limb fistula. She had a past history of stenting for right subclavian stenosis. Now she was complaining of poor back pressure in the arterialized vein during her dialysis and had developed progressive swelling in the upper limb. Again, a central vascular evaluation was required, and she was subjected for a chest venogram. Color Doppler of upper limb was performed for fistula evaluation, which was perfectly all right, and apart from that we could see engorged subcutaneous veins and edema in the upper limb. When we performed the central venogram, we could see the stent in place in the right subclavian vein, but the stent showed some stenosis in the mid part and a completely occluding thrombus within. Now we could also evaluate the brachiocephalic and the superior vena cava, which were completely fine. So this could guide the treatment further of plasty of the stent which was blocked. So this is how we can come to a conclusion using radiology in such patients who are already, so the functional fistula can be reused in her case. The next case is a 26-year female postpartum with severe headache, diplopia and first episode of convulsion. Of course, in this scenario, we would like to rule out cerebral venous sinus thrombosis. MRI brain with venogram was asked for. So, yeah. So on a routine conventional sequences, we could see absence of the normal flow void. A normal flow void is a black structure in the place of the venous sinus. Here we could appreciate some signal. This is a gradient based sequence which is very sensitive for detecting hematomas, and we can see blooming which confirm possibility of a thrombus here. These are the parasagittal T1 sequences which again shows the site of occlusion and a normal patent. sinus on the contralateral side. We perform MR venogram, which gives a 3D depiction of 3D depiction of the all dural sinuses as well as the cortical veins. This is a non-contrast image where we confirm the absence of the flow in the left transverse and sigmoid sinus as well as IJV. Just to rule out any possibility of slow flow related artifact, a contrast was done and which was exactly matching to the findings of non-contrast, confirming a great application of a non-contrast of evaluation. Certain mimics which gives us a false positive finding of a thrombosis. This is a case recently Susan madam has sent. She was a postpartum lady again complaining of severe headache. They are considered post-spinal headache earlier, but later on they asked for a CT MR venogram where there was an absence of the anterior part of the superior sagittal sinus on the venography. But then we confirmed it on the conventional studies that there was conventional sequences that there was no sinus that was a developmental hypoplasia. The commonest sinus which shows developmental hypoplasia is the transverse and the sigmoid sinus. This is an unusual but a known site where we do find absence. This is the posterior part of the sagittal sinus which shows a nice sinus in the falx. Anteriorly we are not seeing the sinus at all, it's absent. And GRE is here to support our diagnosis that there is no blooming to confirm that there is no hematoma or hemorrhage in the sinus. We move to our another mimic. This is a flare sequence which is showing absence of flow void in the right sigmoid and transverse sinus, but the MR venography confirms a good flow and we don't need to do a contrast study in this case. Next case is a 38-year male complaining of right lower limb weakness, imbalance, one episode of convulsion, and a code white was activated in ER. Patient was brought for a CT angiogram. The plain CT brain did not show any parenchymal hemorrhage or acute infarct. The only positive finding we could see is a hyperdense superior sagittal sinus which appears as a delta sign on the coronal and corresponding hyperintensity on the sagittal sequence. On a post-contrast study, we could see a filling defect which confirmed presence of a dural sinus thrombosis. So, real-time monitoring of the scans is very important as we can acquire an additional venogram sequence which is otherwise not a part of our code white protocol. This is a 3D depiction of the same CT venogram where beautifully we can see the thrombus in the superior sagittal sinus and few of the cortical veins. MR of the same patient was performed as a part of the stroke protocol which confirmed presence of a small venous infarct in the left high frontal cortex, and the gradient blooming again shows and confirms the presence of a dural sinus thrombosis with cortical vein thrombosis. Next case, another a code white case, elderly male complaining with right-sided weakness and dysarthria. CT angiogram with MRI brain screening was performed. There was no parenchymal hemorrhage or obvious infarct. The only positive sign which we could see is a hyperdense vessel in the supraclinoid region as well as left MCA cistern. So this is a dense MCA sign. On CT angiogram, we could see a filling defect in the same region, confirming that there is an acute thrombosis. VR image of the same reveals and confirms the presence of a block. There was a very poor distal collateral flow. The same patient, MR showed a hyperacute infarct, which I have not showed it here. Another case, acute onset severe pain in the calf. Doppler, in view of that, Doppler study was asked, which revealed a thrombus in the posterior tibial artery. Possibility of an embolic phenomenon was considered and aortic angiography along with peripheral angiography was asked for, which revealed a long segment aneurysm in the abdominal aorta. There was an eccentric thrombus within the aorta, which you can appreciate a very large volume in the lower sections here. The irregular intimal surface was seen, which was probably the site of the embolus. Next case, 35-year male, presented with acute onset pain in right lower limb. He was a smoker. Clinical examination revealed no pulse in DPA as well as PTA. CT angiogram of both lower limb was performed. And here we can see a partially occluding thrombus for a short segment in right common femoral artery extending to superior femoral artery. These are the multiplanar reconstruction images showing the thrombus here. A volume rendered image showed that small thrombus. Yes. Yeah, so the volume rendered image showed a small filling defect corresponding to the previous thrombus that we could see. The complete amputation of flow was seen from the popliteal artery with a very patchy and poor flow in the calf arteries. So multi-level obstruction of the right lower limb arterial system was seen, and accordingly the management was planned. Next case is a 42-year male alcoholic presented with epigastric pain, ultrasound findings of acute pancreatitis, and lab was supportive. CT was performed. CT showed all signs of pancreatic inflammation along with some necrosis in the region of tail. There was no flow seen in the splenic vein, suggesting splenic vein thrombosis, which is a very known complication of acute pancreatitis. The coronal reformatted images showed good opacification of the portal vein as well as superior mesenteric vein. Can I get some water, please? Excuse me. Next case is a 42-year female with distension of abdomen, vomiting, and clinical signs of bowel obstruction. Excuse me. A CT abdomen with multi-phase imaging was performed. Move the slide. Next slide, please. What we could appreciate was the signs of small bowel obstruction, dilated small bowel loops, but there was a differential enhancement in the bowel perfusion. This loop, we can appreciate that there is a very poor enhancement. The SME revealed a near completely obliterating thrombus in the proximal course. This is a reformatted image again showing the same thrombus. So this was a mesenteric ischemia and associated small bowel obstruction changes. Next case is 49-year female, left flank pain, ultrasound revealed changes of pyelonephritis, lab was supportive, CT KUB was asked to look for any obstruction of the ureter. As we see the CT, there was all signs of pyelonephritis, but the additional findings that we could see on the plain scan was a very distended and dilated left renal vein. Hence, the possibility of renal vein thrombosis was raised, and we converted the study from KUB to a CT IVU, and the post-contrast study beautifully depicted the thrombus distending the left renal vein. It is not a known complication, but a listed rare complication in pyelonephritis. Most of the renal vein thrombosis that we see commonly is with tumor thrombus and RCC. So we need to know the difference between a bland thrombus and a tumor thrombus. This is a different case where a large heterogeneously enhancing mass is replacing almost the entire right kidney. It is extending through the renal vein into the IVC. So the enhancement within the thrombus makes a difference, and that is the reason this is a tumor thrombus and not a bland thrombus. Next case is a 47-year male with ischemic right lower limb. Color Doppler revealed atheromatous changes in the distal SFA, monophasic flow in the calf vessels. CT angiogram was contraindicated due to limitations as he was having renal compromise. MR lower limb arteriogram was performed without usage of any contrast, and we could see a long segment of no flow in the distal SFA, suggesting occlusion. This was a case. MRI can help beautifully in patients when there is a renal compromise. Now, as we have come through many cases of different thrombosis, we will quickly go through the role of ultrasound and the limitations of each modalities that we come across. Sonography being the first modality of choice when it comes to the peripheral evaluation. Abdominal evaluation, it has a little limited role considering the presence of bowel. It can visualize the blood flow. We can analyze the age of the...
Prachi, can we sum it up faster, please?
Yes. Just few more slides now. Yeah, so we can age the clot, acute, subacute as well as chronic, because the management differs. It's a non-invasive and a safe test. There is no radiation exposure or contrast administration required. The best part is it's a portable and a bedside utilities are possible. It is very safe in pregnancy. To summarize, sonography is safe, non-invasive and effective tool in assessing and managing thrombosis, offering a real-time evaluation as well as monitoring of the treatment. Limitations, of course, it comes with lot of limitations also. It's obese patients, there is a limited beam penetration, difficulty in imaging certain vessels like deep pelvic veins, veins in the mediastinum. It is an operator-dependent modality, sensitive to movement. So if patient has limited breath holding capacities, lot of vascular structures cannot be assessed well. Limited assessment of complex blood flows and times when there is cutaneous ulcerations. Inadequate for very small or very early thrombosis. It lacks a 3D view. So ultrasound, when used along with certain other combinations of modalities, it can be used in imaging techniques for comprehensive vascular assessment, particularly complex cases. We move to the next modality, role of CT scan. Yeah, we all know that it's one of the fastest mode of evaluation, which makes it very ideal for evaluation of emergency settings when the diagnosis is critical. It gives us a very good 3D and detailed structural evaluation. We can assess the structures around the vessels also. It gives a roadmap for future interventions and suitable for a large FOV evaluation. Limitations, yeah, it comes with radiation exposure. So concerning in patients of young age and who requires multiple scans over a short time, it can radiation exposure can lead to risk of cancers on a long run. Use of iodinated contrast is required. It can give to allergic reactions, contrast-induced nephropathy, especially in high-risk patients. Difficulty in assessing thrombus composition as well as its hemodynamic significance. It is less effective in small vessels, particularly the digital vessels and peripherally densely calcified arteries. Motion artifacts also limits appropriate evaluation. CT scan is a very valuable for rapid high resolution assessment of vascular thrombosis in emergency settings. However, limitations such as radiation exposure, contrast risks and limited soft tissue details makes it less ideal for follow-ups and small vessel imaging. We come to role of MRI. MRI does not usually require contrast for assessing the vascular pathologies. It provides a multiplanar and a 3D views for assessing the surrounding anatomy also. Detection of blood flow, identifying the and characterizing the thrombus composition. It's a non-invasive test with contrast-free options and no radiation is involved, so safe in pregnancy. Assessing surrounding tissues and organs is possible. Monitoring of treatment is a modality of choice when we want to avoid ionizing radiation. Limitations of MRI comes with a high cost and limited availability. It's a time-consuming test as compared to the CT scan. Contraindicated in certain patients with cardiac pacers and cochlear implants. Claustrophobia and anxiety also limits evaluation in certain cases. It potentially has a small need for use of gadolinium contrast when in doubt. So patients with renal compromise again cannot go for it. Sensitive for motion artifacts. And limitations in interpretation, and as it requires specialized training, acquisition and different equipments also provide limited data for assessment. So here I conclude.
Thank you very much. A very, very a long talk on and comprehensive talk on thrombosis, arterial, venous, mesenteric, peripheral, CNS. Thank you so much, Prachi.
Would like
questions?
Yes. One question only.
Yes.
Madam, when you routinely do CT, abdo, pelvis or chest, do you look at the vessels? I mean, even if it is not asked for?
Most of the CT studies are done with contrast. Only the plain scans where we do not introduce contrast, we cannot answer on the vascular part. All the CTs which are done with contrast, yes, of course, we look at the vessels. exact planning of the scans can be performed better with multiple phasing imaging if we know the clinical background or some scenarios, because like evaluation of aneurysm, it requires a proper arterial phase. So that may not be acquired in all the cases, but yeah, gross arterial and vascular evaluation is done in all the CT evaluations where contrast has
So
been
in routine
administered.
CT, we grossly look at the vessels
Yes.
with the contrast. Thank you.
Any questions? Thank you.
Would request Dr. Manish Arya to give a token of appreciation to Dr. Prachi. So we can break for lunch. Lunch is for half an hour. It's available outside. Kindly come back at 2 o'clock. We can start the next session. Dr. Amit Sharma and Dr. Prajay are pending with their talks, and then we have the PG quiz.
It's Dr. Aniruddha's birthday today, so I think we'll start lunch with a birthday cake and singing for him. There's a cake outside for you.
I think let's go with the CME program. Please join us for lunch outside.
Lunch session is on a topic of critical importance in cardiovascular medicine: thrombosis in acute coronary infarction and its management. Acute coronary infarction, commonly known as heart attack, remains one of the leading causes of morbidity and mortality worldwide. The underlying pathophysiology of ACI is complex, but at its core lies thrombosis, the formation of a blood clot that obstructs a coronary artery, leading to a disruption in blood flow and myocardial ischemia. Thrombosis in ACI is a multifaceted process, and understanding of this process is pivotal for effective diagnosis and timely intervention. Our expert, Dr. Amit Sharma, a renowned interventional cardiologist, will guide us through both the foundational concepts and cutting-edge advancements in this critical area of cardiology. Dr. Amit Sharma specializes in complex coronary and peripheral interventions. With that, I am pleased to hand over the floor to Dr. Amit Sharma.
Thank you, ma'am, for the kind introduction. I must say it's a very great gathering to have here so many people. After a long time, we are seeing this hall full. Thank you so much for coming. And I thank Anirudh and the Thrombosis team for having me here today for giving this talk. So when we talk of thrombosis, we know that this is one of the most common things that we see. In fact, 70-80% of our practice essentially involves acute coronary syndromes where patients present to us with STEMIs, or what we call as ST elevation MIs. And most frequently we come across this situation where what options do we give these patients? So remember, in acute MI, the clock is always ticking. The reason is you are able to salvage the myocardium only in a limited amount of time, because if that time passes, then the myocardial damage that occurs is going to be permanent. So if you have a person who comes to you within 30 minutes of a heart attack versus the person who comes to you after 6 to 8 hours of a heart attack, there is going to be a huge difference in the outcome of this patient. This patient will go home, of course, but how the heart function is going to be in the future is going to be dictated by two things: the speed with which he presents to the hospital and the speed with which he is taken up for any intervention. So these are two things that are very, very important to understand, that between in any patient who presents to you with acute ST elevation myocardial infarction, it is always primary angioplasty. That is the first thing which is the most important part of our treatment, that the patient, what we call as typically is PAMI, primary angioplasty in myocardial infarction. There are numerous studies that have been done till date which have shown that a primary angioplasty beats thrombolysis any day in terms of patient outcomes, in terms of the patient recovering his heart function back to normal. And because of your ability to salvage that myocardium and your ability to reperfuse that area, definitely the outcomes are much better as compared to thrombolysis. Thrombolysis is an inferior mode of treatment. And it is a second option for patients, particularly in our setup, if supposedly if the patient has a dearth of finances, or when he comes at an odd hour when no relatives are available, then this is the mode that is commonly used. But of course, primary angioplasty beats thrombolysis hands down. So a normal primary angioplasty, ideally the indication is within 2 hours from your contact ECG. So if your ECG has been taken at your GP or at your hospital or so, you're looking to perfuse this artery within at least 2 hours. So this should be the goal. And of course, as I told you, that thrombolysis is always inferior. Now if suppose you're not able to do a primary angioplasty, the patient is somewhere very far away and he is not able to reach the hospital which has an angioplasty facility, then your thrombolysis may just work. Because in that case, when you know that the angioplasty is going to take a longer time than 2 hours, in that case this works well. You may give thrombolysis to this patient. But remember, thrombolysis is a bridge. So after a thrombolysis, you will take the patient again for an intervention to see if the artery is open or closed. So that should be the idea behind it, that you need an open artery and not a closed artery, whatever the means of revascularization. Now, if there is a delay between 2 to 12 hours, as I just mentioned, then you will consider thrombolysis, because we do know that if not all cath labs are enabled, not all procedures happen, streamlined, there are a lot of delays, insurance, TPA, all these things. We face this on a daily basis. You try to reach that figure of 2 hours, but sometimes it is not humanly possible to get it in these things happening in 2 hours. But we still try our best. Now, the role of troponins, this is very important, because many a times we see troponins being sent and reports being awaited in the ER if the patient has a frank ST elevation MI. So remember, this is one thing that we should highlight, that if the patient has an ST elevation on the ECG, there is no real role of troponin in this case, except maybe in that, judicious, you see a tall T waves and the patient is a CKD patient, chronic kidney disease. In those patients, maybe yes, you would think of it, but otherwise it's very clear cut. If you see ST elevation MI, don't wait for the troponins to come. It's going to take 1 hour, so you're losing that 1 hour time in between. Of course, in patients where there have been numerous patients we have seen who come with the first ECG that is normal and very typical chest pain, and when you repeat the ECG and the troponins about 1 hour later, you see that the rise has happened at that particular point. And that's why troponins are very, very important. In fact, it is the only biomarker that has been available to us for use in diagnosis of myocardial infarctions, and I can, there is absolutely no other biomarker that has lived up to its name except troponin. Now, there are troponins we know are 2 types. One is the normal troponins, and you have the other ones which are called the high sensitivity troponins. All the recommendations are with high sensitivity troponins. So if your high sensitivity troponin comes normal in 0 hours, so you do it at 2 times. One is at 0 hours when the patient presents, and you do it after 1 hour. For HS trop, you don't need to wait 4 hours to send the next sample. For HS trop, the next sample can be sent within 1 hour. So if it picks up even that 1 hour rise in the troponin. Now if it's a normal trop, what you have, what we call as a C3 triage, which is a normal troponin, there it may take up to 4 hours. So there we ask the patient to wait for up to 4 hours. But if it's a HS trop you're sending, then it's fairly okay to ask for it after 1 hour. Okay. Now the positive predictive value of this. Now if your troponin is positive, 75% of the times you're dealing with an acute myocardial infarction. So even though your ECG is normal, patient is saying I just had some dyspepsia, I just had an extra burp because of the extra samosa that he had at the canteen, be sure that if the troponin is positive, then there is a problem in the coronaries. Now if the trop is negative, then you are almost 99% sure that it's not a myocardial infarction. It can still be unstable angina, of course, but at least it does not require a triage where you have to take this patient directly to the ICU and requires a procedure and all. You have some time to decide there. So that's why the troponin test is most important, and we have formulated it in our this thing where in casualty we do this test first. And as I said, if there is ST elevation, there is no troponin. A CT coronary and a stress test comes later. If suppose this patient has a troponin which is persistently negative, then you can ask for a CT coronary, you can ask for a stress test. The patient is relatively stable. Now, For acute ST elevation MI, as I told you, the time is short. Ideally, there should be no ER. The patient should be shifted directly to the cath lab as soon as the patient enters the hospital. But sometimes this is found wanting, as we know from the existing setups that we have in all the hospitals. So what I'm going to show you is, I don't want to take a theoretical class and tell you about thrombus and how it forms and what is Virchow's triad and all. I will save that for another day. Today I'm just going to show you how we deal with these thrombi and how they make life difficult for us sometimes and for the patient. So I'm just going to play this. You can see it? Yeah. So this is, sorry, let me make this, yeah. Okay, now what you're seeing here is a normal right coronary artery. If you can appreciate, I just want you to appreciate the thickness of the artery so that you will get an idea of what I'm speaking in all the presentations. So if you see the thickness of this artery well maintained throughout, and you can make out that this artery is essentially normal. There is not much of a problem in this artery, except you can see, we look at these narrowings. You see these narrowings here? These are the blockages which are there in the artery, which tell us if there is a block or no. Now you can see most of the time this artery is flowing well over here. So this is essentially a normal right coronary artery. Why this is important is because my next case that I'm going to show you is a young boy, 35-year-old. This was a young boy, a 35-year-old male who presented to us, absolutely no comorbidities, came to the casualty with the inferior wall, 2 hours duration. So he had chest pain only for 2 hours, and he presented with a ventricular tachycardia in the ER. He was cardioverted promptly and he was shifted to the CCU. In the CCU he had a complete heart block. And we did an echo. Echo was LV function normal, but he had a right ventricle involved. The right ventricle myocardial infarction was there. Systolic BP was very low, started fluids, inotropes, and we immediately presented 8. We took him in the cath lab at 9 o'clock because apparently he had an insurance and we could go through this without any problem. This was the ECG that was taken in casualty, and you can see the ST elevations in the inferior leads which was there, which you can see in 2, 3 and AVF. A similar ECG on the right side showed ST elevation in V4R. So that means there is a right ventricle involvement. Now when you have a right ventricle involvement in inferior MI, the prognosis is not good. So you have to be more quicker than usual. This is the angiogram. I will skip this thing. The left side was normal. Now this is the right one which I am showing you. Now you remember the artery that I showed you just few hours back. Now look at this artery. You can see all this this hypo shadows that you're seeing. This is of the thrombus. So the whole artery has got occluded, and this all is the thrombus that you're seeing, and you can hardly see any flow in this artery down here. So this whole artery is occluded with thrombus and stubborn thrombus. It doesn't, yield to anything. We usually give for this thrombus, we have like how you have a surgeons use a Dormier's basket or Fogarty's catheter to remove this thrombus. We have something called a thrombosuction catheter which we deploy inside, and it's like a vacuum cleaner. It sucks out the clot outside. And once it sucks out the clot, the artery looks a little bit cleaner. As you can see here, the artery is much clean. Now if you see this and if you see this, you'll notice that there was a gross difference in the two. So here the artery is totally occluded with thrombus. Here it has opened, and we have been able to put a stent here in the in this portion over here. So this looks better, and what we get in that basket, what you see is this. So you can see here there's a linear thrombus there which is there. Now this apparently is not more than just about 2-3 millimeters or so, but even this bit of thrombus can produce such catastrophic outcomes in the patient. So hence the speed with which we must perfuse this patient. Now this patient apparently did well. He was put on rivaroxaban. This was after another run of thrombus aspiration. We retrieved this. These were all the clots that came out, and apparently did well. And we did a angiography after 6 months to see whether how he's doing. He was put on rivaroxaban. And you can see now the artery is nicely flowing at 6 months. So 35-year-old, so if you are able to reach in time, and if the patient reaches the cath lab in time, then you can definitely do a better thing for these patients. Now this was one of those patients. I will now show you a second patient where this guy was still okay. Now what happens to sicker patients who are in hospital? Now this was a second patient which I am going to show you. Now this patient came with, he was in the hospital with under Dr. Ashish Gupta. He was basically admitted for fever and UTI, and he had some urine issues. He was planned for a cystoscopy the next day, and his pre-op evaluation was all normal. On the day of the prior to the surgery, just at 3 a.m., he developed chest discomfort, severe sweating at 4 a.m., and he was shifted to the CCU in view of ECG changes. These were the fever spikes that we saw at that particular time, which the patient had for the last 3 to 4 days. Now, it is a known fact that any febrile illness can precipitate plaque ruptures and produce acute coronary syndromes. So, when a patient particularly has fever and he complains of profuse sweating, it's not always the paracetamol, sometimes it could be more. So, you are right in asking for a ECG. This was the echo done at that particular day was totally normal. This was the echo which was done, which was essentially normal. Now this was the ECG that we took in the CCU. Can you see the ST elevation in V1, V2, and you can notice the gross ST depressions here in V4, V5, V6. And if you see, another thing to see here is the ST elevation in AVR, which tells us that this patient is probably having an extensive vessel disease. So he was admitted in the ICU, in the CCU, and we immediately took him. This was again in the CCU. You are seeing the similar ST elevation in all the leads, and we took him for echo immediately. The echo showed that the EF had dropped to 30%, and the patient was having severe pulmonary hypertension. And we took him on the CAT table immediately, and you can see his baseline pressure was around 80, 85 or so. This was the initial tracing we took on the CAT table. And this is the angiogram. Now if you see the angiogram, I am just going to outline it in brief, don't want to be too complicated. Yeah, so okay, if you see here, right at the mouth of the vessel, there is a clot sitting right at the mouth of the left main vessel. And because of that, you are seeing that you are not able to opacify that part of the vessel. And this is what has caused the patient all the symptoms and the cardiogenic shock. So after that, if you can see here, yeah, this looks better. Now you can see in this view, it's much better. If you see this here, there's an absolute cutoff over here, whereas you can see rest of the vessel over here. Here there's a cutoff. So that tells us that there is a left main stenosis. So went ahead and we put in a balloon pump, and after putting an aortic balloon pump basically brings up your aortic pressures and also helps to perfuse the coronaries. So we put in a balloon pump and we were able to salvage this patient, and this was the after the stent. Sorry, this is after the stent right now. I'm just going to skip through all this. This is the stent. And this was the final result. Now you can see that part has now cleared off, and we have been able to put a stent at that particular portion. Now after this, the patient did well on the CAT table. You can see his pressures came up to almost 110, 120. So he was doing quite okay. This was his ECG after the angioplasty. You see the ST elevations have all gone. All the ST depressions have reduced. ST elevation AVR has gone down. So he was on the balloon pump. He was generating a pressure of 100 and almost 111 of diastolic, and he was able to go home after 5 to 6 days of hospitalization. Now, sometimes it's simple as this. Yes, patients do. We do lose some patients also. It's not always a rosy and all ends well kind of a story. We do lose patients, and we do try our best to salvage them. But sometimes, you know, destiny has other plans. Now, I'm going to show you a third case. Now, this case was important because sometimes you have to use not so conventional tools. You have to use newer tools when you're dealing with some difficult cases. Now, our hospital is now enabled with a newer kind of a machine gadget that we have, which is called the optical coherence tomography and FFR, which is available. So there was one case which I am going to show you, which we dealt with using this particular thing. 16 July. Yeah. So this was the this thing where we used it. The old lady, she was non-diabetic hypertensive. She was came with a ACS and drop was positive. Her ejection fraction was hardly 30%, and she had aortic stenosis also, moderate aortic stenosis, and this was her ECG. Now, if you see this here, you will notice that there was again a very tight critical. Yeah, if you can notice this here, you will notice that there is a cutoff here in the vessel over here at this point, which shows that there is a left main stenosis again. Now, because we were able to arrange the OCT, other thing, her son was a dentist based in the US, I still remember, so we were able to procure everything. Now, this shows you how critical that stenosis was, and there's a lot of clot sitting at this point. So we did a thrombosuction, we did a OCT, now you can see that's the OCT. It's basically a camera which goes inside the vessel and it defines your vessel from inside. So it tells you what kind of strategy you can use. Now here it is showing all the thrombus. If you see these dirt particles over here, that's all muck inside the vessel, or what we call as thrombus. So we use this particular technique, and then after that it was smooth sailing, and this was the final result with the areas and this thing. So sometimes you have to modify your strategy based on what you're dealing with, and some patients do give you the time for using these kind of non-conventional devices. So what exactly is this OCT? I'll just take 1 minute before I end. This is so what exactly is this OCT? So what it does is, it's basically a camera. It includes your, just going to forward all this. Yeah. So this is what it does. It's basically a high resolution imaging. So if you are seeing on CT this blockage like this, what you are seeing on the OCT is like this. So it makes it more sharper, more clearer. And that's where it helps you in identifying the blockage and how you're going to deal with it in the artery. So it basically uses infrared light for resolution, and that's the system pullback. We now have the Ultron 2, which is the latest available machine which we have, and that is now available at Holy Spirit. Very few hospitals have the Ultron 2, so we are able to give better this thing. This is how it works, and you can see here, now that's the blockage over here. That's the blockage that you're seeing over here, and now you'll see the camera being advanced. This is the camera which is being advanced through the lesion, and which gives us information on how it is, and this is how it moves outside. If you can see this, you see that? So you just need to pull this back, and it runs through the artery and gives me an entire profile of that entire artery. So you get a fair idea of how things are, and you get a nice image display like this, which tells us whether the stent has been appropriately deployed, it has been put properly, is there any dissection, is there any need for worry. It basically ensures that the CCU and the cardiologist have a good night's sleep. So these are some of the unconventional methods that we use also in thrombosis and in patients with acute MI. So first I presented to you as a very simple case, a little more complex, and this is the most complex. So you'll have all these things which we deal with on a daily basis, sorry, not on a daily, on a routine basis, and this is how we deal with them over here. Thank you very much for your patient hearing.
There is something known as a rapid troponin test where you just need a drop of blood. That is a 15-minute test. You are saying it takes nearly an hour. Is that not sensitive or reliable?
Well, the problem with these rapid troponin tests is they are not having any this thing. They are just a card test. And what happens with that is they are very much prone to non-specific results. They don't have a quantification. They are more of qualitative test. And once you have a qualitative test, it's very difficult, because we have seen patients coming with qualitatively negative. Quantitatively, when we do the test here, it's very high titer. So it's very difficult because it depends on the reagent, how they are using, whether that strip is stored well, a lot of other things. So this rapid method, I don't think should be advocated. Whatever troponins we do, we insist on quantitative always, not qualitative.
But as a just as a screening in the ER, you have a patient, a young patient like this, you're 35-year-old. Will it be useful?
We don't ask for, because sometimes you may go to sleep thinking everything's fine, but he may come back. Okay. That's the problem.
Okay.
So most of them has to be quantitative and high sensitivity.
Just an extension of the question that ma'am asked. Would you depend on any other markers apart from the troponin?
So we look at CKMB also as one of the side, but it's like a sidekick, it's not like we don't base the decision on CKMB because CKMB is relatively non-specific. It can be high in chronic kidney diseases, infections, sepsis. So most likely we don't rely on it, sir.
And basically just as you don't completely rely on the troponin also. Right?
Correct, yes.
Unless you
but
have a rising
troponin still, sir, 75%
rising
is positivity. The 25% what we see is your typical ICU patient with bad COPDs or bad CKDs. We see troponin positive. Now even there, if the troponin is positive, it does not mean that the patient doesn't have an acute MI. It tells me that the heart is under some sort of jeopardy which can be dealt with medically.
Okay, thanks Amit, thanks.
The second case that you discussed about a patient of cystoscopy with TURP who came to the hospital and in the night he became. So when do you then recommend the TURP to be done? This is for the information
now
of
this
our
of course the TURP would be done. Now once you put a stent, all elective procedures are out, but at 3 months we can interrupt this therapy and then send him for a bridge by putting him on low molecular weight heparins.
Okay, thank you.
Would request Dr. Jayashree to give a token of appreciation to Dr. Amit Sharma.
Our next speaker is Dr. Prajay Lunia. He'll be giving a concise summary of pulmonary embolism. Dr. Prajay has done his MBBS from JJ, his MD from Nair, and done his DNB from Hinduja and Bombay Hospital. And then he's been an asset to our institution since I think about the starting of COVID. Prajay will be speaking on pulmonary embolism, and by that I believe it's going to be thrombotic, not something like fat embolism or air embolism, which are different topics altogether. And Prajay, go ahead.
I also believe that you do some pulmonary lysis, also, pulmonary embolism lysis, which Dr. Anirudh mentioned during his talk. We're looking forward to this.
Hello. So in this presentation, I'm going to explain about what things can be done and all that stuff. So just probably in 10-15 minutes, certain things will be cleared, how the patient is present and how we do it. So good afternoon, chairpersons and all the delegates and my colleagues and seniors, and thanks Dr. Anirudh for giving the opportunity to just brief a small information about pulmonary thromboembolism. So when we actually say pulmonary embolism, it is actually a pulmonary thromboembolism, because most of the times it is the thrombus which gets dislodged either from the deep veins or from any other catheter access which is there, and it finally gets lodged in the pulmonary vasculature. So venous thromboembolism, if you see, it's a cardiovascular syndrome. The most common cause is the myocardial infarction, as Dr. Amit Sharma sir said. Then second comes stroke, and the third is your venous thromboembolism. It includes deep venous thrombosis as well as pulmonary embolism. The incidence wise is 39 to 115 cases per 1 lakh population, and the risk increases with age. I'm not going detail in epidemiology. Now let us understand what are the risk factors. The risk factors for pulmonary embolism are categorized into severe, moderate and slight risk factors. Severe are a patient who has a fracture of the lower extremity, knee hip replacement, MI within the last 3 months, spinal injury. Moderate risk factors come a patients on chemotherapy, hormonal replacement therapies, patients of thrombophilia, stroke, autoimmune diseases, and slight risk factors like we have seen cases of pulmonary embolism, patient had a flight travel and where they were immobilized for a longer period of time, laparoscopy, obesity, pregnancies, nephrotic syndrome. So these are the certain risk factors. So now let us understand, whoever if wants to volunteer. So everybody knows that there is a pulmonary thromboembolism, there is a clot in the pulmonary vasculature. So what happens after that? So when there is a clot, it causes an increase in the pulmonary vascular resistance and increases pulmonary artery pressure. So when a pressure in the pulmonary artery rises, it causes pressure back on your right ventricle. But the right ventricle is not good equivalent to your left ventricle, and it doesn't have that much capacity to hold that pressure, so it finally starts stretching and dilating. So what you actually see is there is a dilatation of the right ventricle and there is increase in pulmonary artery pressure. Because of this dilatation, your interventricular septum, which is there, it starts becoming flattening and it starts moving towards the left ventricle, and because of which the left ventricular filling, the diastolic filling, gets affected. And sometimes with this pulmonary embolism, you also get right bundle branch block. So because of that, there is a disproportionate time duration of the contraction of the right ventricle and left ventricle. So now just a question to all the youngsters. So there is a clot in the pulmonary artery, then why are you having an hypotension? Because I also, when I was making this presentation, so I was also like little shocked. So when I was reading the whole pathophysiology, so why does it happen? Anybody can just volunteer, it's just not an exam. But then, ma'am, there is a clot in the pulmonary vessel, so how your cardiac output is getting decreased? But there is no issues with the left ventricle. Yeah, so that is why. So the clot is in the pulmonary vessel, but that is causing a dilatation of the right ventricle, which causes shifting of the interventricular septum, and there is an increase in the time of right ventricular contraction because of the Frank-Starling's law. As the muscle fibers dilate, the stretch, the contraction power decreases, and that is why they take more time to pump out the blood from the right ventricle into pulmonary vessels. So that is why the diastolic filling gets affected, your preload, that the amount of blood entering into the left ventricle gets affected, and finally your cardiac output gets affected, and finally patient lands up with hypotension or shock. So why I just gave this brief information of the pathophysiology, because that will help in determining the severity of pulmonary embolism and decide the further treatment. So as we can see in this figure, as I have already said, it increases RV tension because of there is increase in demand, because if there is a pressure, the right ventricle has to contract more. So there is the coronary vessels get also affected, that leads to ischemia, and finally sometimes they develop right ventricular infarction. And sometimes it might present as a chest pain, hypotension or a syncope, and you might feel it is an acute coronary syndrome, but it actually turns out to be a pulmonary embolism. So what symptoms, what patients you all have seen with symptoms? Sometimes patients just can be asymptomatic. You did a CT scan and you came to know there is some segmental embolism. Sometimes patients come with dyspnea. So dyspnea, when a person comes with the dyspnea, it is mostly suggestive of that the patient chances of having a moderate to severe pulmonary embolism. Because if it's a segmental or subsegmental, the chance of hypoxia or desaturation are less. Patient presenting with chest pain can be two possibilities. One, because of the segmental embolism leading to pulmonary infarction, which can lead to pleuritis and cause chest pain, or if there is a saddle thrombus, a big thrombus in the central pulmonary vessels, it can ultimately lead to right ventricular infarction and can cause a chest pain like an angina. So this is how a patient can present to you. Then you can have cough, you can have syncope, or you can have hemoptysis. This similar patient also I had. I am not describing your cases, I am just trying to give practical information so that when the patient comes to us in the casualty or no, we should know how to manage it. So similar patient, I had a post-COVID vaccination young chap. He came to me with a history of cough with hemoptysis 4 to 5 days. There was a patch in the right lower lobe. We got the plain scan done. Somehow contrast was not done. So it showed a right lower lobe pneumonia. We were treating with the antibiotics, we were not settling. We did a bronchoscopy also. So there were little streaky hemoptysis, but still the hemoptysis were not settling. Then finally we decided we do a contrast. So contrast was done. The radiologists were not present at that time. The contrast was done. The patient went to the ward. He gave a call back in the ward, called the patient back, and there was a clot in the right lower lobar pulmonary artery, and that was the reason for the infarction as well as for the hemoptysis. So a patient coming to you with a hemoptysis, with a patch which is peripheral and subpleural, always do a contrast, because you never know, it can be a consolidation, it can be an infarction. What signs you can get? Because of hypoxia, you can have patient will have desaturation, tachypnea. Tachycardia is the most common feature. You can have fever, loud pulmonary component of the second heart sound, hemoptysis. Along with that, if you have edema feet, so that tells you that the person probably has a DVT and that has caused the pulmonary embolism. So now this is the test which can be done in the bedside, which everybody might be knowing it. One is the Geneva score and one is the Wells score. So Wells score, it is to be done just a bedside. So if you have any signs of DVT, the score is 3, And if you feel it is classical case of pulmonary embolism, there is no other reason for this, then the score remains 3. And if a patient has hemoptysis, tachycardia, or a patient has malignancy, everything is given 1 point. And if a patient has a previous history of DVT or recent surgery or immobilization, both are given 1.5 points. So if your well score is less than 4, then the chance of pulmonary embolism is unlikely, and if it's more than 4, it is likely. Why this test is important? Because when you are asking for any further test, this tells you how aggressive you have to be for the diagnostic workup. Because with this score, if your score is 0 to 1, is a low test probability of pulmonary embolism. If it is 2 to 6, it is intermediate risk of pulmonary embolism, and if it's more than equal to 7, it's a high probability of pulmonary embolism. So there is this criteria everybody knows, but as I was also reading up, there is one criteria that is called as pulmonary embolism rule out criteria. So if your age is less than 50 years, if your heart rate is less than 100, saturation more than 94, no unilateral swelling, no hemoptysis, no recent trauma surgery, no history of venous thromboembolism, no oral hormonal intake. So these are all the factors, they are risk factors which actually lead to your pulmonary embolism. So in the emergency department itself, you can try it, this is very less likely to have a pulmonary embolism. So what investigations? So if a patient coming in an ER, if a patient, I did the scoring and I came to know there's a clinical test probability is very high. So I can ask for a D-dimer, it might take time. I will certainly first ask for a 2D echo, check, I'll ask explain the next slide what to be seen. If there is some evidence suggestive of pulmonary embolism, I'll directly go for a CTPA. I will not wait for the D-dimer report to come, because that precious time patient can go into collapse state. So we ask for a D-dimer, CBC, renal function test, APT-INR, ECG, echo, CT pulmonary angio, VQ scan, and ultrasonography of the lower limb. Sir, just a question to Dalal sir. Sir, normally because you have experience in so many years, what frequent ECG finding normally might be seen in a patient with pulmonary embolism? Everybody says S1, Q3, T3, but we hardly see that ECG findings. Yes. So normally what the most common finding which you see is one is sinus tachycardia. You can have a strain pattern, you will have right ventricular hypertrophy, sometimes you can have a P pulmonal. That the classical S1, Q3, T3 is very rarely seen. And if it is seen, trust me, then the patient has a moderate or a severe pulmonary embolism. It can't be a mild pulmonary embolism. So there are certain clues which I am trying to tell you, that if you get these findings, like if a patient has S1, Q3, T3 or certain echocardiograph findings, then the patient is bound to have a moderate or severe pulmonary embolism. Don't waste time in doing D-dimer or other investigation, directly go for a CT pulmonary angio. So this is the ECG, as you can see S1, Q3, T3. So echo findings. Dr. Nitesh might be there. So initially I also was never bothering to see whether he has written RV dysfunction, not written, but these things are important. So when you see RV dysfunction, means the right ventricle is being affected, it's not contracting properly. The classical thing, if you are not able to speak to a cardiologist, tell him I am suspecting pulmonary embolism. In 2D echo, he will see whether the right ventricular hypokinesia is there or not. And the classical finding which you see is the apex of the right ventricular is spared. The mid and the base is there is hypokinesia, and the right ventricle divided by the left ventricle diameter, it becomes more than 1. And if you see a clot in the right ventricle, or if you see there is one pressure called as TAPSE, that is tricuspid annular plane systolic excursion. If it is less than 16 mm, it tells you that the patient is in moderate to severe pulmonary embolism. So what kind of a thrombus is this? Any radiologist resident, sorry, not to Dr. Prachi. Anybody can just comment, which saddle thrombus. So madam only said saddle thrombus. What is this? Left main pulmonary artery. Segmental. Now what is the difference in the last one? Anyone? In the other three there was no pulmonary involvement. The fourth has a pulmonary involvement. Infarct. Yes. So that is why I specifically saying this. So if you see this, the first and the second, normally we go into your intimation high probability, moderate to high severity, but the lower two, they are normally the low risk category patients, because they are segmental embolus. So they will never come with you with hypotension or in a shock state. So if a patient lands up in an emergency, patient, how you can assess the severity of pulmonary embolism. If a patient coming to you with a cardiac arrest or hypotension, it's a severe pulmonary embolism. Just to rule out other cause, do an ECG, no MI changes, do an echo. Echo is showing RV dysfunction, pulmonary pressure is high, and there is IVC congested. There is a definitely we are dealing with pulmonary embolism. You can actually thrombolize it even without wasting time for a CTP or a D-dimer. So if a patient coming to you with a cardiac arrest, you do a CPR, you have to give oxygen and fluid management and simultaneously thrombolize. Second is obstructive shock. What is shock? Shock is nothing but your systolic BP less than 90, or vasopressors are needed to maintain the BP more than 90 along with end organ dysfunction features like cold clammy skin, altered mental status, anuria, or serum lactate levels are increased. So if you have this, there is a patient in an obstructive shock state. And the third is persistent hypotension. There is a BP is less than 90 or BP systolic fallen by more than 40. So if a person is hypertensive and his BP remains 160 and if he lands up in emergency with a BP of 100 by 60, you should not be saying that the patient is not in a shock. Patient is in a persistent hypotension, and if it remains for 15 minutes, even after giving fluid or whatever management and ruling out sepsis, any new onset arrhythmias. So then is in a shock. So these are all features of your severe pulmonary embolism. So clinical parameters I have already discussed. These things we are taking to find out to segregate severity wise, whether it's mild, moderate or highly severe patient of pulmonary embolism. Sorry, it's low risk, intermediate risk and high risk. Clinical parameters like tachycardia, hypotension, desaturation. Imaging wise, you see RV and LV diameter if it's more than 1. If you see a clot, I said TAPSE less than 16 mm, or on a CT pulmonary angiography, they sometimes also tell us that the diameter of the right ventricle is more than left ventricle. That tells you that the RV is dysfunction. Why CT pulmonary angio is important along with 2D echo? Because sometimes along with just clot, you can also get other features to diagnose, whether there is infarction, whether there is any other airway disease or any underlying malignancies which can also contribute to a pulmonary embolism. Laboratory markers, as Dr. Amit sir has already discussed about cardiac troponin I and trop-T and NT-proBNP. These markers are important. Why? Trop-I and trop-T will tell you that RV is injured. But what is the use of NT-proBNP in pulmonary embolism? Anyone? Right heart failure. Why does it increase? So as pulmonary embolism, there is a dilatation of the right ventricle. So whenever there is a stretching, this your BNP is released. So whenever this is getting high, so that means your right ventricle is getting dilated and going into a failure. So this all markers help you in prognosis, not for your diagnosis. So there is one index called pulmonary embolism severity index. I'll just brief in short. Its age is, if more than 80, you give 1 point, and other. Here we take into consideration other comorbidities like chronic obstructive pulmonary disease, chronic heart diseases, or if a patient has saturation less than 90%, they are given certain points. And all this together help in segregating patient into the severity, to find out how is the possibility of early within 30-day mortality with a patient of pulmonary embolism. So you categorize into 3 categories: high risk, intermediate and low risk. High risk patient has to be admitted in the ICU. You have to thrombolize it unless and until if there is contraindication for thrombolysis. Intermediate, this is the main crux. It is further divided into high risk and low risk. So intermediate category, the patient will be hemodynamically stable. The PESI score which I have discussed is more than 1. Both will be positive. RV dysfunction on imaging or with the elevated cardiac markers. If both are positive, it goes in the intermediate high category. If either of it is positive, it goes intermediate low risk categories. Why I am saying? Because intermediate high risk categories, you have to be very careful with the patients. You have to monitor them. If they are getting drop in BP or hypertension or desaturation, you will have to give a rescue thrombolysis to these patients. Low risk category patients, they will not have elevated markers, no RV dysfunction, nothing. Elevated markers might be sometimes positive but not major problem. So if a patient comes to you in a casualty with a suspected pulmonary embolism, first see whether this patient is stable or unstable. If patient is unstable, do a 2D echo, find out RV dysfunction present, not present. If RV dysfunction is present, likely to be a pulmonary embolism, possible to get a CTPA, get it done, thrombolize. Not possible, still you can thrombolize it. If RV dysfunction is not present, check for any other cause for your cardiac hemodynamic instability. But if the patient is hemodynamically stable, you did find out from the well score whether it's a low risk or intermediate or high probability of pulmonary embolism. Get a D-dimer. As I said, if it's a high probability, don't waste time for D-dimer, directly go for a CTPA. But if it's a low or intermediate, do a D-dimer. Positive, do a CTPA. If it's negative, you can rule out because it's a negative predictive value is very high. Now one more thing, if a patient coming to you with the age of 70 years and a D-dimer of 600, is it worth or no? Because the normal cutoff is 500. So whenever a patient of pulmonary embolism, if I give the reference to Dr. Anuji, you always used to ask for a D-dimer levels. So I used to say, why is he asking D-dimer? He's already diagnosed case of pulmonary embolism. What is the use of this D-dimer? Because sometimes it tells you the load of the thrombus. So instead of a cutoff of D-dimer that is 500, we use age adjusted D-dimer. That is after 50 years, it is age into 10, that is 60 into 10 becomes 600, 70 into 10 becomes 700, 80 into 10 becomes 800. So if at age of 80, if you get a D-dimer of 800, you can be relaxed that there is a possibility that we are not dealing with pulmonary embolism. And most of the times, when a patient with pulmonary embolism, normally the D-dimer are more than 3 times of your normal cutoff. So treatment wise, everybody discussed with oral anticoagulants, heparin, Clexane, everything. So if a patient is hemodynamic stable, no contraindication to anticoagulation, you have 3 options. You have heparin, unfractionated, you have low molecular heparin, you have fondaparinux. Fondaparinux is depending on the weight, less than 50 is 5 mg, 50 to 75 is 7.5, more than 100 is 10 mg. If patient is stable, can be discharged in home in a day or 2, you can directly start with NOACs, rivaroxaban, dabigatran or apixaban. Now the major part comes regarding thrombolysis. As Jayashree madam was asking regarding thrombolysis, there are 3 ways you can remove the clot. One is thrombolysis systemic, which we give through IV. There are 3 drugs which have been approved by the FDA. One is your RTPA, that is alteplase. Tenecteplase, retiplase have not been approved by FDA. Alteplase has to be given in an infusion over 2 hours, 100 milligram. Second is streptokinase and third is urokinase. These 3 are approved. If you cannot do thrombolysis because of some certain reasons, what other options are available with us? Surgical embolectomy. So if a patient is very hemodynamically unstable, patient is coming in a shock state, what you will do? Then we'll have to call Amit sir. Sir, can we do IBP in a patient with pulmonary embolism with shock? No. So here comes the role of your ECMO. So ECMO takes time for your heart and lungs to settle down, take over, and then you do call Dr. Anirudh and do a catheter directed lysis or thrombosuction. Third option is surgical embolectomy. So catheter wise, there are multiple options, probably Dr. Anirudh has said, but what is there in the literature, either you can do aspiration, you can do ultrasound wise, or there are catheter wise. And third, which he does it, he does little aspiration and he injects your thrombolytic agent inside. So that is called a pharmacomechanical approach. Why this method is beneficial? Because the dose which you are using here is half than you are using systemic, so the chances of bleeding are less. So this is how you can do a thrombolysis. So as I have already said, urokinase, streptokinase and alteplase. Streptokinase is 250,000 international units over 30 minutes, and then you have to give infusion dose 1 lakh international units per hour over a 24-hour period. Alteplase is only 2 hours duration. IVC filter, as is already discussed. We had one patient here. This patient was about to get operated because of some uterine malignancy and she had extensive DVT. So what you can do is, should we put an IVC filter, do surgery and then put an IVC filter? Why? Yes, so that is why we had inserted an IVC filter first and then we had told them to take for the surgery, because there was a high possibility, because the duration of the surgery would have been long, there would be a possibility that the clot might have dislodged up. So there are certain absolute contraindications. So one is when you don't want to refer patient to Anirudh, that is the absolute contraindication. And a patient who cannot be anticoagulated, if there is contraindications, complications of anticoagulation like bleeding issues, relative contraindication, these are the indications for the filters. Relative are when you have a free-floating thrombus in the DVT, when you have limited cardiopulmonary reserve, poor compliance with anticoagulant therapy, and where you know there is a high chances patient will develop recurrent DVT and pulmonary embolism, you put in an IVC filter. Ideally, you have to keep filter for 3 to 6 months maximum, but when you know the patient is not going to be compliant with the medication, you can keep it lifelong, assuming little risk of the IVC filters. So this is last of follow-up. So when you thrombolized it, should we leave this patient after 3 months, or what we should do it? What sequelae can occur after thromboembolism? Anyone? Pulmonary infarct. Sir, infarct happened before only. After 3 months. So, after 3 months I will send to you to get an echo done to look for pulmonary hypertension. Why? CTPH. To look for chronic thromboembolic pulmonary hypertension. Because sometimes the clot doesn't get dislodged properly. They sometimes develop a linear eccentric thrombus and can lead to chronic thromboembolic pulmonary hypertension. And this is the pH which we have to treat it with a pulmonary vasodilators. So there are multiple options are available. So, and the ideal modality of choice is VQ scan for a CTPH, not a CTPA, because it helps in finding out the ventilation perfusion mismatch defects. Okay, so I decided to shift patient to a NOACs. Which would be the preferred NOACs? Which, when, and for how much duration? I know everybody is covered, but just a brief. So let's see whether everybody was sleeping in the morning time or not. So example, I'll ask certain questions. If a patient has an APLA, would you like to give dabigatran, apixaban, rivaroxaban or warfarin? Why? Then you give that answer also. Is for warfarin. If a patient is on heparin and LMWH and you want to shift to warfarin, questions to the juniors, would you like to overlap or you can directly shift to warfarin? How many days? She is selling 3, she is selling 5. Okay, I would like to give it overlap till my PT INR is between 2 to 3. And if still your INR is not between 2 to 3, then? So that is why. So you have to give an overlap minimum of 3 days, but then you have to monitor your PT INR. It has to be between 2 to 3. Then you can stop LMWH or heparin and then shift to your NOACs. How much duration? If there is no identifiable risk factor, patient no fracture, nothing, just diagnosed with pulmonary embolism, for how many months you would like to give NOACs? 3 months. Why not 6 months? 9 months? No, there is no identifiable risk factor. Nothing. Everything is negative. And you cannot do thrombophilia workup during the episode of pulmonary embolism. Okay, so ideally it is said to be 3 months, can sometimes extend it to 6 months, but normally it is said for 3 months if there is no identifiable risk factor. A patient with APLA has to be given lifelong vitamin warfarin. In a patient of malignancy, we normally give lifelong NOACs. So after 6 months, what will be the dose of apixaban? Normal dose of apixaban is how much? Therapeutic dose? 10 mg BD for 7 days followed by 5 mg BD, and after 6 months you decrease it to 2.5 mg BD. Okay. Thank you very much. Sorry. Pulmonary embolism rule out criteria is there. No, so that by mistake it is then, it is more than 94. Yeah. So you were awake, ma'am. Thank you. So it is more than 94%. So this criteria itself, if you do in emergency department, you can be pretty sure that you are less likely to be dealing with pulmonary embolism.
Excellent presentation. Very clear, and I'm surprised all the RMOs were awake. Good.
Any questions? Just one question for you, Prajay. When would you use a VQ scan?
So VQ scan, there are certain indications. One, when your creatinine is high, you cannot do a CTPA, we will do a VQ scan because it hardly needs any contrast. Second, when especially with pregnant patients and a patient who are allergic to the contrast dye, you should go ahead with a VQ scan, and for patients with CTPH.
Thanks, Rajay. That was an excellent presentation. Thanks.
It needs a different, it comes in a different department actually, nuclear medicine. So probably when we are probably getting the PET scan, that time we might get that.
Want to include a X-ray chest in this?
So X-ray chest, one second, I don't know whether I have written or not. Yeah.
Doing a
So-
scan is expensive.
So X-ray normally in a pulmonary embolism comes normal. Only X-ray finding benefit would be to just look for any other causes. If you have a consolidation or an infarct, you can get that particular patch. Otherwise, chest X-ray is most of the times comes normal. Only sometimes you might get dilated pulmonary artery.
What about those wisdom and
That is
and all?
probably just all theoretical. Hardly we get to see.
Is it only theoretical?
Yeah, theoretical.
Okay.
You can see the infarct.
Amit sir, question to you. Eisenmenger syndrome with or pulmonary embolism, how can we differentiate? Who's critical?
Eisenmenger is mostly a clinical diagnosis, so we normally see the echo, and if we see a reversal of shunt on the echo, mostly Eisenmenger's. But your D dimer may be negative in Eisenmenger's.
Cardiac triage also might be negative in Eisenmenger's. Any other questions? Sir. Thanks.
I would request Dr. Rashid Wasi sir to give a token of appreciation to Dr. Prajay. Thank you, respected chairpersons. Okay, so we start with the quiz. I think the PGs will be keen to join us on the stage. I would request to just place the chairs. I would request Dr. Vijay Dalal sir, Dr. Sanjeev Khanna sir, Dr. Susan madam, and Dr. Amit Sharma sir to kindly come on the front seat here itself. Do we have Dr. Azhar here? Okay. So, Dr. Rahul, you can come over. You can join the team instead of Azhar. Okay, so I would like to invite on stage. So how we'll do it is, team RBC is left, WBC, platelets and plasma. Okay, so I can't call that. So team RBC, Dr. Himanshu Yadav, Dr. Simran Keshwani and Dr. Nikita Jadhav. Kindly take your places in order 1, 2 and 3. Team WBC, Dr. Ajitesh, Dr. Rahul and Dr. Amreen. Team platelets, Dr. Sheldon, Dr. Parul Sinha and Dr. Ashwin Kumar. And the last team, but not the least, team plasma, Dr. Drushti, Dr. Shambhavi and Dr. Nidhi. Kindly have a bit of spacing amongst the teams or get together as a team. No, don't come here, you will not be on the camera. Okay, so we have just swapped a bit of meaning. Let's get attention done with first with the extempo. Okay, so we start with first team RBC. Just pick up any number from there. Pardon, 9? Okay. So you are number 9. Preventing stroke in atrial fibrillation, anticoagulation options. Who is going to speak on this? Simran? Okay, come over.
Good afternoon, everyone. It's an honor to be here today. Medicine is an ever-evolving subject. Anything we speak on today is going to be changing in the next few decades. I would like to speak on the topic preventing stroke and atrial fibrillation, anticoagulant options. Most important thing, atrial fibrillation would be diagnosing what cause of atrial fibrillation it is, valvular versus non-valvular atrial fibrillation. Choice of drug for valvular atrial fibrillation, as we all know, is vitamin K antagonist warfarin. We don't use NOACs in those because they have not been studied extensively. Choice for valvular, non-valvular atrial fibrillation is NOACs that we use as apexaban, rivaroxaban. Apexaban, as we already discussed, dosing 5 milligram, 10 milligram BD for 7 days, then 5 milligram BD for 7 days, and then continued anticoagulation options according to the CHAD-VAS score, which we calculate according to CHAD-VAS. And the diagnosis of atrial fibrillation being the most important. Thank you.
There is a question answer as well. There are 2 questions. The entire team can support if required. From the judges, you can ask.
Recurrent atrial fibrillations, any other modalities of treatment?
Sorry.
For anticoagulation or any other treatment?
So treatment, radiofrequency ablation.
Supposing you diagnose that there are clots in the left atrium and you cannot anticoagulate this patient, then what would you do? Any surgical options?
Left atrial appendage removal can be done for a left atrial clot where we can't anticoagulate.
Clamp the left atrial appendage or you can
remove it.
So Sibyl, my question is, what CHA-2DS score do you anticoagulate, and what CHA-2DS score you would not anticoagulate?
So CHA-2DS score more than 2 to 3 we anticoagulate, less than 2 we don't anticoagulate. But again, CHA-2DS score with females age more than 60 already goes up to more than 2. So most of the patients end up.
So age and female, if these two parameters are there, and if the age is more than 65 years of age, then automatically it's an indication for anticoagulation.
Only 2 questions. Somebody with mechanical valves whose PT-INR has gone close to 4.5 and she has atrial thrombus, how would you manage her?
First thing is if she's presenting with bleeding or not bleeding. If she has presented with bleeding, we immediately hold the anticoagulation. We try to reverse the anticoagulation because we need to stop the bleeding therapeutically at that time. And then again, after 7 to 10 days, we will re-evaluate the patient and redo her INRs, and then we eventually will require long-term anticoagulation again.
Do you know from where the term warfarin has come?
Rodent, it was discovered in the morning only we discussed it.
Anyone? Anyone from your team? Himanshu?
Yeah.
No.
Yeah.
Sorry?
That is
So it's WARF is Wisconsin Alumni Research Foundation. And that's from there they brought warfarin. And of course the history is from the plant where they found people and the animals were bleeding. So suppose you see a patient, Simran, who's got clots in the left atrium but now is in sinus rhythm. Will you presume that all is hunky-dory, you leave it? What are you going to do?
So first, if she presented to us in what condition? If she presented us with
she's got some sort of a neurological stroke or whatever. And now what are you going to do?
We have to choose to anticoagulate her with the risk of bleeding in mind. Depending on her GI, if she has had active GI bleeding, what medications she is on other than that, because with WARF, if we are considering any enzyme inducers if she is on, and then we have to, with the risk of bleeding, we should choose to anticoagulate her if she has an LA clot.
No, why are you bringing in bleeding? I said she's got a clot, she's thrown an embolus, now but the rhythm is sinus.
So we will choose to anticoagulate.
Okay, good. The answer is that very often patients who have atrial fibrillation will come to you in a sinus rhythm, because when they are in sinus rhythm the atrial kick is much better and the chance of embolization is much better, okay, rather than in AF. Am I right, Amit? Yeah. So you must be on guard that just because there is no AF doesn't mean that you want. You will anticoagulate. Good.
Thanks, sir.
So fantastic team RBC. Next we come to team WBC. Guys, which number? 2? Okay. So what's behind 2? Impact of COVID-19 on thrombosis, lessons learnt. Who is going to go ahead? You.
Good afternoon, everybody. So COVID-19 was one of the most important event that happened in the history of mankind. It was the first thing that even we were able to witness. So COVID-19, the whole pathophysiology is all about the cytokine storm. And in the cytokine storm, there's a lot of inflammation that is going on, which can lead to thrombosis. Initially, it was only limited to the pulmonary problem. But then later on, we realized it's not only involving the lungs, it's also involving the major organ like kidney, brain. So there are a lot of patients who are coming with the thrombus. So that COVID-19 is actually leading to the hypercoagulability, and the main mechanism is the cytokine storm. So the main treatment was to first stabilize the patient of whatever the problem they have come with. Either they can come with ARDS, that was the main pathophysiology of that, and sometimes the patient used to come with MI. There were a lot of patients who used to come with stroke also, and obviously we have seen the impact of vaccine in our day-to-day population, like the side effect of vaccine. So the whole thrombosis leading is because of the cytokine storm. And the pathophysiology is the interleukin 16, interleukin 1, and we were hitting with the target drug like immunomodulators for that.
Which was that drug?
So it started with, there was some drug which were like tocilizumab, we used to hit it, yeah. Yeah, so there were some studies on tocilizumab also.
Why do you get thrombosis in when you vaccinate a patient with the COVID vaccine? What is the mechanism?
So I think it was because of antigen antibody mimicry. Because of that, there used to be thrombosis. That whole hypersensitivity reaction used to happen.
I think it was antibodies to the platelets which activate the platelet aggregation over there.
Yeah, so that platelet aggregation reaction, yeah.
Since you've explained it so well, Amreen, could you tell us which country in the world autopsies were done which showed us the way forward with the COVID pathophysiology?
The country, I'm not sure about it, ma'am, but I think it was
Italy. Huh? The autopsy done.
It's from Europe.
Europe, Sweden, or some?
No, Italy.
Italy, okay,
The first
yeah.
autopsies from Italy showed us that.
Autopsy studies were all from Italy.
Okay.
But Sweden is very close.
Yeah, because there was some Zoom call which
Not geographically, but Sweden also did a lot of autopsies. Yeah, because they have very fine post-mortem registry, and anyone who dies is almost forced into an autopsy. You just can't get away. So Sweden is great.
Which vaccine causes the maximum thrombosis? Which type of? There were 3 or 4 types, no?
हाँ? Fire क्या? Fire अरे नाम बताओ. हाँ? Covishield, I think it was the one that used to go. AstraZeneca, yeah, Covishield. It was immuno. No, it was live attenuated one. Adenovirus. Yeah. Antiplatelet, and then we used to, that heparin intrinsic factor, something was there. Yes, sir.
But the main thing was the antibody formation.
Yes, sir. That leads to heparin-induced thrombocytopenia. HIT used to happen in this kind of patient. Yes, sir. Yes, sir.
Thanks, Dr. Amreen.
Yeah.
So, team platelets? 5? Okay. Let's see, Dr. Sheldon. After the watch, do you win something? Pulmonary embolism in ICU management strategies. Who is going to speak on it? Five minutes is the talk in front.
Good afternoon, one and all. I would like to speak on the topic pulmonary embolism in ICU, the management strategies. So, pulmonary embolism and venous thromboembolism as such is very common in ICU patients because most of them are critically ill, most of them are in sepsis, most of them are bed bound, and also post-operative patients can be seen in the ICU. So, this leads to hypercoagulable state and stasis, which leads to thrombus formation as per the workhouse triad, which includes stasis, hypercoagulability, and endothelial damage. So, venous thromboembolism can be prevented initially by pharmacological and mechanical methods. So, once the pulmonary embolism has occurred, the patient will be dyspneic, which is the most common symptom, and tachypnea is the most common sign. We can do an ECG, in which the most common finding is sinus tachycardia, and S1Q3 T3 pattern also can be found, which is kind of specific for pulmonary embolism. So, once the pulmonary embolism has occurred, we can do the D-dimer to see the thrombus load, and also we can categorize it as massive, submassive, or non-massive pulmonary embolism. Massive pulmonary embolism involves drop in systolic blood pressure less than 90 for more than 15 minutes. Non-massive is, you can see the echocardio findings of right ventricular akinesia, and non-massive pulmonary embolism will not show any of these two findings. So, as such, thrombolysis is indicated when there is massive pulmonary embolism, and thrombolysis, the drugs approved are streptokinase, urokinase, and alteplase. Altiplase is given as 10% bolus dose and then infusion over 1 hour. And also you can, after the thrombolysis has been done in massive pulmonary embolism, we can shift them to oral DOAX or NOAX. In non-massive and submassive, pulmonary embolism, we can go for unfractionated heparin or low molecular weight heparin as indicated. And finally, we can shift them also to on DOAX for a period of 3 to 6 months or indefinitely as per the underlying cause. Thank you.
Any other investigations to confirm the diagnosis before you start your treatment?
So we can go for a CTPA, which is the gold standard investigation. And if it is inconclusive, we can go for a VQ scan also.
What is the criteria that you use for an immobilized patient? Is there any clinical criteria you use for diagnosis?
So Wells criteria.
Okay.
Modified Wells criteria, which
modified Wells criteria.
Yes, sir.
When you have a severe pulmonary embolism and you said there's hypotension and there's tachycardia, how would you differentiate? You know, you're rounding every day, you're seeing the same patient, you said multi-organ failure, patient in sepsis. Any which way the patient in sepsis is having all those symptoms. How would you differentiate between that and a pulmonary embolism?
D-dimer levels can tell us about the...
You're rounding and you don't ask for D-dimer all the way.
Sepsis, we can do a transthoracic echocardiography. It will show typical right ventricular free wall akinesia, but at the apex the motion abnormality will not be seen. And also we can do a triage also to see the NT-proBNP and the troponin I levels also, ma'am.
A CBP line at that point of time makes any difference to you diagnosing
CBP
the
line, yes, ma'am. We can check the increased right atrial pressure.
That would be the diagnostic differentiation, no? Because otherwise you have a hypotensive patient on all fronts with a low CVPI. But I think that CVP would be something that would guide you with differentiating the two.
Yes,
ma'am. So, taking a question a little backward, you are on rounds, you got immobile patients. How will you see the patient daily to prevent this from happening, prevent an acute PE from happening?
Sir, in cases post-op patients, we can, if early ambulation is possible, then we can start early ambulation, and if it is not possible...
So we are talking of immobile patients.
Immobile patients, then we can start them on anticoagulation earlier.
Everyone?
Those who have undergone major surgery and those who are expected to be immobile for a longer period of time. And we can start mechanical methods also, like pneumatic compression stockings, and early physiotherapy also can be initiated.
So you watch every day for calf tenderness, okay? And okay, any other signs you look for in the lower limbs?
Some Moses sign is there, Homan sign is there.
Very good.
Neuhoff sign.
Excellent.
And Leydig sign.
Thanks. So he is from which team?
He is platelets.
So we have to mark.
Yes. Okay. The next one? Okay. So team plasma, which is your number? Your lucky number? 7? Okay. So number 7 has balancing bleeding and thrombosis risk in acute coronary syndrome. Guys, you need to decide quickly. Lucky, not so lucky, is it?
I did neuro. हाँ, मुझे नहीं पता. Okay, so acute coronary syndrome mainly presents to us includes ST elevation, MIs. So the first thing is we start the patient on thrombolysis. The drugs which are used for thrombolysis will include streptokinase, tenecteplase, retiplase. Overall, the bleeding risk with streptokinase was more. That is why we had switched to tenecteplase and retiplase. Tenecteplase, the dose being 40 mg per kg, and retiplase given at 15 minutes interval. Retiplase, overall the bleeding risk is less, that is why it is better to use the retiplase. Tenecteplase also bleeding risk relatively less. Streptokinase used to have a lot of bleeding risk, and that is why the this has reduced the use. For thrombosis, to balance the bleeding and risk of thrombosis, the main aim for using these was for the thrombosis in MI. When the patient, suppose if we are thrombolizing the patient comes to us with bleeding, patient starts developing bleeding, the first thing is to stop the thrombolysis, and reversal can be for streptokinase, it will be using fresh frozen plasma. Serum fibrinogen can be monitored in these patients, and FFP can be used to stop, and the same with tenecteplase and retiplase and and overall, once the patient is stabilized and the bleeding has reduced, then we can start the patient on antiplatelets and statins to further manage, and INR monitoring, of course.
Streptokinase has the least fibrin specificity. That's why the risk of bleeding is very high in that case. So potentially bleeding in a STK patient is worse than having it in the other patients. That way. But potency of your the fibrin specific agents like tenecteplase is much higher than streptokinase. So if the patient has any bleeding, if he does, then it is more in tenecteplase. So risk of bleeding is more in STK, but the magnitude of bleeding is more in tenecteplase.
You've thrombolized a patient, seems to be doing much better, and then suddenly the patient complains of a severe headache. You send him down for a CT and he develops a bleed. He has got a CVA. Explain to the relatives how he has developed a CVA.
So, ma'am, initially anytime whenever we thrombolize, whether it is for MI or for a stroke, we anyway explain the risk of bleeding to the patient. So, anytime we are thrombolizing the patient, we anyway have to take a consent and explain the patient that the bleeding might happen. Once the bleeding has happened, the first thing is going to be ABC, airway, breathing and circulation. So, first we'll have to explain to the relative that we will have to secure the airway, intubation if required, stop the antiplatelets, anticoagulants, intubate the patient if required, and start anti-edema measures, and SOS if required, decompressive craniotomy has to be taken care of. But we will have to tell them that we have to choose between heart and brain.
Patient says, I came for my heart and now my brain is also.
But ma'am, that is what we must have explained further. And also it's always heart versus brain. So if we have managed the heart first, but if the brain didn't take care, so we have to manage that also now.
What about the option of a PAMI? Option of PAMI that did you give the option of PAMI to the patient?
Not now, ma'am. If the patient is bleeding, then we will
earlier,
not
prior to that, was that also documented on paper? When was it documented on paper whether you gave the option of PAMI to the patient?
Yeah, we always do, no?
Always doing everything.
So maybe then you should have done PAMI instead of giving any of these fibrinolytic agents.
Or not, no, maybe. But so risk of bleeding is not something which we can predict. No, even after PAMI, it's not like the patient is not going to bleed or he will not.
But you're not using thrombolytic agents.
Yeah.
You're using only heparin,
So if they had
which
to.
is reversible.
Yeah.
Good.
Okay, I think now we are done with the extempo rounds. A clap for all the participants who have literally come out of their way to attend this. Okay, so we'll now be going into the quiz section. I would request the mic to be passed on as you keep going. Okay. So it's a point for a correct answer and no points for a wrong answer. I would request tallying to be done later on. Judges can give the papers after the marking is done, so that we can tally the same. So we start with the normal questions. I'll be going 2 questions per team, and it will keep on going ahead. And we go topic by topic. You will not get the questions here. You just have to listen to me. Okay. So team RBC, a 70-year-old male presents with a sudden onset pain, pallor and pulselessness in the left leg. What is the most common cause of acute limb ischemia? Is it A, atherosclerotic plaque rupture, B, embolism, C, vasculitis, or D, trauma? A 70-year-old male, sudden onset pain, pallor, pulselessness. Is it atherosclerotic, embolism, vasculitis, trauma?
Embolism.
Correct. 1 mark. A patient with atrial fibrillation develops acute limb ischemia. What is the likely source of the embolus? Is it
Heart.
Is it a DVT? It is a left atrial appendage. Is it a right atrium, or it's a popliteal artery aneurysm?
Atrial appendage.
Correct. 1 mark. Pass the mic to WBC, please. So, team WBC, which of the following is a gold standard for diagnosing acute limb ischemia? Is it Doppler ultrasound, DSA, CT, ABI? What is the gold standard for acute limb ischemia? Doppler, DSA, CT, ankle brachial index.
DSA?
Yes, correct. 1 point. Team WBC. In acute limb ischemia, what is the role of fasciotomy? Prevent embolization A, B, prevent compartment syndrome, C, revascularize ischemic tissue, D, treat the systemic acidosis.
Compartment syndrome prevention.
Correct. 1 point to WBC. Let's go to team platelets. A patient is diagnosed with Rutherford class 3 acute limb ischemia. What is the treatment of choice? Is it A, thrombolysis, B, surgical revascularization, C, primary amputation, or D, conservative management? It's a class 3 acute limb ischemia. Is it A, thrombolysis, B, surgical revascularization, C, primary amputation, D, conservative management? It's wrong. It's primary amputation. Class 3 is an irreversible ischemia. The second question to you, a 60-year-old male with an acute limb ischemia is started on unfractionated heparin. What is the primary goal of this therapy? Is it A, to dissolve the clot, B, to prevent a thrombus propagation, C, to increase the blood flow, or D, to stabilize systemic blood pressure? It's an old male, 60-year-old male with an acute limb ischemia. What is the primary goal? Is it to dissolve the clot, prevent a thrombus propagation, increase blood flow, or stabilize systemic blood pressure? Yes, correct. 1 point. Prevent thrombus propagation. Okay, team plasma, the lucky team. What is the most appropriate anticoagulation strategy following successful revascularization of an acute limb ischemia? Is it low dose aspirin alone? Is it long-term anticoagulation? Is it clopidogrel and aspirin? Is it no anticoagulation required? Okay, so the options are low dose aspirin, long-term anticoagulation, clopidogrel and aspirin, that is antiplatelet, and no anticoagulation required. After successful revascularization, option A is low dose aspirin. Option B is long-term anticoagulation. Option C is clopidogrel and aspirin, and option D is no anticoagulation required. Wrong answer. Okay. The right answer is long-term anticoagulation. The second question to you, what is the primary mechanism of ischemia reperfusion injury after revascularization of an acute limb? Is it number 1, direct thrombus toxicity, B, free radical generation, C, persistent vascular occlusion, or D, hypoxia-induced cell death? Yes, correct. Okay, so we are done with the acute limb section. Now we come to the acute MI section. So, team RBC. A 62-year-old male presents with chest pain and ST segment elevation with a myocardial infarction, STMI. Coronary angiography reveals a thrombotic occlusion of the LAD. What is the most appropriate treatment, initial treatment? Is it A, oral anticoagulation? Is it B, intravenous streptokinase? C. Primary percutaneous coronary intervention, that is PCI, or D. Aspirin monotherapy?
PAMI.
Yeah, correct. 1 point. Second question to you. A patient with STEMI undergoes PCI and stent placement. Which medication is essential to prevent a stent thrombosis? A. Warfarin, B. Dual antiplatelet, C. LMWH, D. Beta blocker.
B.
Correct. 1 point. Okay, so team WBC. A 68-year-old male with STEMI undergoes thrombolysis with tenactiplase. What is the most reliable sign of successful reperfusion? Is it A. Persistent chest pain, B. Resolution of ST segment elevation, C. Appearance of Q waves on ECG, or D. Normalization of troponin levels?
Option B.
Yeah, correct. 1 point. Which imaging modality is most appropriate to diagnose a left ventricular thrombus after an anterior STEMI? Is it A. Cardiac CT? Is it B. Echocardiography with contrast? Is it C. Coronary angiography, or D. MRI of the chest?
Can you repeat the question?
Imaging modality which is most appropriate to diagnose an LV thrombus after an anterior STEMI. Is it cardiac CT, echocardiography with contrast, coronary angiography, or MRI of the chest?
MRI of the chest.
Hey, ruk jao na. Only one option. The answer is echocardiography with contrast. Okay. We go to next, team platelets. Guys, only one person should answer, meaning if whosoever is the first, the answer will be taken into view. Okay, team platelets. A 64-year-old with recent anterior STEMI develops a new embolic stroke. What is the most common underlying cause? Atrial fibrillation, option A. Option B, septic emboli. Option C, left ventricular thrombus. Option D, coronary artery dissection. A 64-year-old with recent anterior STEMI develops a new embolic stroke. Is it atrial fibrillation, septic emboli, left ventricular thrombus, or coronary dissection, artery dissection? Most likely cause. LV thrombus, correct. 1 point. Which antiplatelet agent provides the fastest inhibition of platelet aggregation in STEMI? Is it clopidogrel, is it ticagrelor, is it prasugrel, or is it aspirin? Fastest inhibition of platelet aggregation. Yes, correct. 1 point. Team plasma. The 70-year-old patient with STEMI develops a mural thrombus. What additional therapy should be initiated? Is it A, aspirin alone, aspirin with clopidogrel, anticoagulation with warfarin and continued antiplatelet, or thrombolytic therapy? Yeah, third, correct. 1 point. A 60-year-old patient with STEMI develops recurrent chest pain despite PCI. Repeat angio reveals no occlusion. What is the likely diagnosis? One is restenosis of the stent. The other is coronary vasospasm. Third is a no reflow phenomenon. And fourth is a new thrombus formation. A 60-year-old patient with STEMI develops recurrent chest pain despite a PCI. Repeat angiography shows no occlusion. So what is the likely diagnosis? Restenosis, coronary vasospasm, no reflow phenomenon, or new thrombus? The answer is no reflow. Okay, next we come to cancer-associated thrombosis. So team RBCs, a 65-year-old woman with metastatic ovarian cancer presents with unilateral leg swelling and pain. Duplex ultrasound confirms a DVT. What is the preferred initial treatment? Is it A, warfarin, B, LMWH, C, aspirin, or D, compression stockings alone?
LMWH.
Correct. 1 point. Second question. A 72-year-old man with pancreatic cancer develops a pulmonary embolism. Which of the following statements regarding this treatment is true? Okay. Aspirin is a preferred anticoagulant. Treatment duration should be limited to 3 months. direct oral anticoagulant should be considered based on bleeding risk, or D, he should be treated with thrombolysis. Which of the statements is true? Pancreatic cancer, 72-year-old man, develops a PE. Pancreatic cancer with METs, develops a PE. Aspirin is the first option, is aspirin is the preferred anticoagulation. Treatment duration should be limited to 3 months. Direct oral anticoagulant should be considered based on bleeding risk, that's C, or D, he should be treated with thrombolysis.
Thrombolysis.
DOACs. Okay. Okay. Pancreatic cancer, malignancy, apixaban is the drug of choice. Team WBC. A patient with recent diagnosis of lung cancer is started on chemotherapy. She presents with symptoms of a swollen arm on the left side and is diagnosed with an upper extremity DVT. Which of the following increases her risk of thrombosis? Number 1, her recent cancer diagnosis. Number 2, chemotherapy treatment. Number 3, central venous catheter placement. Or number D, a last option, all the above. Her recent cancer diagnosis.
All of them.
Her recent cancer diagnosis, her chemotherapy treatment, her CVP placement, or all the above?
All of the above.
Yes, correct. 1 point. In a patient with cancer-associated thrombosis, what is the recommended duration of anticoagulation? 6 weeks, 3 months, 6 months, or as long as the cancer is active, or 1 year?
Can you repeat the question?
What is the duration of anticoagulation in CAT? 6 weeks, 3 months, 6 months, or as long as the cancer is active, or 1 year?
As long as the cancer is active?
Yes, correct. 1 point, please. Okay, team platelet. A patient with colorectal cancer and recent DVT is considering anticoagulation options. She has a high bleeding risk. Which anticoagulant option is generally safest in cancer patients with a high bleeding? Is it warfarin, LMWH, aspirin, or heparin bridge to warfarin? This is team platelets. You understood the question? Okay. Colorectal cancer, recent DVT, safest option with a high bleeding risk. Warfarin, LMWH, aspirin, or heparin bridge to warfarin. So start heparin and then start warfarin thereafter. Which one? Which is one of the safer options? No phone usage, please. Oh, okay. We trust you. Yes, correct. 1 point. 50-year-old man with lymphoma presents with sudden shortness of breath and chest pain. Imaging reveals a PE. He has no prior history of clotting. What is the likely underlying mechanism of thrombosis in this case? Is it A, genetic predisposition? Is it B, inflammatory response to cancer? Is it C, recent surgery? Or is it D, all the above? A 50-year-old man with lymphoma presents with sudden shortness of breath and chest pain. Imaging reveals a pulmonary embolism. He has no prior history of clotting. Okay. What is the likely underlying mechanism of thrombosis? Genetic predisposition, inflammatory response to cancer, recent surgery, or all the above? You can't question a question. Just tell the answer yes or no. Yes, perfect. 1 point. Team plasma. A patient undergoing chemotherapy for breast cancer is found to have a proximal DVT. She has a low platelet count but no active bleeding. What is the best management approach? Option A, continue chemotherapy and observe. Option B, start LMWH and carefully monitor. Option C, prescribe aspirin. Or option D, use unfractionated heparin instead of LMWH. This is a patient undergoing chemotherapy for breast cancer and a proximal DVT. Yes, correct. 1 point. Next question. Which of the following cancers has the highest association of VTE? Breast cancer, pancreatic cancer, prostate cancer, or thyroid cancer? Highest association of VTE. Okay, wrong. It's pancreatic cancer. Okay. Roscius sign. I know. Okay. Next we go to DVT, pure DVT. So team RBC, a 45-year-old male presents with unilateral leg swelling, pain and tenderness. The Wells score is 4. What is the most appropriate initial investigation? Is it A, CT venography, B, compression ultrasound, C, D-dimer assay, or D, contrast enhanced MRI? Unilateral leg swelling, pain and tenderness. Wells score is 4. And what is the most appropriate initial investigation? CT veno, USG, D-dimer, contrast enhanced MRI.
USG.
Yes, correct. 1 point. A patient with Wells score of 1 undergoes a D-dimer test which is elevated. What should be the next step? Option A is repeat D-dimer in 48 hours. Option B is start empirical anticoagulation. Option C is perform a compression ultrasound. Option D, CT pulmonary angio. Wells score of 1 undergoing a D-dimer test which is elevated. I think we are in a time constraint here.
Repeat after 48 hours.
No, it's perform a compression ultrasound. Okay, so team WBC, a patient is diagnosed with a first episode of unprovoked DVT. What additional investigation is indicated? Is it A, a factor V laden mutation testing? Is it B, cancer screening for age appropriate? Is it C, echocardiography? Or is it D, an abdominal ultrasound? This is a first episode of unprovoked DVT. Do you do genetic testing, cancer screening, echo, or abdominal ultrasound? What is the most likely, meaning what is the first thing you will do for such a patient unprovoked?
Just asking that like age-wise, because it differs.
So cancer, echo, abdominal ultrasound. Cancer is age appropriate, or genetic testing. What do you want? Just, I'll tell you the options again. Genetic testing for factor V laden mutation. Do a cancer screening for age appropriate, that is different ages, different types. Is it echocardiography or is it an abdominal ultrasound?
And is this the initial?
This is an unprovoked DVT. There is no provoking factor. There is no secondary DVT, it's a primary DVT.
Factor V?
Wrong. No, it's cancer screening. In patients with suspected DVT, what is the role of a D-dimer test? Is it A, diagnosis DVT? Is it B, differentiates acute from chronic DVT? Is it C, excludes DVT in low probability cases, or is it D, prevents the recurrence? What is the role of a D dimer in a suspected DVT? Diagnosing DVT, differentiating acute from chronic, excluding DVT in low probability cases, or predicting recurrence? C. Yes, correct. 1 point. Team platelet. A 50-year-old woman with APLA develops a DVT while on warfarin. What is the next step in management? Is it A, increase the warfarin dose? Is it B, add aspirin? Is it C, switch to LMWH? Or is it D, start an oral anticoagulant, direct oral anticoagulant? Patient is already on warfarin for APLA. Do you increase the warfarin dose? Do you add aspirin? Do you switch to LMWH? Or do you start a DOAC? I think we'll require tea after this.
Sir, increase the warfarin dose.
The answer is switch to LMWH. What is the initial treatment of choice for an acute proximal DVT in a hemodynamically stable patient? Is it unfractionated heparin infusion? Is it aspirin? Is it DOAC, newer oral anticoagulant? Or is it catheter-directed thrombolysis? Initial treatment choice for acute proximal DVT in a hemodynamically stable patient. Is it unfractionated, aspirin, DOAC, or CDT?
Sir, option A. AA, heparin infusion.
Okay, I'll give it to you. 1 point. Team plasma. So, in a stable patient, normally we can start DOACs with the recent protocols. You can start rivaroxaban. But unfractionated is not wrong as well. Okay, team plasma. 2 questions for you. A patient presents with extensive DVT involving the iliac vein and signs of limb ischemia. What is the best management? Okay.
IVC filter and
Compression stockings, CDT, aspirin therapy, or conservative management? Extensive DVT involving iliac vein and signs of limb ischemia. So this is basically venous congestion. What is the best management? Compression stocking, CDT, aspirin, or conservative management?
CDT.
Catheter-directed thrombolysis.
CDT.
Yes,
With
correct.
IVC filter.
1 point. What condition predisposes patients to upper extremity DVT? Is it prolonged immobility? Is it CV catheter placement? Is it obesity? Is it factor V Leiden mutation?
Second.
Second one, the central venous catheter. Correct. 1 point. Okay. Time up. Okay. We'll do rapid fire. Acha, we'll do a rapid fire quickly. Rahul is doing a rapid fire currently. Okay, so I think, okay, we'll start with this. Team RBC, what artery is the most commonly affected? This is a rapid fire. What artery is the most commonly affected in ischemic stroke?
CA.
Yes, correct. 1 point. Which scale is used to predict early mortality and morbidity intracerebral hemorrhage? Which scale is for predicting early mortality and morbidity in ICH? There's a score.
NIHSS.
Wrong. Team WBC. What is the target blood pressure in administrating thrombolysis in ischemic stroke? Correct. What is the gold standard technique for identifying cerebral venous thrombosis? Gold standard. Okay, wrong. MRV. Gold standard. Venous. Okay, next. Team platelet. What is the most common location of atherosclerotic plaques causing stroke? Team platelet. What is the most common location of atherosclerotic plaques causing stroke? Carotid bifurcation. Okay, correct. 1 point. What is the primary mechanism of clot formation and cardioembolic stroke? Yes, correct. 1 point. Team Plasma, what clot retrieval device is commonly used in endovascular thrombectomy? What clot retrieval device is commonly used in endovascular thrombectomy? Okay. Answer is stent retriever. What is the most common hypercoagulable state associated with cryptogenic stroke? What is the most common hypercoagulable state? It's antiphospholipid APLA. Okay. I think we end the quiz. Thanks a lot for the participants. It was a nice round. It's time to, I think, add up and summarize. Ankita? Yeah. I would request Dr. Susan Sauder and Dr. Sanjeev Khanna to come up on the stage for the prize distribution. And Dalal sir, please. I would request Dr. Susan to give us the vote of thanks first, after which we announce everything.
Yeah. This has been an academic fiesta like no other, and I think we all need to put our hands together for the one and only